the lobby. This has several things you can see. Let me take you through all the buttons there are there down there. So this is the help desk wherein you can log in, and you can click here and you can see several product about us products, the whole portfolio of Mindray. Then this is the auditorium where you can attend the CME. You will be able to see all the sessions in this auditorium. This is the photo booth in case you want to click a selfie with the Cube and BLK Max Mindray logos. You can just click your own photo over there. Here it is. You will find the stalls in the exhibition booth hall. So when you click on each of the booths, it takes you to the detailed product portfolio. As you are moving offline, you can just go into the booths online. So you will find all the product portfolios, the information on all the products. You can get in touch with our executive. You can also go in for a meeting with our executive. So we have stalls for hematology, we have stalls for biochemistry, CLIA, and other Mindray portfolios like patient monitoring, ultrasound, surgical units. So Mindray is not only in IVD, but also in patient monitoring, ultrasound, and surgical units. And this is how we are the best for serving the healthcare sector. Here you will find feedback form. So you can put in your feedbacks so that we stand a chance to improve ourselves. Here you can find the certificate. You can download the certificate post you finish the conference. It's like I think today evening you will be able to download it. So this is the social lounge wherein you can find.
If you use hashtag CubeAspire 2021, it will automatically come on this wall. So please do share your thoughts on social media also. And if you type this hashtag CubeAspire 2021, it will automatically come on this platform. Thank you.
Thank you, Nikhil. This is the leaderboard. So this is the leaderboard. You have, if you go into our in all these buttons, you visit the stalls, you will get some certain points. So the point information is given here. If you attend a full session, you have 100 points. If you visit the booth, you have 100 points. If you download or any resource from resource center, you have 500 points. If you watch any product video, you have 500 points. And if you take the feedback survey, you get 100 points. So in this way, if you you have to gain points, so you stand a chance to win some exciting prize. The first 3 winners will be announced and they will get an exciting prize. So this is all with the platform. You can go visit the whole platform. It's like the offline event. It's very exciting. One more exciting thing is we have a quiz at 12:30. So all of you have to be online. There are exciting prizes for the quiz winners also. So you have to take part in the quiz and attend the quiz also. So thank you. And now I move ahead with our main program for today. With the grand success of yesterday, we commence this day again with enthusiasm, and I take the opportunity to introduce our chairperson, who will be introducing our speakers for the day, for the session 1. So I take honor to introduce Dr. D.K. Mishra. Okay, so I take honor to introduce Dr. D.K. Mishra. He is the Senior Consultant, Lab Hematology and Molecular Genetics, and Director, Department of Laboratory Sciences, Data Medical Center, Kolkata. Dr. D.K. Mishra chairs the ICMR Task Force Subcommittee on MDS and is a convener of the Indian MDS Registry. He is a member of the Science and Education Committee of International Society of Hematology. He has his main areas of interest are like myelodysplastic syndromes, minimal residual disease in leukemias, and stem cell research. So I invite Dr. D.K. Mishra to introduce the first speaker of the day.
Very good morning, Sama, for that humble introduction. And I thank
you,
the
sir.
Mindray to have been putting this Cube Aspire meetings year after year. And it's a very successful meeting where the nuances of blood cell counting and its various facets are discussed every time. And considering the pandemic situation, the conduct of this meeting virtually has been a phenomenal success. Yesterday, though I couldn't be present much, but whatever glimpses I got it was extremely good. And I'm sure today's deliberations also are going to be very, very scientific, and it will benefit a lot of our audience. To begin the day's proceedings, we have a very eminent speaker, Professor Thalassemia from St. John's Medical College, who is a personal friend of mine. I know her for last almost 3 decades. She, in fact, needs no introduction, and she is well known in the circle of hematology, laboratory hematology, and hematopathology. She heads the Department of Laboratory Services in St. John's, as well as the Department of Transfusion Medicine and Immunohematology. I have been closely associated with her in the development of molecular diagnostic services in her center. And today, and as you know, that she has been awarded a PhD from the Rajiv Gandhi University of Health Sciences, Bangalore, of which I am also one of the MD examiners in pathology and DCP in pathology, for her work in coagulopathy in malignant solid tumors. So that is what links me to this particular topic, because I work mostly in tumors, be it liquid or solid. She is also a recipient of the Dr. M.R. Parthasarathi and Dr. A.V. Ramprasad Silver Plaque Oration Award from the Jawaharlal Nehru Medical College in Belgaum. Has more than 60 publications in index journals and has authored 3 chapters in various books. Her special interests are in the field of hematology and transfusion medicine, molecular diagnostics, and blood coagulation. So today, she is going to speak on the utility of cell counters in the diagnosis of MDS. That's the subject which is very dear to me. And now hand it over to Dr. Thalassemia to start her deliberations.
Very warm good morning to all of you. First of all, my thanks to Team Mindray, VLK Kapoor, and Dr. Handu particularly for having me a part of this program. Thanks to Dr. D.K. Mishra sir for such a nice introduction. It's been really nice to work with him, to get his inputs, to get his guidance, to set up a molecular diagnostics at St. John's. And sir has been managing, in fact, responsible for the MDS registry. So I feel very privileged to present this, to discuss the topic of MDS with him as a chairperson. I remember my first paper as a postgraduate was on 5 cases of MDS at a forum here itself in Bangalore. So MDS is a field which has where the knowledge has evolved with the incorporation of molecular genetics and other things into the diagnosis of MDS. And we all know that it's very, very complex, and it's difficult to pick up MDS at a very early stage. And there are diagnostic tools, but how good they are and how we can use cell counters to pick up an early case of MDS is the focus of this discussion. So what I will be doing is, I will start with a brief introduction to the topic. I will probably share some of the publications on the role of cell counters in the diagnosis of MDS. So let me, at the beginning itself, I would like to seek the permission of the chairperson as well as the organizers that normally in our presentations, we don't talk about the names of instruments or companies. But here, this is the first time I'm doing it for the simple reason that I just want to highlight the role of different types of equipments in the diagnosis of MDS. That's the only point, sir. So I hope, is that okay? So we'll just begin with what is MDS. We all understand that MDS is a group of clonal hematopoietic stem cell disorder. The primary feature in the peripheral blood picture is cytopenia, single or multiple cytopenias with morphological evidences of dysplasia. And we are concerned about picking up MDS at an early stage because of the risk of transforming into an acute myeloblastic leukemia. So cytogenetics and molecular diagnosis plays a very important role in the diagnosis of MDS, although we all do agree that morphology is the mainstay of diagnosis. So the first suspect of the presence of dysplasia usually has to be in a general, very ordinary laboratory which does routine CBC. And that's where we need to pick up these cases and which can evaluate. Very often we get hundreds of patients with leukemias, with anemia, or patients can have an isolated thrombocytopenia or leukopenia for investigation. So how do I pick up out of those 100 cases, this one patient could be MDS is the diagnostic challenge, and therefore it becomes very important to have a very good diagnostic tool. Although I did mention that microscopic observation is the gold standard, and that too by an experienced hematopathologist to pick up early evidences of dysplasia. And we all know that this is dependent on subjectivity with a lot of inter-observer variation in the interpretation. It's also very vital to rely on a standardized peripheral blood smear with a good staining for correct interpretation. So the diagnostic hallmark being dysplasia. Dysplasia can be in the red cell series, the white cell series. Particularly, there are several features of dysplasia in the granulocytic series, where you see abnormalities of the nucleus of the white blood cells in the form of hypolobulation, clumping, ringed nuclei, nuclear appendages, hypersegmentation, pseudo-Spelger-Hue anomaly, that is a hypolobular neutrophils, and so on. Besides abnormalities of nucleus, we do see abnormalities of cytoplasm in the form of hypo or hypergranulation, pseudo-Shediac-Higashi-like granules, Dole bodies. Sometimes we may see micromegakaryocytes, rarely in the circulation, but more often in the bone marrow. And of course, in the bone marrow with Meduan iron stain, ring sideroblasts become a characteristic feature. So if we look at the components of MDS in the current WHO classification, dysplasia is an important feature. And we all know that in each type of MDS with single lineage dysplasia, multi-lineage dysplasia, MDS-RS with single or multi-lineage dysplasia. So the focus is on the presence of dysplasia. And we know that besides, there are criteria for cytopenias, blast percentage, and so on. I'm not going into the details of WHO classification, but I just want to highlight the salient features which will help us pick up an early case of MDS. And one such feature is the peripheral blood anisocytosis as reflected in the smear in this picture. When we look at the bone marrow, of course, this erythropoiesis is an important feature. Megaloblastoid change is another very important feature. Features of dysmyelopoiesis, as I enumerated: hypogranulation, hyposegmentation, nuclear cytoplasmic asynchrony, Dole body-like inclusions in the peripheral blood all contribute to dysmyelopoiesis. Hypogranulation, as you evidenced in these pictures here, hypolobation, pseudopelga-hue-like anomaly. And this megakaryocytopoiesis can be evidenced in the presence of giant agranular platelets in the circulation, mononuclear megakaryocytes, micromegakaryocytes in the bone marrow. So that is what is shown in this picture here. Presence of blasts, of course, becomes very leading, and then diagnosis is not difficult. So once a stage of MDS evolves into refractory anemia with excess blasts, it becomes easier to pick up, and that's not the intention. Our intention is to make a diagnosis at a very early stage. So when I have all these tools, a very good bone marrow biopsy, iron stain, bone marrow aspirate, and the disease is already evolved, diagnosis becomes relatively simple and straightforward. And we all also know that assessment of dysplasia itself is challenging. I did highlight the inter-observer variation. We also know about reactive causes of cytopenias and dysplasia. There are several other confounding factors which can make interpretation of dysplasia difficult and challenging. Therefore, the diagnosis of MDS requires a high clinical index of suspicion to prompt further investigations. There are inherent limitations of manual cellular analysis, the small number of cells that we count routinely, subjectivity associated with morphological examination, morphological interpretation, which is highly dependent on the quality of the staining, all contribute to the diagnostic challenges. And we also know that although molecular genetics, karyotyping play an important role, they could be normal in a proportion of cases. So do we have a robust diagnostic tool? So with this brief introduction, we do understand that there is a need for more robust diagnostic tools, whereas morphological features are there. And when it becomes obvious, by the time MDS is already evolved, and therefore it's important that we screen peripheral blood smears for picking up those hidden evidences of MDS. And that is where the role of research parameters in cell counters will probably contribute. We know that research parameters have been extensively studied to detect various types of leukemias, to detect infectious diseases like malaria, sepsis, viral infections. So these are, there are enough and more literature available. But what about its role in the diagnosis of MDS, where it can contribute to picking up even before subtle morphological changes become evident on the peripheral smear? So we have several cell counters in the market. We speak about the Coulter series, the Sysmex XN series, the Celldyne, Advia, Mindray, Pentra, and so on. So how are these equipments going to help us pick up evidences of dysplasia? Because as I mentioned, the detection of dysgranulopoiesis could be an important first step to diagnose MDS in a routine laboratory. So in the next few minutes, I'm going to share some publications. So what does literature say on the role of cell counters in MDS? So one such is the utility of Sysmex XE 2100 analyzer, where they talk about neutrophil NUT-X and NUT-Y parameters to detect neutrophil dysplasia in MDS. And this has been published in the International Journal of Laboratory Hematology about a decade ago. So NUT-X and NUT-Y parameters are there as research parameters in the hemogram. NUT-X is a mean value of side scatter, which analyzes the inner complexity of the neutrophils. And NUT-Y is the mean value of fluorescence intensity, which reveals cellular nucleic acid or protein content of neutrophils. We all know that hypogranulation is depicted in terms of NUT-X, and the NUT-Y is the dysfunction of neutrophils, that is a side scatter. So these are key features of MDS, and they can help us in detecting dysplasia. So this is one such hemogram that is presented on the cell counter, where we look at the NUT-X and NUT-Y parameter. The side scatter is low, the fluorescence is low, therefore the NUT-X and NUT-Y values are decreased, and the peripheral blood shows hypogranular neutrophils. So these authors studied 6 groups of patients. One group was the normal volunteer group, another group of anemia, another group where patients had isolated neutropenia. They looked at another group in comparison, that is patients who are immediate postpartum, where you expect a neutrophilic leukocytosis. They involved another group which included patients with infection or patients on GCSF therapy, and the last category was the MDS group. So if you look at this table, I draw your attention to the last column, and if you look at the NUT-X and NUT-Y parameter values, the last column depicts MDS, and these values are significantly decreased in comparison when you look at the other groups of the control, patients with anemia, patients with leukocytosis, postpartum, etc. This particular group of MDS has decreased in NUT-X and NUT-Y values. So the mean NUT-X and NUT-Y values in this group of patients were looked at, and the means were significantly lower and statistically significant. Now they looked at this data more closely. This group had included almost all the groups, the RAEB, CMML, refractory anemia with ring sideroblasts, 5q deletion, and so on. Importantly, they did not find any significant difference between the various groups of MDS, although MDS as a distinct entity, the values were significantly different from the non-MDS groups. So there is a good correlation between microscopic assessment of neutrophilic granulation in the MDS group and NUT-X and NUT-Y values, and that's what the authors had to say. So we all know that the prevalence of MDS in general population is not very high. Therefore, this criteria would not have been very useful to screen as a positive predictive value. But however, low NUT-X and NUT-Y could be considered to be a morphological review criterion together with isolated or multiple cytopenias in the hemogram, which will add value to the diagnosis, and therefore creating a cutoff point with high specificity will play a role in picking up MDS. Otherwise, we will have to unnecessarily screen a large number of peripheral smears. Now, as an extension of the study, the XN3000 cell counters that are available in today's market also depict similarly NUT-X and NUT-Y values, which constitute the cell population data. And in MDS, the dysplastic neutrophils show reduced side scatter due to hypogranularity and side fluorescence representing dysfunction. So this is one such hemogram where it is evident that the NUT-X, the side scatter and side fluorescence values are decreased in the terms of NUT-X and NUT-Y values. And this is also published in the Indian Journal of Hematology and Blood Transfusion, but one of our colleagues. So a notable, we move on to the next paper where we look at the utility of cell counter in the evaluation of MDS. This is published in the British Journal of Hematology. Again, they talk about a parameter called NEWX, which is similar, which depicts neutrophil complexity and the width of dispersion. And these authors have looked at evolving an MDS screening score. So a low hemoglobin, platelet, and absolute neutrophil count with MCV and NEWX, where NEWX was a parameter which was increased along with a high MCV. So they evolved a score, and they identified that these parameters in a multivariate analysis helped to pick up cases of MDS with cytopenia in comparison with cytopenia not related to MDS. And therefore, they identified this parameter as a key parameter in the screening of MDS group. So this depicts the sensitivity and specificity of MDS group in comparison with the control group they looked at two cohorts, a leading cohort and a validation cohort, and they identified the role of MDS CBC score with a sensitivity of 86% and a specificity of 88% in conjunction with other parameters like MCV, ANC, and so on. So an MDS score over 2, they concluded that a score over 2 should generate a flag on the cell counter to prompt the examination of peripheral blood smear to evaluate further. So this has been shown to be of interest in the clinical context. So one should look at interpretation of all these scores and parameters always in the clinical setting to make the right diagnosis. So the next paper is the role of the cell counter parameters on the Beckmann-Coulter series. And this is a publication from CMC Vellore, where we all know that cell counter, the Beckmann-Coulter functions on the technology used is the VCS technology. And they have looked at the leukocyte cell population data, which represent the positional parameters. And they have studied the role of these positional parameters. And they have identified that the mean cell scatter, distribution of cell volume are decreased. The mean cell scatter is decreased, whereas the distribution of cell volume, the cell conductivity, and the cell scatter is increased. And they have found them to be highly statistically significant in a series of patients with MDS. And like in the previous study, they've also looked at the sensitivity and specificity, and they're all in the specificity is as high as 86 to 90% if we look at these parameters together. So the authors conclude that the use of white cell positional parameters computed by these cell counters can flag an abnormal neutrophil flag, which can be a useful tool to detect MDS when the morphological changes are very subtle and are not conspicuous to be detected on a peripheral smear examination. There's one other paper which is published in Cancers, where these authors have looked at several research parameters on the Beckmann-Coulter, and they have evolved an MDS likelihood score. This again to allow an early detection of subclinical cases, which will be a trigger to a review of morphology, and they have developed an algorithm to pick up these cases. So they looked at several research parameters, and they compared MDS with a group with age-matched healthy volunteer group, and they also looked at, in addition to the neutrophil parameters, they incorporated the platelet distribution width as well as the red cell distribution width, which have a role to contributing to the diagnosis of MDS. And these results highlight the abnormal diffraction of neutrophil, and leukocyte parameters emerged as an important role in evolving this MDS likelihood score calculation. So they also they looked at 5 different angles of laser scatter, which reflect the granularity, cell membrane composition, the cellular complexity, and transparency. And they looked at these angles in conjunction with the CPD parameters and the other research parameters like low hemoglobin density, the platelet distribution with early granulated cells, and so on, to evolve a score towards the diagnosis of MDS. Now, I'll just draw your attention to another paper which describes the possibility of MDS screening using using CBC, and this was published in Leukemia Research. And they have done the study on ADVIA 2120, where the abnormal signals that are developed on the cell counters could indicate a flag, that is a dysplasia flag. And they looked at the role of this flag in several subgroups. So they had 5 groups to compare. One is an MDS group, the other is the MDS MPN group, another group of non-hematological malignancies, solid tumors on chemotherapy, and a set of routine patients which do not belong to any of these categories. They also evaluated the sensitivity and the specificity of this flag on the ADVIA 2120. So I won't go into the basics of technology, but they also evolved parameters, research parameters, that's a NUTX and NUTY, and this is how the hemogram looks at. So here, if you look at the depiction in B, where it picks up the macrocytes in comparison with normal RBCs, it picks up where in the last scatter plot, you look at the D scatter plot, which picks up the pseudo-Pelger-Hue cells and the blast cells. So they also looked, I said, in conjunction with the red cell parameters, the red cell distribution width, and the reticulocyte parameters. So an analysis of MDS patients on this cell counter showed that in addition to numerical parameters, the dysplastic flag can contribute to the early detection of MDS. So they classified the patterns into 5 different patterns. Pattern 1, which is based on morphological abnormalities of the granulocytes, the peroxidase content of these cells which are decreased. Pattern 2, the neutrophil defect in dimension. Pattern 3, based on the defect in dimension of neutrophils and the presence of RBC and retic parameters. Pattern 4, based on the presence of monocytosis, neutrophil peroxidase content and thrombocytopenia. Pattern 5 is based on presence of 2 populations, the red cells and retic, one macrocytic and the other in the microcytic group. So using these different patterns, they evolved the flagging of a dysplastic cell depending on the positional indices and the abnormal scatter. The pattern 1 and 2 showed sensitivity of MDS with pseudo-Pelger-Hue neutrophil. Hypogranulation. Pattern 3 shows sensitivity with an apparent dimensional defect of neutrophil, and where there is, and they also incorporated the retic hypochromia as a feature. Pattern 4 is sensitive to MDS with monocytosis and thrombocytopenia. Pattern 5 is sensitive to MDS associated with ring sideroblast, abnormal RBC and retic parameters. So this pilot study demonstrated that the flag dysplasia is very sensitive as well as specific. And they also showed the false positivity rate to be very low in comparison with other flags. Now we move on to the role of Pentra-MS, where abnormal neutrophil cytogram helped in picking up patients with MDS. So in this study, they found that there was a discrepancy every time the samples which had dysplastic features in WBCs were evolved. And we all know that Pentra analyzer, the technology used is double hydrodynamic sequential system technology. It incorporates cytochemistry in addition to flow impedance and light absorbance principles. So they looked at, again, different types of neutrophils, and they actually did an SBB staining to detect the degree of hypogranulation or hypergranulation, and they classified into 4 different groups. And they evolved a parameter on the cell counter, which is the median light absorbance parameter, and they compared it with the SBB score on staining of the peripheral blood. And they found a very good correlation between the median MLA score and the SBB score. And this is what helped this authors to pick up early cases of MDS. And that was one such study on the Pentra. So this is another study, probably the last study that I'm going to be discussing now, the relationship between red cell distribution width and prognostic scores in MDS patients. So these authors performed the study on the Mindray BC equipment, and we all know that the red cell distribution width is very useful to depict the degree of anisocytosis, and high values have been linked to adverse outcomes and poor prognosis in patients with several category of disease entities, particularly in the diagnosis of MDS. These authors have studied the role of this parameter. So they have compared RDW values with different MDS scoring systems. And I would like to draw your attention to this table where they've looked at, you see that the RDW values are significantly different between in each of these scoring systems between the low score and the intermediate or the high score, and they are found to be highly statistically significant. So therefore, the authors conclude that RDW can be an indicator of poor prognosis in these various scoring systems, and therefore can be used as a supportive marker for MDS diagnosis. And another group of authors have postulated that RDW has an independent predictive value in the diagnosis of MDS in patients with unexplained cytopenias. And they have said that it can be contribute to a novel scoring system for MDS patients. And therefore, it is a poor, it can have a high meaning in patients with MDS. It's also been proven that patients with high RDW in patients who have bone marrow blast, MDS group of patients with bone marrow blast less than 5% can carry a high risk of transformation to AML, and therefore a poor prognostic indicator. So the key message that I want to convey in this presentation is that yes, we know MDS is very challenging to diagnose. The prevalence in the general population is low. Therefore, one has to have a high index of clinical suspicion. We know morphology is very important in diagnosis, but it has its limitations. Bone marrow diagnosis, complemented by genetics and molecular testing, play a very crucial role. But the question is, do we have further robust tools? What is the role of cell counters? And that's what I've tried to address in this presentation. So we realize that red cell parameters, the RDW, the WBC parameters, which depict the cell granularity, the site scatter, the fluorescence, could they all be used? The cell population data, could they be used? I couldn't speak much on platelet parameters because of time limitation. Yes, they all have an important role. However, the studies on temporal stability of these parameters, inter-analyzer variations, non-neoplastic mimics, establishment of age-specific reference ranges are all necessary to standardize these parameters for routine clinical application. So with this, I would like to conclude this presentation, and thank you very much for your patient listening, and thanks for this opportunity. Thank you.
Thank you, Dr. Sita Lakshmi. Dr. Mishra, over to you for some questions.
Thank you very much, Dr. Sita Lakshmi, for that nice presentation, and you illustrated with published literature. And should we have the questions now, or should we at the end of this particular session? So there is one question in the chat box. If I could just read out that Dr. Manjusa Chumre has asked, ma'am, sometime on peripheral smears of MDS, we get less than 5% of dyspoetic granulocytes. So how sensitive the research parameters, Nutex and Nutri, will be in detecting such a low percentage?
Yeah, I'll just make an attempt to answer this question. Yes, as we highlighted in the presentation, the diagnosis of MDS is challenging because there's not that this a single parameter which will say, oh, this is MDS. So it's in the context. One is in the clinical context, and if we look at hemogram, we look at several parameters together. So there's no one single parameter which can be used as a single pointer. So you have to look at it in the context of other parameters, correlating them together. The more number of parameters that is adding value to the diagnosis, yes, we have a stronger indicator to say to that this is possibly MDS. So you should not probably depend on just one parameter, either maybe Nutex or Nutri or RDW. We have to look at it in toto to arrive at a meaningful diagnosis is the way I would look at it. I'm sure sir will add more to what I want to say. Sir, please.
So just a small brief comment. You know, the diagnosis of MDS, the morphological diagnosis on the bone marrow aspirate smears. And there are many complementary other techniques which can complement to this diagnosis. As the WHO has said that you should have at least 10% of the erythroids and myeloids which should show dyspoetic changes in the aspirate. and at least 30 megakaryocytes, you must see whether there should be this megakaryocyte on an MGG strain. So it is very defined. And ICMR had just published last year in National Consensus Guideline on the diagnosis and management of MDS, of which I was the chair of the MDS committee. We have already published it. It is in the ICMR website. The other thing is that whatever Madam has said, it is a very important tool that these will be early predictors of, say you have cytopenia, whether it is MDS or non-MDS related. So these are the research population data which can be utilized to your advantage to give a preemption that probably it could be myelodysplasia. So it's not an absolute diagnosis. It is an indicator that possibly there could be dysplastic changes, and dysplasia, even post-chemotherapy patients will have dysplastic changes in the peripheral blood. So dysplasia as it is not MDS. So dysplasia can be seen in many other conditions. Even infections can give rise to dysplastic changes. So what Madam had said, that from a hematology blood cell counter, you can get indications of dysplastic changes by using various algorithmic approaches from the various parameters, which can tell you that probably there is dysplastic changes. So that is all that I want to convey. And
Thank you, sir. Thank you.
I think one more question is there by Ashok Mayadis. Across the cell counters, parameters are different, creating confusion. Some sort of standardization is needed. Yes, Madam, if you could contribute to this.
Yeah. Yes, I think if you saw in my presentation, that was also a part of my last slide that I spoke about. But we should probably realize that all of them, all the cell counters, irrespective of variation in technologies that are being adapted in each cell counter, there are certain things which are common, which are uniform, which can be applied. Yes, standardizing them across analyzers will definitely contribute to standardization of our interpretation. And that is something that we as hematopathologists could make that effort in order to make our diagnosis, make our interpretations more meaningful. So you're very right in saying this. There needs to be some form of standardization across analyzers, which will definitely add value. Yes, sir. Thank you so much for that comment.
Yes. So here I would like to say that all the platforms are different. They use different principles. They use different technology. So, and these are all RPD, research parameter data. So when you are using research parameter data, they are not IVD approved. So you are just studying them based on the research population data. So standardization for a particular purpose may be difficult. Until unless in a particular platform you are trying to study that particular entity and create your own way of assessing the research population data, whether they are dysplasia or no dysplasia, but across the platform it is difficult to standardize. Otherwise, this itself will be a IVD parameter for diagnosis of dysplasia. RDW is there in every platform. So if you consider only RDW, possibly there may be some standardization. So similarly, if you have new text and new TOI is not there in other platforms. So standardization across platforms at the current moment may not be very feasible, but it is yes. It is a good question, and I think we should attempt it as time goes by. Thank you.
Thank you, Dr. Mishra and Dr. Sita Lakshmi for such a good explanation. Now I request Dr. Mishra to introduce our next speaker.
Yes, thank you, Dr. Sita Lakshmi, for that. I really enjoyed your presentation, and the data was excellent. Thank you very much.
And I request the audience, if they have any questions, they can type in the chat box so that Dr. Sita Lakshmi
they can
answer.
put in the chat box as well as in the question answer box. So both ways they can.
Yes, yes.
Thank you. Thank you very much, sir. Thank you.
So the next speaker is none other than Dr. Tina Daru. She is the queen of hematology of India. I have seen her from the days when she was a senior resident in Gangaram Hospital. So from senior resident to junior consultant to associate consultant to senior consultant to principal consultant. She has climbed this ladder in a very meteoric manner, and I'm sure her next designation will be chief consultant, and after that possibly BL Kapoor has to decide what designation they would like to give it to her. Dr. Tina Dadu, her previous assignments, I've already said where from she was. She started her career at Sir Gangaram, then moved to Hinduja Hospital for a while, came back to Delhi, joined BL Kapoor, and she has been awarded with the AS Fellowship in Flow Cytometry and worked at the University of Florida at Gainesville in Florida. Her interest has been neoplastic hematopathology, and she is an enable assessor and a wonderful person to talk to. And I have known her personally, and she is a brilliant, dynamic, young hematologist who is going to be the leader of hematology one day in this country. And with that brief introduction, I request Dr. Tina to start her talk. Tina, please.
Hi, good afternoon, everyone. I am Dr. Tina Dadu, and I head the Department of Hematology at BLK Max Super Speciality Hospital. Today, I'll be talking about the hematological parameters in dengue. So, the first question I'm sure that you would want to ask me is that why dengue? Everybody is talking about COVID all the time. There's COVID all around. So, why dengue? So, I just thought that, dengue has given a lot of importance to the hematologist, unlike COVID probably, and it is a low platelet count in dengue that actually makes us what we are. So I thought that I should keep my loyalty toward dengue, and since everybody has spoken about COVID, so I'll continue with dengue. Now in dengue, actually it is a low platelet count, which is of major concern and which causes a lot of panic in the minds of the patient. And we have been really working hard on to predicting the platelet recovery. So in the past, actually, we have discussed a lot about the immature platelet fraction, formerly known as the IPF factor, and also about the HFC, which is the high fluorescent cells. So today's basically agenda is to sort of give a small recap of the IPF and HFC, and also to correlate the two parameters and how do they help in the recovery of platelets, and do they have a correlation or not. And other than this, we also thought that we should have a look at the other hematology parameters, basically the platelet parameters, which might help in the recovery of, which might help in predicting the recovery of the platelets. And these include the mean platelet volume, the PDW, the plateletoprit, the platelet large cell count, and the platelet large cell ratio. So we'll go through all these parameters one by one, and we will see if any of these parameters also help us in predicting the recovery of the platelets or they don't. So let's begin with the first factor, just a small recap of IPF, which is the immature platelet fraction, which is the index of thrombopoiesis. So in dengue, the platelet counts go down, and the primary reason for that is platelet destruction and also suppression of the megakaryocytes which produce the platelets. Now, once this factor is removed, or this offending factor is removed, the platelets begin to recover. So the first indicator of the recovery is indicated by the immature platelet fraction, as this component can be analyzed in the peripheral blood. So we see that there is an increase in the IPF, and we know that the platelets will start recovering. This is a plot which shows the x-axis shows the number of days, the y-axis shows the platelets on the left-hand side and IPF on the right-hand side. So as we see on day one, the day one of admission, so the platelets were 89,000, they went down to 54,000, further dropped to 39,000, which was the lowest. After that, they started recovering on day 4, that is, they started increasing. Now, if we look at the IPF at the same time, on day 1 of admission of the patient, the IPF was 7.8. At this point, we don't understand, or we didn't know whether the IPF will go up again on the next day, it will remain the same, or it will go down. So the next day we see that there is the IPF has gone up to 11.2%. So there was an increase from 7.8 to 11.2, which clearly indicates there was an increasing trend of this IPF. So if on day 2 you know that your IPF is showing you an increasing trend, and then we correlate it to the day of recovery, which was day 4, where we saw that the platelets have started recovering, that means there there's a 2-day gap. So we analyzed all our dengue cases and we figured out that 0.7% of the cases show a recovery within 24 to 48 hours from the rising trend. So this was a beautiful parameter which indicates that increase in the IPF will help to reduce the panic in the minds of the patient, as they would know that within 48 hours their platelets will start recovering. But there is a problem with the IPF. It comes with an extra cost, and in a country like ours, where economics and the economical factors play a major role, it actually, if it can be replaced by something else, it's going to be always better. So IPF is not a part of CBC. So we looked at other parameters which actually may be surrogate for IPF, and therefore they might be helpful in predicting the platelet recovery. So we looked at other factors, and one of the factors which we have earlier discussed also is the HFC, which is a high fluorescence cells. Now this was the new kid on the block and trying to rock and roll, but then came COVID and all the limelight which this poor guy deserved, he did not get it. But anyways, we'll just take the focus back to him and see what it offers. So this is a scatter plot from the Mindray machine that we run the samples on. And we see that the x-axis is showing us the site scatter and the y-axis is showing us the fluorescence. We can clearly see the lymphoid population here, which is actually the smaller cells with a low fluorescence. And there is another population here, which is the high fluorescence lymphoid cells. And these actually high fluorescent lymphoid cells is the thing that we are now going to concentrate on, because this is the population of this activated lymphoid cells, which is the combination of the B and the T lymphoid cells. So we actually plotted a graph where on the x-axis shows the day of admission of the patient, and the y-axis is showing us the platelets, which is indicated in red here. So let us have a look. Day 1 of admission, the patient's platelet count was 1,30,000, dropped down to 50,000, then to 29, 15, and then 13. And day 5 was the day when it showed recovery. Sorry, this is the day 6. So day 6 is the day when the platelets had started recovering. From 30, they went to 30. Then after that, it just increased to 62, then to 79, and then 142, and kind of patient completely recovered. So this was the trend that happened with the platelets. Now, what happened to the HFCs? The HFC on day 1 of admission was 0.4% of the total lymphoid cells, increased to 0.5, 0.9, and then there was a sudden gain in the HFC, which went up to 4.1%. So there was a HFC jump, so that we call it. And then after that, it increased further, reached a peak of 13.5%, and after that, it gradually started dropping again. So if we see this day 3 of admission, from when the HFC increased to 4.1%, so this is the day 4, where we figured that there was an increase in the HFC, significant increase in the HFC. And if we compare this day to the day of platelet recovery, again, there's the gap of 2 days, that is 48 hours. So again, we went back to our data and we analyzed our entire data, and we realized that 23% of the patients recovered within 24 hours, and rest of the 65 within 48 hours, and rest of the patients within the next 72 hours. So 90% of the patients did show a recovery within 48 hours of the HFC jump, which was again very similar to what we saw in the IPF. So if I actually put the two graphs together, I clearly see here that this is the platelet versus the HFC graph, and this is the platelet versus the IPF graph. So we see here the platelets dropped, they reached a low point, and after which they started increasing. Similar thing happened here also. The next thing that we see here is HFC started rising. There was a sharp increase, after which it increased and had a peak, after which it started coming down. A similar thing happened in IPF as well, that it started going up, reached a peak, and started going down. So if you see both the pictures, they are very identical to each other, and thus we felt that HFC can be used as a surrogate marker for IPF, and thus we can predict the increase in the platelets in the dengue patients using HFC. In fact, we felt that HFC is even a better parameter than IPF, because it doesn't just help us in predicting the recovery of the platelets, but it also helps in the diagnosis of dengue. So we found that if the HFC percentage is more than 5% and the patient is having thrombocytopenia during times when dengue is prevalent, it is very diagnostic of dengue. We don't even have to get a dengue test done. And a lot of times we find that with all the 3 parameters, and if the patient is on day 5 or day 6, whereas NS1 is not positive, and his IgM have also not started coming up, the patient may be falsely negative by the antigen antibody test, but this is a strong sign that the patient has dengue. But at the same time, we just thought that we should also have a look at the other parameters, which are the MPV, the platelet to crit, PLCC, and platelet large cell ratio. Do these parameters, do they have any significance in predicting the recovery of platelets or not? So just let's go through them one by one. So platelet to crit is basically the volume which is occupied by the platelets in the blood. So it's very obvious when the platelets go down, the platelet to crit will also go down. So if you see, the blue line is actually the platelet count and the green line is the platelet to crit. So it's very obvious that they will parallel each other, and thus platelet to crit in no way is going to help in predicting the count of their platelets. So let's go to the next parameter, which is called the platelet large cell count. Now, platelet large cell count is basically the number of the platelets, the large component of the platelets, the larger size platelets. So in dengue, we expect that when the IPF starts increasing, as the IPFs are larger in size, we expect that the large cell count will also increase. But remember one thing, that this is what we're talking about is the platelet large cell count. So it is the absolute count that we're talking about. So this absolute count also parallels the platelet count, as a result of which this is also not helpful in predicting the platelet recovery. So then we thought that probably PLCR, which is also called as a platelet large cell ratio, might be something which would be of some use. So the platelet large cell ratio is actually the percentage of the larger platelets which are present in the blood. So basically the large platelets divided by the platelets is what we get. So the platelet large cell ratio is the one that we are trying to figure out that might be helpful to us in predicting the recovery of the platelets. So when we saw the graph and we saw this and we got very excited, we saw that this is kind of exactly similar to what we are getting in HFC and in IPF. We see that the platelets are dropping, and at the same time we see that this PLCR, that is the platelet large cell ratio, has gone up, increasing trend, and this increase in the trend is again predicting the recovery of the platelets. And again after that there's an increase. So we got very excited. But unfortunately, we found this pattern only in 35% of the cases. That means the rest of the 65% of the cases were not really helpful. I really do not know the reason for this, because we expected that this should kind of mimic the IPF and it should be paralleling the IPF. So probably we have to do more studies and we have to do more number of cases to figure out what is the problem. But in the 35% of the cases where this pattern was maintained, 90% of these 35% cases showed a recovery within 48 hours. So again, very similar to IPF, but we just saw this pattern in 35% of the cases. The rest of the cases, you would ask me, how was the pattern? In the rest of the cases, we saw this zigzag pattern on the plots. Like the PSRE increased, then it decreased, then it increased, and it decreased. So it was not giving us a very robust pattern where we were sure of actually using this parameter as the predictor. So maybe this has to be made a little robust, I don't know, but maybe a lot more work needs to be done on this from our side. So we went to the next parameter, which was called the mean platelet volume, that is the MPV. So again, the mean platelet volume is the average volume of the platelets. So it is that, again, a very similar pattern that we saw in the PLCR or in fact the IPF. So again, we were very excited because the platelets were dropping and we saw that the MPV was increasing. This was expected also, because increase in the MPV is basically reflecting the increase in the IPF, because you have a larger platelet, you have increase in the IPF. So we saw the same thing here, increase in the MPV, and this was exactly very similar to what we got in the PLCR. But just the same way as in the PLCR, we found this only in 35% of the cases, and we did not, in the rest of the 65% of the cases was exactly similar. That is the zigzag pattern that we got on on the PLCC. So again, probably the larger platelets, which was showing the high MPV, were the ones which were being calculated as the higher PLCR, as a result of which both the patterns were very similar to each other. And in both MPV and the PLCR showed this pattern, and so most of the cases showed a good pattern in 35% of the cases, and the rest of the 65% cases showed this kind of a zigzag pattern, which we again don't understand because we expected it to mimic the IPF. So anyhow, data is data, and the negative correlations, the positive correlations actually don't eventually do matter actually, but still the negative also have the same value. So this was another plot which again showed us a very zigzag pattern, and we were very disappointed looking at this because the platelets clearly showed a beautiful fall, and then there was a rise, and there was a rise after that. But the MPV did not help in predicting the platelets. So I really don't know whether MPV and PLCR have that kind of a value in dengue or they don't, as HFC and IPF have. So if I have to conclude my presentation based on all these factors, I would say that MPV and PLCR definitely have some potential, and maybe a lot more work needs to be done on that to figure out what it is actually. But PLCC and platelet rate for sure are not useful in predicting the recovery of platelets, because they are actually paralleling the platelet count. So if I have to conclude the whole thing, like including our previous parameters of IPF and HCF, I would say HFC and IPF both are excellent markers in predicting the recovery of the platelets. But HFC is a parameter which also helps in diagnosing dengue in thrombocytopenic patients. Secondly, it helps to predict the recovery, just the same way as IPF does. Thirdly, and the most important actually, is you don't have to pay anything extra for getting this HFC count. So every time you're running a CBC on an analyzer which is using fluorescence-based differentials, you do not need anything extra, and just the same instrument is going to give you a very robust HFC value at no extra cost. And last but not the least, it is not impacted at all by the blood transfusions, whereas in patients in which you're going to run the IPF, the transfusions may actually suppress the IPF, but it does not impact the WBC component at all. The platelet transfusions are totally no impact on the WBC, so we can use HFC parameters in the patients who have been transfused also. So hands down, I must say that, of course, I don't have to mention, the winner is the high fluorescent cells, the HFC. So after comparing all the markers, which was the IPF and the HFC and all the new platelet parameters, we figured out that HFC is one of the best markers, the cheapest marker to predict the recovery of platelets in patients who have dengue. With this, I would like to now end my presentation, and would thank you all for a very patient hearing.
Dr. Mishra, would you like to ask some
Dr.
questions?
Tina, your wonderful presentation as usual. Your masterly talk. You are the numero of IPF, platelet, PLCR, and the HFC in India. Number of publications are to your name. And dengue being so common in the dengue season in Delhi, you have extensively worked on this field. So you are an authority on this particular subject, and you have spoken like an authority. And the session is open for discussion in case anybody has any questions.
So before we take up any questions, I would like to thank you for the overwhelming introduction that you gave about me. And it was, I don't know whether I actually deserved or I don't deserve it, but I actually literally was blushing when you were saying that. So really thank you.
I have been seeing you growing in the ladder from senior resident to chief consultant, and after that, what department you have, I'm not sure. But you are here to stay for long years in hematology, and
so that's very kind of you to say that. It's really lovely coming from you, a person who's so senior, and we have always been looking at you right from my junior residency days actually, and we've always looked at you and we felt that, oh my God, can we ever be like you? And we always follow you. So I'm really grateful to you for.
Don't embarrass me, Tina, more. Now the session is open in case anybody has any queries about platelets in dengue. So I have one comment before, and I want your opinion about it. You know,
Absolutely.
I am from Calcutta, the city of joy.
Yes.
You know, here you have something called constitutional macro thrombocytopenia.
Yes, sir.
The average MPV here is about 11.
Yes.
Okay? The platelet count is about 70, 80,000 on an average.
Absolutely.
So here, if you apply the same theory to what you have said, that the IPF goes up, this thing, because here as it is, the mean platelet volume ab initio so high. So to apply dengue concepts of cell counters here in Calcutta is a little difficult, because we have studied, many other people have studied, that the inherent RNA content of these platelets are also quite high. If you do a reticulated platelet count by using thiazole orange and do a flow cytometry of these platelets, you'll find that they will be overexpressed. So under that circumstances, what are your take on people like this who are ethnically different and have got a higher MPV, and obviously will have a higher HFC also in dengue? So how do you monitor them?
So as far as this question is concerned, it's very relevant, as you rightly pointed out, that in Calcutta and places like the East Indian places, where the platelet count itself is a little lower and the IPF is a little higher anyways. So first of all, I would say that we will have to have a IPF range, which is going to be different in that population. Irrespective of that, when we are actually following up dengue patients and the thrombocytopenia in dengue patients, we are looking at a pattern. More than the percentage, we're looking at an increase in the percentage. So if the IPF, say for example, in a patient is 15 on an average, we are not banking on whether it is more than 10 or it's less than 10. We are banking on the fact that from 15, it will probably go to 20 or 25. So there's going to be a significant increase. So that is what we are monitoring. So probably next time when there's dengue in Calcutta, which I hope that there's not, but still if it is, then we can actually follow up these patients and figure out what is their baseline and then how the IPF goes up.
Yes.
And secondly, the HFC will be a great parameter because that will not be impacted by the platelet count, by the absolute platelet count or the platelet low or the fall. The HFC is a very different parameter. So if, when we see an increase in the HFC, in fact, again in Calcutta, I think it might be a better predictor of recovery of platelets than the IPF. This is my take on it, but of course you can actually see when the next time dengue is there.
Okay, okay, thank you. Any more questions? I don't think any questions are there in the chat box nor in the QA box. So once again, I would like to thank Tina for her wonderful erudite, eloquent exposition of the subject. And thank you very much, Tina, for that.
Thank you very, very, very much. Lovely talking to you.
Thank you so much.
Thanks, sir.
So Mishra, may I request you to introduce the next speaker for the day, please?
Yes. And the next speaker is none other than Chakravarti Narasimhachar Srinivas. That's correct, Srinivas?
Yes, Dr. Deepak.
Yes.
So nice of you. Good morning.
People know him by the acronym CNS. Okay. And you'll be surprised that what multifaceted personality is Srinivas. He gave a talk on the role of Bhagavad Gita in laboratory medicine. I was surprised. And when I was going through his profile, because I was also doing my homework about him, I thought that I must introduce him in the correct perspective and the correct way. He is, I know him for the last almost 25 years now, and he has varied interest. And one of the interests that most excites me is his integration of laboratory medicine with Bhagavad Gita. And he has given a discourse on that. He has contributed chapters on this to various books. So my tribute to you, Srinivas, about that. So as you see that because of his varied interest, he is the founder and managing director of Prayoga Academy, Chennai. The former head of transplantation, immunology and molecular diagnostics, Neot Hospital, International Hospital in Chennai. Has 26 years of experience in laboratory medicine, pathology, transplantation, immunology, and molecular diagnostics. He's an ISO 15189 assessor, NABH Medilab assessor, and a CAP inspector. He's also a WHO certified GCLP stainer, good clinical laboratory practice. He is director of Center of Excellence in Phlebotomy and the LQMS course at NIOT. Published extensively in 40 national and 20 international papers and has been invited for talks, delivering more than 100 talks on various aspects. That includes the talk on Bhagavad Gita and laboratory medicine. I am a great admirer of Srinivas. Whenever I see him, he exudes a different kind of persona in him, and very popular speaker all over the country. He is completely grounded, and he is a phenomenal character in our field of pathology, hematology, and whatever you can say. In clinical pathology also, he is very active. He has conceptualized a social media group called Laboratory Newsletter with over 250 members, and I'm sure this 250 members will continue to grow. With that brief introduction, I'll now hand it over to Srinivas to take the further proceedings. Srinivas, please.
Thank you, sir. Just give me a moment. So I have to just make sure that I'll be on the screen to share my screen.
I think he's connecting. Before that, in case I have the privilege, there is one question in the chat box for Tina. If Tina could just unmute. Somebody has asked, how about platelet distribution width as a comprehensive marker? Tina,
So, yes, absolutely, sir. So actually, we looked at the platelet distribution width also, and like MPV and PLCR, we expected the platelet distribution width also to actually show us the same correlation as IPF, because when the IPF increases, again, the variation in the platelet distribution width, like the PDW also increases. But again, unfortunately, I haven't put the graph here, I'm sorry about that. But we again did not find an absolute correlation or an exact prediction of platelets in the PDFs, in the PDW.
Yes.
So again, something very similar to MPV and PLCR, but definitely probably.
Yes. So what, Tina, I would like to suggest and
Yes.
to you that since you are in a very high endemic zone of dengue, why not
Yes.
you develop an algorithmic approach on these multivariate parameters like
Yes.
MDW, sorry, the
Yes. PDW and the PLCR.
PLCR and HFC, and
Yes.
come to an algorithmic approach to predict as a predictive marker.
Absolutely. So that's a very good suggestion,
Yes.
and I will certainly work on it. And
instead of
yes,
just taking one parameter alone
at a
why
time.
don't you-
Yes. Yes.
Dr.
So I will
CN,
definitely try and probably will come up with it next.
because
Thank you.
considering the volume that you have, I think your center can do it.
Absolutely.
And I think
I
Anil and
agree.
you and
Yes.
Niseth, who is there with you now, can
Absolutely. So with their support, it is going to be absolutely a possibility, and we will try and develop
yes,
something.
exactly.
Dr. Mishra, Dr.
Yes,
CNS
now
is
yes,
waiting.
Srinivas is now ready. Yes.
Good morning. Sorry for that small delay. I'm actually indeed blessed because my guru and mentor, Dr. Deepak, was here as one of the chairperson. And I would also like to thank Dr. Anil Handu and the Mindray for giving this small opportunity to share about our beginning steps of our digital imaging, what we are trying to do in the laboratories right now. And during the COVID, this was a very good learning machine for us to make sure that we don't miss some of the minute details of the hematological parameters, that is the visualization of the cells itself. So my topic will span for about 20 to 25 minutes, and we'll be dealing with how the man, machine, and the morphology of the cells are important for digital imaging. The objectives of the talk are what are the steps which we are involved in the manual review of the peripheral smear and what are the bottlenecks, and what is the principle of the digital morphology and how we can use the digital morphometry and morphology for our day-to-day workup, and few case studies to make us understand that how it is more helpful when the eyes cannot see much and when there is a fatigue of the eye itself. So we all know that the blood smear study takes the center stage in the hematological workup, and it is the basic workup what we do. And it is the most important parameter to complement the flag review criteria or confirmation of some of the findings from the hematological analyzer, or it may be a requested order from the physician to make sure that a peripheral smear review is being done. So when we are doing a peripheral smear review itself, we have to understand that whether we have got any presence of RBC disorders or morphological abnormalities of the RBCs. Do we have any qualitative and quantitative disorders of the WBCs, or do we have any quantitative and morphological disorders of the platelets? So basically it revolves around the morphological study and the quantitative abnormalities if we have got to correlate with that of the peripheral smear study itself. So the manual smear study involves various steps, but the most important thing is the peripheral blood smear preparation, a good stain smear, and a good microscope and a microscopist or the morphologist. And the slide examination recording has to be done along with that of the data. And the data has to interpret it along with that of the hematology analyzer and other accessory ancillary investigations to come to a conclusion and give advisory services to our clinical colleagues itself. The most important process is the blood film preparation and the staining, and the quality of the peripheral smear preparation and the staining becomes the most important crux around centered which the microscopic study depends upon. So for all digital imaging process, whether it is in histopathology or in smear study, the most important becomes the preparation of the smear as well as the staining itself. And then of course, the vision which has been taken up either by the microscope or by the digital imaging system gets us a good data for all these slide processes what we have done. Now, what is the current hematological workup? Can we just have a look at the flow? The flow is that an EDTA tube sample is getting into the hematology analyzer. As per the review policies of the laboratory SOPs, if the results are within the range, it gets transferred out of the laboratory information system and the electronic medical record, and it can be accessed through anywhere in the internet or through the intranet itself. Suppose there is a flag of criteria or an abnormal results, the EDTA sample has to undergo a smear preparation reviewed by that of the technicians, and it has to be reviewed by the pathologist, maybe one pathologist or two pathologists or three pathologists. Suppose there is a problem where we don't have the pathologist for that particular day or that particular time, the smear has to be transferred manually to his place where he is there for the analysis itself. So the most important thing here in the whole process is that the smear preparation has to have the traceability to the patient's EDTA sample, which is barcoded, and the technician should label it very well so that the traceability of the numbering should also get on to the traceability of the EDTA sample, which is a barcoded sample itself. Now, when we are using the slides, when it gets transferred to one pathologist to the other pathologist, there is a labor which is involved there, which may be time intensive of about 30 minutes, which we have to routinely take even to rule out the MP or a malarial parasite. It may not be standardized because of the peripheral smear staining, or it may not be good because of the field of the view of the microscope may be different. And it is very difficult to train the technologist as well as the morphologist who are the junior residents or the senior residents to make sure that they'll be able to catch up the good image and the good cellular characteristics to diagnose that case itself. The histological images, that is, when you have to have a delta check on cases, it will be very difficult for us to get on to that of the manual smear preparation itself. So to summarize, the disadvantages of the manual process may be so many, but the most important thing is the brain fatigue, which may lead to missed malignancy or missed parasitic index or missed parasites of the blood itself. The training, when it is incomplete, given to that of the personnel, may be altered to have a skill labor, which might give you a difficulty in getting onto the scrutinization itself. Remote consultation may not be possible from the place where you are in the central laboratory to the peripheral laboratory or the peripheral laboratory to that of the central laboratory. The storage of the stain slide becomes a big headache for the laboratories because it occupies a lot of space itself. The data archives and the delta checks may not be possible in a manual process. Let's see whether when we are adopting the digital morphology, whether these things get totally ironed out, or still we have some limitations and advantages on the manual process itself. So when we look into the digital era of the morphometry of the peripheral smear, it was in 1966, it started with that of the Sweden company manufacturing a scanning microscope system to review the peripheral smears. In 1974, by LARC, the image processors got into the picture. And in 2000, the pioneers from the Sweden who were manufacturing the image processing system converted the machines into the cell vision. So when we look into the advantages of the digital imaging, we have an increasing number of the blood samples which are coming because of the master health checkups or because of the epidemics, where we are reviewing more number of the slides, and it requires, most importantly, the concentration by the reviewer itself. So when you have got epidemics or when you have shortage of the skills, there is a reduced healthcare spending which becomes the constraint for the management, and the efficiency comes down itself. Now, when you want to go in for a standardization so that the process remains the same, whoever may be at the forefront, the digital imaging and the stainer also helps us a lot. Coming to that of the higher quality, the traceability becomes one of the advantages for of the digital microscopy, so that you can trace across to that of the barcodings which have been done on the peripherals, as well as the coding which has been done on the digital imaging system. Delta checks can be optimized. A classification of the cells can be beautiful, and the same cells can be viewed by the other persons when we are doing a teleconsultation itself. So the pressure to do more with less will be removed, because you have got a imaging system where it can do within a span of about 10 to 15 minutes, it can finish off the scanning of the slide, and it can give you beautiful images of the WBC, the RBCs, and the platelets itself. The shortage of the skilled personnel can be removed, and remote consultation can be done because the pictures can be transferred via the intranet or the intranet, or to the links of that of the imaging to that of the mobile phones. So smartphones can also be used for accession. Shorter turnaround time can be there. I'll show you some of the cases where it highlights that the turnaround time can very much improve upon. And standardization brings in a consistency in the process itself. The most important thing is that quality control of the peripheral smears can also be done by using the digital morphometry itself. So by adopting the digital technology, that is the machine, it can improve the efficiency, promotes quality, improves connectivity, and promotes proficiency testing also inside the circle. So this is in short, what is the process which happens in that of the digital imaging. The slides are processed by the digital imaging system. The microscopes inside the digital imaging system can capture the cells, and the differential can happen. There is a pre-classification or a characterization of the cells. It can be remote either next to the computers which are provided by the digital imaging system, or remotely, and you can have a remote verification with one of the pathologists from India, or it may be from abroad, or it may be in the same circle. So this is the main small principle which I have got for you people. There's a small digital camera which has been accessed here via the sagittal section of the machine itself. The digital camera has got, these are the relay tubes which you can see here. You have got 1x as well as a 0.x relay tube. You have an objective of 10x as well as 100x, and you have an LED table which is the table source for the light itself, and the slides are being automatically mounted over here. The slides get scanned, and once they are scanned, you have a monolayer of an RBC morphology which has been triggered by that of the scanning system, where 21 different morphologies of the RBCs are projected. It counts about 500 RBCs to give you a perfect morphology of the RBCs. Coming to that of the WBCs, a monolayer search for the WBCs has been done, especially when there is a location of the nucleated cells, and about 100 to 500 cells it can magnify, and it can give you as an sorter itself. Most of the time, the WBCs are sorted for about 100, the RBCs for about 500, and the platelets are also counted with these machines. So how do they do that? So whenever you have got a slide which has been stained, it has been barcoded, and the slide goes in for the scanning from the center where you have got a thin monolayer, and as a battleground or a battlefront, it does the scanning, and it starts doing a stepwise manner to make sure that you have got the touching of the RBCs to each other, so that there is no overlapping, and you get a beautiful picture of the RBCs, the WBCs, and the platelets. So it uses what is called as a neural network or an artificial neural network, or in other words, we can also say that it is using the artificial intelligence by 360 degrees based 6 features. One is the form of the cell, the color of the cell. So the staining becomes very, very crucial for the analysis of the digital imaging. What is the texture of the granules of the RBCs or the WBCs or the lymphocytes or the monocytes, what we have got? Do they have any vacuoles? and do they have any probable functional differences which can get it, and also some of the wavelengths which can be trapped by that of an artificial neural network to give you the cell morphology itself. So this is how you get the initial diagrams which has been there, and initially you get these which are there intricate or inbuilt to that of the system, and this is the imaging what you are seeing and an output itself. So these are the classification on which the cells have been broadly classified into the band neutrophils, the eosinophils, the basophils, the monocytes, the promyelocytes, the myelocytes, the blast where there is no lineage specific, and the plasma cells and the lymphocyte variant forms. Now we were talking about that of the dengue, and we were talking about with that of the high platelet counts what you have got, as well as the high fluorescent cells what you have got in the lymphocytes. Those are actually highlighted in the digital imaging by the lymphocyte variant form of the plasma cells itself. When we have got giant thrombocytes also, you have a flag off, and you have got nucleated RBCs as a special section, the smart cells and the artifact to that of the WBCs itself. So let us see how do the machines give the information itself. This is a print screen from the WBC itself. So the blood WBCs, you can see a lot of neutrophils here. On the left hand side, you have got the percentage count, where you have got here the classification which has been beautifully done for the WBCs, and the numbers are also there here given as 1, 2 and 3. And if you're going to do a teleconsult, you can say that number 1 cell, if you can just see what might be your opinion, number 3 what is the cell, what is their opinion, you can just ask the teleconsulting group itself. Now coming to that of the looking into the aspect of the screen, when you have the screen, either you can have a gallery view of like this, or you can split the screen into two to have both the screens which are being. The advantage of having two screens here is that this CellaVisions has got inbuilt library which you can increase from your experiences, and you can pre-classify the cells and put across what you see in your day-to-day work. So what happens is that this is from the library here on the right-hand side. So this is the CellaVision library what you have got. And on your left-hand side, in the left-hand column, you have got one cells what has been characterized by our cells. So when you see there is a picture matching program which gives you a clear idea that whether we are near to it, or it may be something to do that of an atypical cells which we have to classify them as a blast cells or the non-blast cells itself. So the image library helps us quite a lot to understand that whether we are having a good traceability of the cells to the international libraries itself. Coming to that of the RBC classification, the RBC classifications are based upon the cell type as well as that of the inclusions, which you can see here, starting from the sickle cells to that of the cystiocytes to the target cells. You have got inclusions like Howell-Jolly bodies, Pappenheimer bodies, the basophilic stippling, and the parasites, especially the malaria or the babiosis itself. So one of the greatest advantage of the digital imaging for the RBCs is that it gives you a beautiful classification based upon the ISLH guidelines itself. So it gives you the percentage over here, 0, 1, 2, 3 on your left-hand side. On your right-hand side, you have the gallery where it says that you have number of the target cells, number of the cystiocytes, number of the helmet cells, number of the sickle cells, number of the spherocytes, the elliptocytes, the ovulocytes, and the teardrop cells itself. So you can connect this to your LIS, and the reports can be generated based upon the ISLH guidelines, and you have a beautiful smear report using the digital morphology itself. Coming to the platelets, whenever you have got a doubt on an automated analyzer and you would like to do a count of the platelets, the digital imaging do help us by giving us this 9 squares, and you can manually count this and you can get the count corrected to that of the high power per square, whatever you have got. And you can also have an approximate platelet per grid, and you can calculate the platelet result so that you can get a correlation between the smear, what you have done, to that of an automated analyzer itself. Now you can also go ahead to that of the imaging of your cellular fluids. If you are doing in your hematology, the cellular fluids or the body fluids can also be done using the what we call as a CellaVision pre-mode, or you have a digital imaging mode which you can change across to that of the body fluids mode itself. So when we look at the advantages, it will have a cell atlas or an imaging atlas. You can export and email the images, and you can also have a location which you can get onto that of an abnormal cells which you have missed or someone who can see. You can make yourself the guidelines and you can adopt your own SOPs to bring in to that of your reporting guidelines to that of the LIS, and you can also do a mark the images for the commenting, and you can also have a staff training program or the proficiency training program for your staff also. I'm talking to you about how can we check the quality of the smear preparation as well as that of the staining itself. Here I have got one of the quality check modalities of the digital imaging, and on the right hand side is a beautiful cell image from that of a peripheral smear where it shows the stain intensity is good and the smear color is also good, and the quality has been given as green color here, which indicates that it's a good quality smear. So when it is a poor quality smear, there is no green color in your slides, which you see here. There is no monolayer quality at all. And the stain intensity and the smear color is very poor, and it requires to be relooked at the troubleshooting itself. Again, poor stain quality here. There is a small amount of thin preparation of the green color, which has been reviewed by that of the digital imaging. The stain intensity is poor, the smear color is poor, and you have got a stain marks all over here, which indicates that you have to make a filtering of your stain quality itself. Now coming to the RBC main menu, when you look at an RBC main menu, this is the one you get on to that of a larger frame where you have got dimorphic picture over here on your right hand side. On your left hand side, you can see that you have got more number of the classifications of the RBCs itself. RBC characterization, which I was already telling you that of an RBC differentiation can happen there like this. And you can also have a matching program to understand the blue colors are the ones which are from the library, and the topmost one is from the smear which has been read to correlate that of how does the elliptocyte look. And here also you have got examples of the teardrop cells in the library, a few of them, but you have got more number of them from the smear itself for the comparisons itself, image match itself. So let us see how we can apply the digital imaging to that of the day-to-day operations itself. I have got few cases for understanding. Now, here we have got 21-year-old history of a road traffic accident we have got. And if you see that you have got flag off in the hematology analyzer, as a policy of that of the laboratory, any of the flag offs what we get here and abnormal histogram as you see here should go in for a slide review program. So when we did a slide review program for this, you see beautiful Rolu formation in this cases, and you have got anisocytosis, and you also have got a papilloma bodies in this case. Next, we have second case of 37-year-old female who was positive for SARS-CoV, especially during the pandemic of the first wave. You have got a WBC count of about 12,000 over here, and you have got a neutrophilia, and we had a policy that all the SARS-CoV-2 PCRs which are positive by RT-PCR should go for a smear review. And when we have a smear review for this case, we saw beautiful agglutination in this. One more case of RT-PCR positive for SARS-CoV-2. We had got the annotations which had been done so that we can do it on a Sunday consultation to that of the pathologist, and this was reviewed, and these were the small bugs which you are seeing. These are classical malarial parasites which you are seeing here. Okay. Now on your right hand side, I want you to see that these are the images of the malarial parasite. But on your left hand side, if you go to that of the RBC characterization, you have a parasites which have been flagged off here as red. So that's the advantage of the CellaVision, where you will be able to pick up the digital imagings beautifully well. So this is again a classical picture of the malarial parasite here. Now this is 17-year-old female. This was a very pathetic case which I saw during the pandemic. So she had a recent onset of blindness, and on the hematology analyzer you had a bad scatter plot over here, and the smear study shows beautiful blast cells here. And you see here you have got now the blast which has been flagged off 50% on your count of that of your left hand side, where it says you have got 50%. So a case of leukemia was reported on that. A 55 years old lady who had RT-PCR positivity, where you had got satellitism of the platelets over here, and the neutrophil shows beautiful vacuolations in this, and you had got toxic granules in these cases. So the pictures of the neutrophil changes during the COVID pandemic was very well given by the digital imaging system, so that we were able to help the clinicians in a better way. And this was one of the megakaryocytes in the same cases where it shows vacuolation. Now we had few unusual cases during the first wave itself. This was one of the cases which had a rosette formation because of polyclonal gammopathy. And this was a case of renal failure, which I still remember that this was a CKD. Protein electrophoresis showed band of the alpha-1, alpha-2, beta, as well as at the gamma. And beautiful rosettes were seen in these cases, which was also uploaded to the ASH image bank. Then we had one more case of the fat embolism syndrome. During this case, where the hematology smears were abnormal. On the tube, we had this flat globules. Let us see what was the picture when we saw in that of the digital imaging. The digital imaging showed beautiful flat vacuoles engulfed by that of the neutrophils here, which was published in the ASH image gallery. And this was the image of the yellow particles, which we went on the wet mount, showing the flat globules, and it was a case of fat necrosis syndrome. We also saw Howell-Jolly-like inclusion bodies in COVID patients, where we had got small Howell-Jolly-like inclusion bodies, which was one of the indications that it may be a patient may be on a high dose of antiviral drugs or antifungal drugs. And this was one of the cases of an indication of the cytotoxicity or the cytotoxicity to the bone marrow also. This was one more case, the first case where I told the 21 years old male who had got the Rolu formation. The bone aspiration was done, and it was also mounted on to that of the digital imaging to show you that these are the Russell bodies which are there in the plasma cytoid cells, and the serum electrophoresis showed positivity for the M protein itself. So these are again the bone marrow of the same picture, or the same boy had showed lot of binucleated plasma cells, and a report of multiple myeloma was issued on this case. This was one of the beautiful cases which I learned, which I think I'd have really missed in my manual manual morphology itself. This was a beautiful plasma cells which showed Snapper's neat granules in the plasma cells, and it got published in that should be uploaded to that of the ASH image bank, which got into several reviews because they wanted us to make sure that we gave them the proper documentation of the reference. There was only 2 references worldwide, which we had to ask the authors to give and try to upload it in the ASH image bank. So in addition to all this, we have got some fun, which making that of the digital artist. And thanks for so much for listening with great care. Take care and be safe. And I hope I was able to give you in a nutshell how the man, the machine, and the morphology makes our life better. Thank you very much.
Thank you, Srinivas, for that brilliant talk. And I think you have integrated the digital morphology into the current practice. We have few questions from the audience. The first question is by Sandhya Ramachandran, who is asking, 100x objective is available with which slide scanner?
I could not get you, sir.
100x objective is available with which slide scanner? A question by Dr. Sandhya Ramachandran.
Okay, it's available with that of the Cellar Vision.
Okay. So the next question is by Dr. Sabnam Ruhi. She's asking, how can you include this Cellar Vision in the scope of NABL, and what are the prerequisites, if any?
Okay. I would suggest them to look into the CAP website, where they have released guidelines for the digital imaging system in the month of May 2021, where it gives how you can incorporate the digital imaging system, whether it is hematology or histopathology, in our accreditation process itself.
Yes. Any more questions by the audience? I don't see any in the question answer box or on the chat box. Any more? If the audience could ask questions.
Yeah, we can have the questions typed in the Q&A and chat section.
Yes,
for
I
Dr.
have asked all of them what is available currently.
Yes.
Yes.
So even if there
Somebody
are,
else is asking, yes, one more question. No, it is just Shabnam is thanking CNS.
Oh, thank you.
Dr. Ravis is asking thalassemia slides, how it could be characterized.
Yeah, we can do so. We can do the smear screening for the thalassemia. And if you want to incorporate some rules, you can incorporate the rules into that of your flagging system in your hematology analyzer and incorporate that as a reflex smear study. And you can get onto the digital imaging where you can get onto that the target cells grouping can be done by the digital imaging system.
You see what, Srinivas, we also have been using Celavision for almost now 1.5 years.
Yeah.
The total number of WBCs that the scanner counts,
yeah,
is just 200 neutrophils, 200 white cells.
Okay, sir.
So I have asked the Celavision people if it could be adjustable. Suppose I want 500 white cells to be counted in the differential or to be imaged. The time taken will be more, but at least we will know more number of cells. So particularly in a cancer center where blast count is very important in post-induction or post-consolidation, where 1% occasional blast, 1 to 2 blasts per 200 WBCs. So just 200 cell count by Celavision, I think, is not adequate. So I think it is work in progress. I think Celavision must be working on it. How you can adjust the total number of white cells to be within the imaging radar. So that I think they must be working. Yes. What do you say about this?
That's right, sir. So we have some issues in the digital imaging system, especially when we have pediatric cases, sir. So you will be knowing much more about it because you are handling more of the pediatric malignancies also. So there are some issues with that of the pediatric slides, especially when it comes for the leukemia. And when they have pancytopenia, it becomes very difficult to go with the help of the digital imaging system.
Okay. Anybody has any questions? Anil is in the audience. Could he contribute something? Anil?
Yes. So the point is,
So what
I
is
think
your
you
comment on this, these discussions that we had about the Celavision?
I think it's an amazing kind of a, if I look at the technology part of it, there's no question on that part. Yeah. It is surely going to, may not really replace the man, as Dr. Srinivas has rightly pointed out. What's more important is that it needs to amalgamate in our routine working, wherein the flagging and, how we define our slide review criteria and then eventually use this for our benefit is what really is going to make it the best. And in fact, I was amazed at the kind of cases which Dr. Srinivas showed us. This normally, you would just miss them, because you generally have a tendency to look at the smears, maybe 50 cells or 100 cells, but then when you take it from a digital morphology analyzer, a lot of things get picked up which are given to your eye and you are able to actually figure them out. So all in all, I surely feel that digital morphology is going to be, something which is the future for, in the area of hematology. And I just hope that we have solutions which are not very expensive to afford for majority of the laboratories to get it into this picture. And hopefully it should give us a lot more information than what we currently have. But all in all, a fantastic presentation, sir. I must, congratulate you for that. It was beautiful, especially the cases, the contributions which you made to the ASH Image Bank. Amazing, really, really good and really, really beautiful. Thank you, sir. Thank you very much for sharing so much with us.
Thank you, Anil Handu. Personally, I would like to thank you for inviting for this forum. Thank you.
Thank you. I think we are coming to the end of this session. At the end, I would like to profusely thank Anil for his persistent effort year after year for putting this in place and conducting this scientific program and developing this program into a yearly annual ritual. And I must compliment him for all his efforts. Brilliant effort, Anil.
Thank you very much, sir. Thank you so much, Dr. Deepak. It was really, really nice of you to have accepted to be a part of the chair of this session. And I'm really thanking you from the bottom of my heart to have, taken us through the entire session since morning. your comments and your snippets in between have been extremely good and beautiful and thought-provoking also in some of the presentations. Some guidelines or some suggestions which you've given to Tina especially, I'm sure she will be taking it up in the laboratory and with Nishit's help, and we should also be supporting it significantly. Hopefully in our next session we will be able to give you better information on that
and
front
with your leadership role.
Absolutely, sir.
So there are two more things in the chat box. Just Dr. Sabnam has said that there is a similar system in the market by Sig2Play. What is your experience with it? You know, Sig2Play is now tying up with us for validating their platform. This is an Indian company in Bangalore.
Yeah.
And they have devised a platform which is similar to Celevision. And I think, yes, this is an Atmanirbhar Bharat initiative. So let's see how much Atmanirbhar we could be.
Yeah, I think Sig2Play is something which is probably, I've also had some interaction with them in the recent past. We are also looking at, evaluating them in our center.
Yes.
On the face of it, they seem to be a promising new set of people, who are trying to get us something which is maybe similar to Celevision, but only time will tell. That's first thing.
Yes.
Second thing, we expect it to be much cheaper. So obviously it might be, a product which perhaps people with the, constraints of finances can easily look for.
Yes. And Dr. Rna is with them, who is working
Yes.
hard all over the country to go around and do this. And lastly, Parag Tavkar has come on the chat box, and he's saying possible to count up to 900 cells. You know, the default setting of Celevision is 200 white cells. So I asked him, why can't we make it 500? Because when you have very low number of blasts in the peripheral blood post-induction or post-consolidation, so you have to examine large number of WBCs to find that one occasional or one or two blasts. So I asked him if we could increase this 200 default setting to more. So he has written that possible to count up to 900 cells. So that's good news. We can do that. Though the scanning time will increase, but I think it is doable. The system should permit us to do that. So with that, I thank the organizers, Mindray, Dr. Anil Handu and his entire team of his colleagues in BLK, Max, and I hand it over back to the organizers to take the proceedings.
Thank you, sir. Thank you, Dr. Mishra.
Thank you, everybody, all the speakers for their brilliant talks.
May I call on Dr. Handu
and
again?
Dr. Srinivas.
Thank you, Dr. Mishra. Thank you for your valuable
Thank you, sir.
feedback.
Thank you.
And thank you. Now, moving ahead, may I call Dr. Handu to please introduce our next chairperson, Dr. J.S. Suri.
So it gives me immense pleasure to introduce Dr. Suri to the audience here. Dr. J.S. Suri is a veteran in the area of laboratory medicine, and he is the founder and the proprietor of the Suri Path Labs in Delhi. This lab happens to be just next to our hospital. In fact, when we started our baby steps in BL Kapoor Hospital many years back, that's in the year 2008-9, in fact, it was Suri Path Labs who supported us at that point of time and ensured that we started our journey in the area of laboratory medicine. With him and his team, Dr. Pradeep, you would have heard him yesterday. They are doing a phenomenal job, not only with respect to the routine laboratory services, but high-end laboratory services, which includes molecular testing, which includes high-end hematology analysis, and including histopathology as well. So I think Dr. Suri needs no further introduction. He is a veteran in this area, as I've mentioned already, and I invite him to chair the session from now on. Sir, please, all yours, sir.
Thank you, sir. I will, Dr. Suri, I will share the CV and you can just go through it.
Thank you, Dr. Handu, for kind introduction. Dr. Handu is a close friend for a long time. And I'm also thankful to Mindray for giving me this opportunity. And the next topic is microscopic or automated query consideration on the NRBC by Dr. C. Ketloy from Thailand. Yes, Dr. C. Ketloy is PhD Biomedical Sciences, Interdepartment of Biomedical Sciences, Graduate School,
by mistake.
Faculty of Medicine, C University, MSc Medical Sciences, Faculty of Medicine, C University, and BSc Medical Technology, Faculty of Allied Health Sciences. I can't pronounce this word, C University. And her professional career is Associate Professor, Faculty of Medicine, C University, Research Team Leader, Chula COVID-19 mRNA Vaccine Development, Chula Vaccine Research Center. Her area of interest are hematology, vaccinology, and immunology. I will request Dr. Ketloy to please give us the pleasure of her talk.
First, I would like to thank the organizer for giving me an opportunity to talk to you all today. Today, I would like to present in the topic of microscopic or automated consideration on NRBC count. In relation to this presentation, I declare no relevant financial interest in the products or company. All reagent used in NRBC study was supported by Mindray Medical Thailand company. My presentation will be divided into 4 parts. First, I would like to give you why the slide review list is important. Second, I will move on to the nucleated red blood cells and its methodology for NRBC counting. Finally, we will consider on the comparison study of the NRBC count by microscopic count and automated analyzer and its conclusions. Before going into detail, I would like to introduce our hospital, King Chulalongkorn Memorial Hospital, which is a medical school of Chulalongkorn University. King Chulalongkorn Memorial Hospital is a tertiary care and teaching hospital which is located in the central of Bangkok. We have a 19-story building named Poporo from the great King Bhumibol from the outpatient department, and also have a 29-story building. This is a new one, which has a living space more than 200,000 square meters for supporting up to 1,700 bed inpatient department patients. At our central laboratory, we provide routine CBC service totally around 340,000 per year, and approximately 50% of these tests are converted to a manual smear review as a result of our adapted review criteria from automated CBC of the International Society of Laboratory Hematology. On that time, NRBC are the most frequent abnormal morphology tracking by the automated hematology analyzer. This slide shows 71 rules review criteria for automated CBC. In our laboratory, the slide review will be done when the NRBC is tracked and show any value by the automated hematology analyzer. So the slide review rate significantly increased turnaround time of the CBC, and especially the laboratory costs the money. Now let's move to the NRBC. Nucleated red blood cell or NRBC, sometimes we can call normoblast, are are the immature red blood cells that mainly located in bone marrow and should be none in peripheral blood in normal case, except for the newborn and the fetus. The presence of NRBC in the peripheral blood or normoblastemia is an indicator of pathological state associated with either increased erythroid activity or bone marrow damage or state. Several studies show that the presence of NRBC has a significant prognostic value, does not offer a diagnostic of disease. For example, in thalassemia patients, the number of NRBC is beneficial for blood transfusion management. So as few as just only one NRBC should be reported when seen on adult peripheral blood smear. Since NRBC are often included together with the lymphocytes in automated hematology analyzer, the presence of NRBC leads to the overestimation of white blood cell count, and the accurate NRBC is essential for collecting white blood cell count by subtracting separately count NRBC by manual microscopy. The NRBC are reported as a number of NRBC per 100 white blood cells. A reliable and sensitive method for detecting NRBC in patients can be used as important diagnostic information for the clinicians. So there are three methods of the NRBC counts. The first one is a traditional one, the manual microscopic count. The second one is the reference method, which is the flow cytometric analysis. And the third is the automated hematology analyzer. The most widely performed method for NRBC enumeration in clinical laboratory is the manual microscopic count, same as here in Chulalongkorn University. For the manual microscopic count, most laboratories have used a traditional manual count to detect and estimate the number of NRBC. By using the right beam, NRBC are counted separately and expressed as a proportion of a total of 100 white blood cell counts. Although this method is a traditional method, that virtually X mean which can distinguish a small lymphocyte from an NRBC. This method is labor intensive, time consuming, somehow subjective, and therefore potentially inaccurate, and is rather imprecise due to the small number of NRBC count. So the next one is flow cytometric method, which is a reference method that have more several advantages over manual microscopic method. In that large number of cells can be analyzed, and that several parameters rather than morphological characteristics can use for identifying cells. However, this method requires expensive instruments and specialized personal skill, laborious sample preparations, and time-consuming analysis. For the flow cytometric staining, a problem with NRBC and also mature red blood cell count is the absence of a specific marker on their surface. NRBC can be identified by a combination of cell nuclear staining with the propydium iodine and CD45, which is the leukocyte surface labeling. By using this double staining, NRBC appear as the PI stained cell, which is the nucleated cell, without surface expression of CD45, and can be distinguished from white blood cell, which always express CD45 here. So the percent NRBC can be calculated by using the NRBC event in quadrant 1 and subtract by the total white blood cell event, which is the total cell that express CD45 on the surface. in quadrant 2 and 4 and multiply by 100%. Last but not least is the automated hematology analyzer. This method offers many advantages for high throughput laboratory, including faster turnaround time, labor saving, and high reliability. A new generation of automated analyzers were developed to count the NRBC concentration in blood with excellent precision and accuracy, depending on a varied technology and methods. Here, I would like to show you the principle of hematology analyzer in our laboratory for the NRBC count. In routine CBC test, differential white blood cell count can track the NRBC if they are present in the sample, and the actual number of NRBC can be measured in a dedicated counting channel to obtain accurate quantitative NRBC. This is help to reduce the cost of counting NRBC in the sample without the NRBC flag. So, in the NRBC channel, a combination of patent-lysing agent and fluorescent dye can be helped to identify NRBC on the optical fluorescence system. In this channel, the red blood cell was light, and the nucleic acid in the nucleated red cell, which include the NRBC and the white blood cell, was tainted by a fluorescent dye. And NRBC can exhibit a weak fluorescent signal, can then be identified from white blood cell which have a strong fluorescent signal and are present as an absolute number. The fluorescent intensity and forward scatter light intensity of each cell are analyzed, and this allows the clear separation of the white blood cell and the NRBC, and can calculate at a percent NRBC that can found in the blood. So in year 2016, our laboratory switched to a new automated hematology analyzer. So however, our technicians still performing the slide review in all NRBC flag by automated analyzer, because they are believed and also confident that the microscopic method is the best method for NRBC counting. Interestingly, they found that their manual count always have a higher count than the automated analyzer. So the objective of this study is to evaluate the possibility of reducing the manual review rate by the automated count. And our NRBC study has been done on year 2017 and published in the International Journal of Laboratory Hematology on year 2018 in this paper. So what have we done? We use a positive, we use 100 positive NRBC flag sample from the automated analyzer to perform the reference flow cytometric analysis and the traditional manual microscopy by using two technicians to count the NRBC by performing at least 200 cell white blood cell count using a light microscope on the blood film. And the average of the NRBC number from both technicians were reported as an NRBC absolute number. This slide shows the comparison study of the NRBC count between the microscopic and flow cytometry. And before going into details, I would like to explain about how to interpret the result. If two methods that we would like to compare are comparable, the slope of passing backlog analysis should be nearly 1. and the bias of band Ottman analysis should be low or equal 0. The manual microscopic count by two technicians show a poor correlate with the flow cytometry. You can see here the slope around 1.3, and the manual count show a progressive negative bias, which indicate an overestimation. This finding is in line with the observation by our technician in their routine manual NRBC counts that are always higher than the automated count. The comparison study of NRBC count between automated analyzer and the flow cytometry demonstrate that the automated NRBC count have an excellent correlation and low mean bias with the flow cytometric method. So how to explain this possibility? The possibility of the manual microscopic count error might be due to the heterogeneity of the cell distribution in bloodstream. As you can see here in this figure, the 15 different area of slide from head to tail show in here from 1 to 15. You can see that the amount of white blood cells and the amount of NRBC are gradually decreased. However, the proportion of the percent NRBC is increased. This slide shows the NRBC count by flow cytometry and manual microscopic count in fracking sample from automated analyzer. According to the 41 rule review criteria by ISLH that I mentioned earlier, an NRBC cutoff of more than 1% was defined as the positive threshold. You can see here that no false negative NRBC count were observed in both flow cytometry and manual microscopic count. However, in NRBC count less than 1%, you can see here that no NRBC on 14 but smear was observed. The difference in the consistency of automated analysis and microscopic count might be due to a significant difference in the number of analyzed cells. The automated analyzer can count more than 20,000 cells, but by manual microscopic count, we count just only 200 cells. Based on our data, we can conclude that automated NRBC count with NRBC more than 1% was precise and could replace the traditional manual microscopic count, which is labor-intensive step. And after implementation of automated release of NRBC count more than 1% in our lab, it helped to reduce the slide review rate at least 20%. So the reduction of manual review rate by the automated count can bring our staff more happiness with a good quality of life and bring the quicker turnaround time, which is the speed of the result, with reducing the cost. Before ending of my talk, I would like to thank Ms. Chatip and Ms. Charissa from Faculty of Medicine in their help for cytometric analysis, and both technicians from my central laboratory from the hospital for their help in microscopic analysis. So thank you for your attention.
Thank you, Dr. Ketloy. Dr. Suri, there are no questions in the chat box. Would you like to comment on this? Anything?
I think we must thank Dr. Ketloy. Regarding nucleated RBCs, I think it's a very important parameters which we have been seeing on the manual smear examination for almost 50 years. And when we do see nucleated RBC in an adult person smear, we start thinking ahead, for what is the cause of this. So whether it is some sort of a hemolytic anemia or some malignancy or some other pathology, we need correlation with other parameters, whether there is leukocytosis, immature cells of different types, what is the status of the platelet, and we get the direction where we have to go. The main essence of this probably lecture is the role of automated. Firstly, she's convinced us that automated nucleated RBC in the modern analyzer is a good tool, and it compared well with flow cytometry, almost 100%, and particularly when the NRBC count is low, lesser than 1%, then our efficiency of auto analyzers is far superior, because auto analyzer can still find 100% nucleated RBC, maybe 0.5%, but when we examine the peripheral smear, we may miss. Probably we are not looking for it, or we are not trained to look for it, or we are not seen adequate number of cells. So that is what my observation is. As it is a recorded session, probably there will be no question to be answered by the speaker. So we can go to the next.
Thank you, sir. I will display the slide for next speaker.
Our next speaker is Dr. Prabhu Meghanathan. He is a lab director, Hybrinomics, Life Sciences and Diagnostics, Bangalore, Karnataka. The topic of the discussion is identification of leukocyte. I can't see this. In viral infection from CBC scatter. Dr. Prabhu is formerly worked in the prestigious institution in Karnataka, like Apollo Hospital, Karnataka Institute of Medical Sciences, Bangalore Institute of Oncology. He has a molecular experience in real-time PCR with more than 50,000 PCR reactions being performed. Won first prize in online quiz for postgraduate in KCI APM 38th Annual State Conference. He is from the St. Joseph's College. He has several publications to his name. So we'll request Dr. Prabhu Meghanathan to give his presentation. Thank you.
Hello, everybody. I'm Dr. Prabhu Meghanathan from Hybrinomics Life Science and Diagnostics. Thank you for CUBE for inviting me to present this talk on identification of lymphocytic changes in viral infections from CBC scattergram. The scattergram has been used widely for identifying various causes from leukemias and cancers. Let us look into the infectious pathology, especially understanding how a virus would also be predicted using the same scattergram. As we already know, the basic principle of a scattergram, and the principle is laser and the fluorescence. Using laser technology, we use forward scatter and side scatter. And fluorescence gives us information of DNA and RNA content. This, in turn, the beauty of the Mindray is that it executes SF cube technology, which in turn plots the scattergram in a 3D pattern. So which helps us to understand the cellular complexity, the DNA and RNA information, as well as the cell size. Using these three parameters, we could able to categorize the various patterns of diseases and the cell morphology. The normal pattern of these scattergrams are like the fluorescent dye, the fluorescent color plot, which you could see here is usually at the lower end. And then we have a monocyte, the violet color representation of it, and neutrophils, the blue color representation. The HFC cell, which is usually present on the upper part and which are usually scanned in a normal scattergrams. This is a normal prediction of how a scattergram looks at. We will be concentrating on the pattern and the distribution of the scattergram. Here, basically, we'll be looking into the RNA viruses of this scattergram. We are looking into 3 different RNA viruses, which is commonly known to us. One is H1N1. In H1N1 is also an RNA virus, which in turn has already caused a pandemic. And it also produces the similar symptoms of SARS-CoV of respiratory distress syndrome. The classical picture of H1N1 is more of a lymphopenia, and also it produces sometimes pancytopenia too. Looking at the scattergram of H1N1, you could see the pattern of distribution of the scattergram of a lymphocyte and monocyte and neutrophil is almost similar to that of a normal, which is on the right-hand side of your slide. The basic difference would be some amount of HFC cells, which is a little higher in terms of an HNN. This would be a possibility of thing. These cells, when looked and under peripheral smear, look more of atypical lymphocytes with vacuolations and undulations of the cytoplasmic membrane. Dengue is also an RNA virus, the classical pattern of it. But strangely, the dengue pattern of scattergram is very well known to us and also totally different from the other RNA viruses. This is the scattergram of a dengue, which in turn where you could see a high fluorescence of the HFC cells, which is usually present on the upper part of it. And when you compare to the normal in the upper corner of your field, you could see the more these HFC cells are skewed up on a higher trend. So this is a classical pattern of a dengue. So let us also look into dengue for serial data or sequential data of representation of scattergram. As you can see, maybe the day 1 to the day 6, the HFC cell is probably increasing and decreasing in different cases, both having a similar pattern of distribution. Strangely, I would also like you to make a keen observation on the distance between the lymphocyte, the monocyte, and the neutrophil patterns in dengue and the normal scatter plots. Basic differences when you look at it when in a H1N1 is the distance between these two are almost similar to us, whereas in a dengue there is closeness of the monocytes and lymphocytes and neutrophils. Basically, the pattern why this happens is the cell size is almost getting similarity among these cases when infected. Now coming to our current scenario, where in turn a SARS-CoV-2 virus, which has created a huge pandemic to the world. This virus is also an RNA virus. Strangely, it also produces symptoms similar to that of H1N1 in terms of respiratory distress syndrome. And also, it also produces symptoms similar to that of dengue, where in turn sometimes patient presents with the platelet low count and hemorrhagic features. So looking at these pattern of the SARS-CoV with different varied patterns from coagulopathy to that of respiratory syndromes, looking at the pattern of scattergram is little much more stranger to us. When you look at it, it has the exact copy of the same of a normal distribution pattern of a normal population to that of a scattergram of a SARS-CoV-2, except for the few targeted high fluorescent like cells, which is plotted on the upper graph here. Even here, a scanty amount of high fluorescent cells. This is a sequential pattern of SARS-CoV-2, wherein a patient initial feature presents a little bit of scattered high fluorescent cells, with a distribution pattern similar to that of a normal scattergrams. Whereas after a few days, you could see the there is a lacunae gap, but the site scatter part of it remains the same distribution pattern when compared to that of the first. And the high fluorescent cells population also remains almost the same. This is a characteristic pattern which we could notice in SARS-CoV-2 after a sequential pattern. When we looked at morphology of these cells looked more like a plasmacytoid-like cells or not vacuolated. The cytoplasmic membrane was more smoother, not like undulated like an atypical lymphocyte, which is characteristically seen in other viral infections. There's another case which also produces the same pattern of initially a scanty amount of it, of the high fluorescent cells, which is almost the relatively same numbers, except for the width distribution distances from these scattergrams, which is varied, or widening of the gaps is noted. Basically, all the SARS-CoV-2 do also produce lymphopenia in their action of during the course of this. Let us look at the cases which are negative for SARS-CoV, or also negative for H1N1 and negative for dengue. Strangely, when we compare it, it is almost similar to that of an H1N1 or other thing, except for the pattern of the lymphocyte distribution, which is usually having a bulge or more skewed towards the side scatter towards the left. And the pattern of your high fluorescent cells is similar to that of an H1N1 or similar to that of H1N1, except for the bulb-like basement surface of the in other viral infections, which is not noted in the normal phenomenon. Whereas in H1N1, difference is that the H1N1 and normal cellular distribution looks the same, except for the high fluorescent cells, which is usually noted in H1N1. The other viral infections, what we have noticed is the high fluorescent cells, along with the increase in the amount of lymphocytes at the base. Let us also look into non-viral entity or bacterial infection, which we could characteristically label probably as a dewdrop-like pattern. If you look at an H1N1, it's just normal phenomenon, whereas a normal is just having a small distribution. Whereas in this, you could see it is like a drop, dewdrop, which is just dropping down from the top. So these, though both are different viral etiology, and other part is your neutrophil population is also high, we are looking more into the lymphocyte, the pattern of lymphocyte, pattern of it. Can we really look at it? Is the HFC cell different from this? When you look at it, the degree amount of HFC cells of the side scatter is very high in terms of bacterial infection when compared to a viral infection. Other point would be highlighted is that the dew, like a dewdrop, you could see just forms a small, like a dewdrop, like how a droplet falls down. This is a characteristic difference for any lymphocyte population from bacteria to that of H1N1, which could have been observed by us. So in general, the phenomenon what we have noticed is that H1N1 produces HFC cell, a scanty amount of HFC cell, but the pattern of distribution of the relative scattergrams of lymphocyte, neutrophil, and monocytes is similar to that of a normal population. Whereas a dengue usually have a high fluorescent cells, which is very high. Along with that, these scattergrams usually tend to merge each other. The next part of a SARS-CoV-2 is that they also represent the similar pattern of a normal distribution, except that the HFC cell is very scant in terms of SARS-CoV-2. As we could see here, hardly few populations. And the next characteristic pattern, what we noticed is that these distribution of pattern scattergrams usually widens as the day progresses in SARS-CoV-2. And the lymphocyte population morphology also is drastically different from that of other viral infections when compared to SARS-CoV-2. Thank you. This would be the end of the conclusion.
Thank you, Dr. Prabhu.
Thank you, Doctor.
Would you like to comment and ask anything to Dr. Prabhu?
No, I think he had given an excellent, and I'm amazed that he has differentiated from scattergram between H1N1, dengue, and SARS-CoV, and I think he has done a great job. I have no question. If
Yes, sir.
audience has any, please. And it was really enlightening to know.
Thank you, sir.
So should we move on to the next speaker, sir?
Yes, please. I think we can go for the next speaker. I think it's a great pleasure to introduce Dr. Anil Handu. He needs no introduction. He is known to everyone, rather he is the host of this seminar. Anyway, to complete the formality, I will still introduce him, and it's great pleasure for me. He is a Senior Director, Hospital Laboratory Services, Max Healthcare. I think the screen has gone. Anyway, I can continue. And he's a renowned hematologist with vast experience, and he has done a lot of research in hematology, and I will request him to proceed with his topic. The topic is flag optimization of WBC. Whose job is it? So let us see and enjoy the.
Thank you very much, sir.
Thank you very much for that kind introduction. And the job for me today is to talk about flag optimization. And the question that we need to ask and answer at the same time is, whose job is it to go ahead and do flag optimization? Now, the question which we need to first answer is why the analyzer is in place. So what I have done is to answer the question of whose job is it with respect to flag monitoring on a flag optimization on a hematology analyzer. I have divided my talk into the first question, which is the purpose of having the cell counter, then concepts about flagging. I'll talk a little bit about slide review rules, which perhaps Dr. Kunal would also would have spoken about. Validation of slide reviews results, because it's again important for us to know about that, and automated selection and release of reports, which is so relevant in today's day and age. Now, the first question that we need to answer is, what is the aim of having a cell counter? You know, the aim of having a cell counter in place is to reduce manual labor and reduce the work of reviewing the smears, right? So the idea is that you're just wanting to make sure that the machine does majority of the work, and what work really comes to you on your table for review and giving your expert opinion is something which you spend your time on, and that is that's the time spent worth on it, right? Now, the issue in this is, could you miss a case? And that's where the biggest challenge comes in, and that's why the flagging concept needs to come into the picture as well. So that's where we talk about what is flagging, why do we talk about flagging, and how does flagging become important in any hematology analyzer. So what is the role of flagging is the first question, which we need to answer. And mind you, it's not just to put a flag of a vendor on an instrument and say, well, this instrument is from Mindray, or this is from Abbott, or anyone else for that matter. It's extremely important to realize that we need to have something on board which is going to help us to give us an alert that do we need to review the results from this particular sample which is being fed across into the analyzer, or can we go ahead and release the results without looking at a smear or without reviewing the smear at all. Now, when we look at flagging in general in any hematology analyzer, there are various types of flags which come up in an analyzer. Some are very clearly what is called a condition flag. For example, it describes cell population. It says like it's a normal cell population or a normal cell population. Example, for instance, if you look at WBC flags in one of the analyzers, it gives you a flag of blast ? It gives you a flag of immature granulocytes ? Some analyzers it gives a flag of band forms. In others, it gives you variant lymphs, atypical lymphs, or it goes out and directly tells you go and review a smear. So now this is something where the analyzer has taken a call based on certain algorithmic information which is coming across to it from various channels that the sample is passing through, and based on that it's giving us this information. Some more flagging. If you look at the red blood cells, there are certain flags, like for instance, nucleated red blood cells. Previously, in some of the analyzers, which were not as advanced as we have today, for example, the 6800 plus from Mindray is a very, very robust analyzer which has a specific NRBC pickup. Now, there were analyzers previously which did not have really an NRBC pickup, but it will give you a suspect flag of NRBC and say query NRBC. Similarly, when you have macrocytes which are in plenty, it would give you a flag stating that your smear probably has the macrocytes. Sometimes it would give you a definitive flag of dimorphic red blood cells or fragmented red cells and stuff like that. Again, it also depends upon how have you defined your limits within the laboratory with respect to definitive flagging. And also, the instrument is able to guide you and give you information for providing for a review. There are other messages which are also so-called flagging messages which are important, and some of them are typically very generalized. For example, an alert low or an alert high, or a critical low or a critical high. But then there are others which can be vendor specific or instrument specific even with the vendor itself. Like for instance, in some places people use these kind of dotted lines where it says clog detection in a flow cell instrument and stuff like that, but it may not necessarily be the same kind of a flag which is coming in the other instruments. So therefore, there is a little bit of variability with respect to the analyzer flagging messages that come in. However, these messages are extremely important because they actually alert you with respect to what is happening on an instrument with a particular sample that you've sent across. Now, as a hematologist and as a person who's been called for many discussions and the purchase committees across many hospitals, which I have been seen through both in Delhi NCR as well as some other parts of the country, a usual query which keeps coming to me is that I have bought these gotten these analyzers for evaluation in my laboratory, analyzer A, analyzer B, analyzer C, and I have looked at it. They all give almost similar hemoglobin, similar total counts, similar platelet counts. Now, which of the analyzers amongst these should I just look at as one of the best? And how do I decide with respect to that? So every time I keep asking them a question, how are they with respect to flags? So if, for instance, in analyzer A, there are no flags at all, it doesn't give you any flag for anything, whether it's an abnormal sample or a normal sample, versus an analyzer B, where there are just too many flags. Even for a normal sample, it's giving you flag of sometimes, that there are clogs, or for that matter, it says that, you have a blast there, or it says that there's an atypical lymph there, or versus an analyzer C, in which flags are just right. So if I have to choose between three analyzers, the answer for this question is pretty simple. The analyzer C obviously is the best because it's able to give me optimized flags for my samples to be reviewed, which eventually will make sure that I'm not wasting my time on something which is trivial. Now, just to show you one of the screens which is important, a lot of people do not perhaps even know that flags are set in a very specific mode on a hematology analyzer. Like this is a picture which I'm showing you from the software which is used with the Mindray group of instruments called Lab Expert, and in that we have something called iMessages, and within that iMessages we are able to actually set up values with respect to whatever we are wanting to be flagged out. So if you can see in this particular slide, what you're seeing is you have these flags which are prominently in front of you: the RBC lyse resistance, the blast, normal lymphoid blast, atypical lymph, agglutination. And I've specifically shown you one of these as fragments. Now, if you look at abnormal lymphoid blast, in this particular sample which was run across, it has picked up, it has highlighted this very prominently, clearly telling you that probably you were dealing with a sample which was a blastic sample, and in fragments, it gave you a value of 0. Now, the threshold has been set at 40. Now, this is a threshold which has been set across by the company which has provided it to us. Now, what we need to do in our center is to see whether this 40 is really right for us in our center or not. And that's where flag optimization comes into play. And obviously, this flag optimization, therefore, does not remain necessarily with only the instrument, with the company or with the vendor who's giving you the instrument. So if we look at flagging, setup, and optimization, we need to remember that all of these are kind of what is called numerical data, which is based on certain set of digital as well as some analog information coming in from the sample, which is sent across into the analyzer. And once we get these numbers therefore are put on a certain grid, and on that grid eventually you're able to put off your cutoffs. Now, there will be a default setting for these numbers. I'm just giving you an example. Like, for instance, in Mindray, we have these I messages, and Sysmex, we have Q flags, and likewise, we have similar kind of scales which are available in other instruments as well. And in fact, these scales become important because they eventually are able to give you some research parametric data also on which you can work. Now, this same thing I am quoting it from one of the journals, which has been published by Sysmex Journal International, where we have these default settings and what actual settings were given across in a modified setting way, in one of the instruments which was used across in that particular article. So it's important for us to realize that. Now, why do we want to flag at all? The important points of making sure that the flagging is optimized and given across in such a way, it basically ensures that the information which is traveling to you across from the instrument is able to guide you whether you're going to be looking at a smear or not looking at a smear, or reviewing the data directly or not reviewing the data directly from the instrument. And that reduces a lot of burden which comes on into a laboratory in any setting for that matter. Now, when you have a negative flag, that means no flag has been raised by the instrument. And if you have optimized your flagging in the right way, that means there is no significant abnormality in the sample, and this can be very easily just released for people, for the patient to be taken up to the clinical colleagues, and they can take an action basis that. Now, for instance, if you have a positive flagging, when you have a positive flagging, that means there is one of these messages which has come across which has been flagged out, in the sense, like, for instance, if you have fragmented red cells being projected by the instrument that there are fragments in the sample, or there are infected red blood cells in the sample, obviously it tells you that please go ahead and have a look at the smear. And again, there is another possibility where they say error. That means there is an error within the system itself, and it's a functional abnormality. The sample was not aspirated properly. Like, for instance, if you have partial aspiration, in such a circumstance, okay, just flag an error. So therefore, if you look at it, it's more like a traffic light or a traffic signal, the flagging system. If it is negative, it's obviously a green signal. If it's positive, it says look at the review and look at the smear and then report. And finally, if there is an error, you may still need to review or probably rerun the sample and stuff like that. And that's why it's more like an orange kind of a thing. So look before you allow it to go ahead. And that's where the flagging system becomes extremely important in any hematology analyzer. Now let's look at what is a positive kind of a flagging versus what is an error in terms of a flagging. Like, when you look at a positive flagging, for example, if you look at the differential morphological counts, there could be abnormality in the cell differential itself. There could be abnormality in the cell morphology which the analyzer was supposed to pick up vis-a-vis the system that it had adopted. For example, it had adopted a system of looking at a dyed white blood cells and giving the information on whether you have blasts or not, no blasts at all. Similarly, there could also be issues in the cell count. For example, the cell count is abnormally high or the cell count is abnormally low. In all of these cases, you will get a positive flagging system, and these are relatively definitive flags. Now, the moment you talk about error, we are basically talking about something which is functionally erroneous, or there is an erroneous data which is coming vis-a-vis this particular patient sample in the previous, as the previous sample had been run previously as well. For example, if you have a barcode error, other than the barcode error, in the sense there is an analysis error per se, like, for instance, the sample is being partially aspirated, or the data is of low reliability. This especially happens when you have samples which are having very low cell counts, and sometimes abnormality of the delta check also can be projected as an error in a sample. So if we look at interpretative or IP data messages which are seen in majority of the sample, you can have an abnormal one or a suspect one. Now, when you say abnormal one, it indicates that the sample is definitely abnormal, right? And this obviously cannot be said for every parameter. In fact, in majority of the cases, the abnormal messages which are definitive are like leukocytosis, or like, for that matter, leukopenia, thrombocytosis or thrombocytopenia, and at the same time there are no other messages involved. On the contrary, when you look at the suspect message, it only raises a possibility that there could be this sample could be abnormal, and there could be a possibility of presence of, say, atypical lymphoid cells, as it happens in dengue, and which could even be flagged as query blast cells. So there is a difference between a suspect and an abnormal flagging. Abnormal is always definite whereas suspect is always a questionable one which needs review on a smear. Now, remember, flagging system is based on a lot of information, and a lot of information basically comes from the cell. The cells from the cell information again is coming from all histograms and scatter plots. And remember, in the instruments where we have fluorescence, like for instance in the Mindray's one, the fluorescence is also looked at, and then eventually the interpretative data messages are given across. So there is what is called an artificial intelligence mechanism system in all of these instruments, high-end instruments, wherein the interpretative data messages are actually looked at, put into a specific algorithm which is present within that particular analyzer in their software system, and then eventually they are able to give you the interpretative messages. What's important to note is they can be set for some of your parameters. Sometimes or by default, the instrument vendor or the company may not be giving you actual information or giving you all the set of parameters for which the definitive messages have been put up. So you will need to sit down with your vendor company and ensure that this information is taken care of, and eventually you are able to give the information which is useful for the people to take care of. Let's look at some of the flaggings in WBCs which we have typically seen in one of our instruments. The typical abnormal flags or definitive flags are, like for instance, the WBC abnormal scatter plot. So if you have a abnormality in the scatter plot, the analyzer itself is telling you, look, there is an abnormality and these are the possible abnormalities which we have. Similarly, neutropenia, neutrophilia, as I already told you, and definitive flags which are all abnormal. So we need to know that definitive flags invariably are true, and it's very unusual to find abnormal definitive flags when they are false. Though there are times when you have falsely picked up abnormalities in a sample. Like for instance, if you have these small little red cells which are lyse resistant, they will obviously get into the WBCs, and these WBCs might be picked up. The numbers might just go up and give you an abnormality there. But then we also know that the instrument has to be optimized in such a way that it's able to pick up those in some other message as well. On the contrary, when we look at the suspect information which comes across, for example, blasts, the analyzer is able to pick up these cells in a specific area and always looks at it from the fact that they could be immature cells or could be blasts. So it will just raise it up to you and say, look, there is a possibility of blasts. And if you look at all of these, it's all giving you a question mark. The point of giving a question mark is to tell you that perhaps you're dealing with something which may or may not be there. Right? So that's where one needs to be very cautious, and in all such suspect cases one would definitely want to review. Now, would you be happy if you keep on getting a suspect flag for a blast in every smear? It's impossible for you to review every smear when you are dealing with samples, say about 400 or 1,000 samples a day. So in such circumstances, optimization of this flag becomes extremely important. Similarly, optimization of abnormal lymphoid blasts becomes extremely important. Again, optimization on infected RBCs becomes very important. And in some of the instruments which can give you what is called the high fluorescence cells, and sometimes even the so-called stem cells which you're able to pick up from the analyzer, you should be able to optimize it appropriately. Similarly, when you look at the red blood cells, again, definitive abnormal flags, which you talk about, say, the distribution, the scatter patterns, the microcytosis, anisocytosis, etc. But you also have to keep in mind the suspect flags, which can come up from a hematology analyzer for red blood cells. For example, fragments. In fact, there is a very interesting parameter now, which is called fragmented red cell count, the FRC, which is now becoming, in fact, very, very definitive on a hematology analyzer, and you're able to pick it. And in fact, there is a beautiful article on it from the ICSH in International Journal of Laboratory Hematology, which talks about how fragmented red cells can be actually quantitated on a hematology analyzer and give the right information to the patient. So it's important to know all this and give the right information to the patient as well. Coming to platelets, you again have abnormal distribution or abnormal scatter plots, thrombocytopenia, thrombocytosis, but what's far more important in a typical thrombocytopenic patient would be to know whether there are platelet clumps at all or not, and presence of these giant platelets, which will eventually give you a lot of confidence when you're reporting the platelet counts out. Otherwise, platelets, as we already know, are forever controversial, especially when they are at the lower counts. So if you set up your quantitative flagging and you monitor them at a regular interval, it's very important to know that there is a system within the instrument where with a software system where you have to actually set up your, the quantitative flags. For example, these two pictures are from Sysmex, which I have taken up, and in this particular case, when you see the blast flag has been, set up at a certain threshold beyond which the moment it crosses that, it's able to give you a positive flag, and then eventually when you see the smear, you're able to pick it up as well. Similarly, when you look at the negative samples, you're able to pick up your negative samples, and degree of abnormalities are also detected. So now the trigger level needs to be fixed, and that trigger level, the involvement of the laboratory along with the vendor company is extremely important. Unless we are able to work in tandem, work together, we will never be able to set our Q flags or the flagging system appropriately, so that we are able to give information which is useful for the operator, and then eventually ensure that our slide review is taken care of. Again, something which we had already shown you from, this is from Mindray, where we have seen how to set up the flags. This is a threshold which has been set across by the instrument vendor at a certain point of time, and they obviously need to be reviewed. For example, for infected red cells, this is where we had plotted it and ensured that the infected red cells are able to pick up at a certain threshold. Now, this threshold setting becomes important, and this in itself is a very important activity where you have to keep on validating, reviewing, and validating vis-a-vis the smears, and then giving this information out. Now, if we look at the flagging on a cell counter, we need to remember that all these points are important. It is defined on a cell counter, usually in an administrator mode. It needs customization at the user end, and once defined and validated, it needs to be applied to the sample mode in case you've not applied it to that. So therefore, if somebody asks you a question whether you need first, second, or third, you must say you need all of the above, and out of them, what I would emphasize on is it needs customization at the user end, and that's extremely important for us to remember. All right, we should also remember that linearity limits for red cells, the white cells, the hemoglobin, the mean corpuscular volume, the platelets, and the mean platelet volume is equally important, and we need to ensure that we are taking care of it, because this is also going to help you set up your flags. Now, once we have all the flags available with us, we need to look at it, because we have to look at how we will review our data vis-a-vis that. So reviewing the data in a high-tech laboratory today becomes extremely important, because we don't want our technologists and our doctors to spend time on something which is not relevant. So therefore, we need to review each results in the set of rules. We need to look at normal ranges, which I was just showing you, and including the linearity limits. We would like to look at the critical values, the IP and the OPD. We would look at the delta checks. We would look at the relationship of parameters, dilutional leads, etc. And then eventually give the results out, and that data review would make it very important. Now, when you try to do this entire activity, there are a certain set of rules, which is called the slide review rules. And how do you actually really know about it? In fact, I have asked this question many times before, and I have asked this in many of the audits, where I have realized when I ask this question, how does everyone know the rules? The usual answer, which ideally people should talk about, is procedural manuals. But the fact is that the reality check, when you take up, you realize that this is not really so. Invariably, most of the people actually claim that they actually pick up from the memory or the experience, and a lot of us are otherwise looking at posted sheets on instrument cabinets and countertops. So it becomes important for us to know that the flag-based decision rules have to be fed into something which is eventually going to help us to give the information in such a way that we are not going to do the donkey's work, and actually make sure that our time is utilized in an appropriate manner. So therefore, a concept of auto verification or automated reflex testing should also come into the picture, and this is applicable primarily to those laboratories wherein we have a computerized laboratory information system available and a good quality automated hematology analyzer at the same time. So remember, it's beneficial when we have this activity, and will ensure that we are able to give out quality results. Now, when we talk about validation and authorization process of any laboratory result, we would like to validate the result by reviewing the quality control, by reviewing the analyzer performance, doing a good delta check, and comparing the previously related results to the patient. And if all this is possible together, it will help us to reduce the slide review rate further. Now, after a typical automated complete blood differential count with the flagging which has been looked at and the differential results that have been produced, it's only after that we will be able to verify the report after ensuring an appropriate examination with a visual differential count if need be, and a manual platelet count also. And if there are other tests which need to be done, they can be done parallelly. Now, this is one of the slides which I like to show in my presentations. These are the slide review rules which we had defined in our laboratory, at BLK Hospital. some time back, and then we've been reviewing it after every year. These are based on certain flagging criteria which are given out from the analyzer, and we actually keep on reviewing just to make sure that they are relevant to the cause that we have developed. Of course, when this activity is done, you need a good set of people with a person who's going to spearhead the whole thing. And fortunately for me, I have a beautiful team with us, and we are able to get this generated every time and ensure that every 6 monthly we are able to handle it. We have done a very interesting study on nearly about 7,500 samples, where we've looked at the decision rules, the flag-based decision rules, and these decision rules have eventually helped us to have what is called a slide review rate, which is giving us information as to what was true negatives and what was true positives. And if you look at it, our false negative, where we are likely to lose out cases, is less than 2%, which makes it very beautiful, so that the flagging and the optimization of flags, which is helping us to ensure that we have appropriate slide reviews, has been taken care of. And just to give you a peek into what was the false negative analysis that we had done, a lot of it was a flagging or a delta check which was ignored by one of our technical staff or the doctors, and of course some others which had been missed out. So false positivity rate which we had in our study was primarily due to suspect flags, and which is expected in any part of the country, or for that matter the entire world. Now, I'm sure that you must be thinking that I have almost finished. I have, but I must tell you that there is some part of it which is abhi do picture baki hai mere dost, which includes looking at the international standard, and the standard is ISO 15189. I know a lot of people would like to talk about this because there is something about the ISO 15189 which makes it connect only to NABL. The issue is that ISO 15189 is an international standard, and interestingly, there is one particular thing which they talk about, and that's about automated selection and reporting of results. And this becomes an important aspect in hematology analysis, because we are able to take decisions based on certain rules which have been defined within the instrument, and these instruments, this automated information, software-based information, can be then used based on artificial intelligence to decide whether we are releasing the report or allowing it to go ahead for a review. So points to be noted here again is it needs to be defined as a specific verification engine, preferably in a middleware or a laboratory information system if it has a possibility of doing one. And there is also a question which a lot of people ask is, who will sign the reports in such a case when you're putting it through an auto verification system? So the answer to that question is that it is the person who defines the auto verification engine, and this is something which needs to follow a guideline called Auto 10, which is from the CLSI. This is the guideline which we should know about, and it's in this guideline that everything talks about. Now, the moment we talk about something which is going into auto verification, there are two things which keep coming into our minds. One, will I lose my job? And number two, why should I adopt it at all? Now, whenever we adopt a change, especially with this kind of an activity, we need to set our expectations right. We need to make sure that we take care of the comfort zones of the people, and we also ensure that any vendor issues which are there with respect to laboratory information system or otherwise are taken care of as well. And as I have mentioned previously, whenever we go through this change of thought process and looking into the flagging system, optimizing the flagging system, and then putting it through the auto verification system, there will be a lot of people, both at the technical and the doctoral level, who may not be wanting to change their comfort zone. So initially, they will all go through these phases: the shock and the denial, the anger, the negotiation, depression, testing. But mind you, everybody will eventually become positive and have a positive reinforcement and have this change in place, which will make life easy for everyone. So I would still want to push everyone to do a plan, do, check and act, and ensure that this part of it is worked up, especially for the analytical part of it on the hematology analyzers, wherein you have to ensure that the hematology analyzer has been guided by you to define what needs to be done, rather than it being just an instrument to give you a count of the cells and not give you any further information. And there is a proper system of how to go ahead with doing it, and it's all detailed very nicely in the CLSI guideline Auto 10. For the paucity of time, I will not get into details of that, but I would surely recommend all of you to go through this CLSI guideline and see how the auto verification process can be done. Now, auto verification with modern analyzers is possible, and it actually helps you in many ways. Some of them I have very clearly demonstrated in this slide, which is increases your productivity, reduces your turnaround time. Importantly, it reduces your manual review, and maybe it can lead you to what is called a paperless environment, and also help you to reduce errors. So to take home, what is my message to all of you with respect to flagging? Remember, for optimization of flagging, whose job is it? Was my question. My first answer to that is first acknowledge that yes, we need to do it together along with the vendor company. We need to define and review our thresholds of all the flags that we have on our analyzer. There may be certain flags where we may not really need to interfere, but then there are other flags which need to be reviewed in our own setting. We need to validate it. We need to train the staff and ensure that they are not fiddling around with the flagging which has been set. We need to make sure that it's implemented across the sample modes as well. And at regular intervals, we need to revisit and review and update any changes in such a review. We must ensure that our middleware and the laboratory information software, if available, is also ensuring that the information coming in from the flags is utilized appropriately for automated slide making if you're using. So with that, I would just show you, this is my bibliography, which I have actually utilized for looking at all this, making this presentation up. And thank you for your kind attention. Should there be any questions, I'll be happy to answer.
So there are questions. Dr. Suri, would you like to comment? Then I will, there are some questions in the chat box, which I will read out for Dr. Handu.
Yes, I have. Firstly, I like to thank Dr. Handu on the beautiful talk on optimization, flag optimization and validation, etc. I think it has been very informative and lucid, and particularly his many things are there which are very important. But I will like to seek his input on the optimization of use of the parameters given by the modern analyzer, though it's beyond what he has talked about, because what I'm finding, what for this optimization and the results are, it is for the patients, and the in between us and the patient is a clinician who probably doesn't understand. So, and the modern analyzer is giving so many parameters that it is firstly difficult for us to understand, assimilate it, and pass it on to the clinician. And we are doing it. Probably Dr. Handu is also doing, all these lectures are there. But if these lectures can be conveyed to the clinician, then probably the things will be better. I have observation that optimization of use of parameters given by hematology analyzers. Do we understand the parameters of hematology analyzer? How much do we pass on these parameters to the clinician? Do clinicians understand or accept? We need to train clinical friends about the hematology analyzers parameters. So these are my daily problem, If I write too much about my report, they don't understand. But if we can answer their question better, they do understand. So what is his comments on this?
So that's a very valid point which you've raised, sir. In fact, this is one big fight which perhaps we've been having for the last more than a decade now. The fight is to ensure that we are able to get across the information to our clinical colleagues. As you rightly pointed out, the biggest challenge is that while we may have a huge information, while some of us may even be aware of the information as to how it helps us, how does this information eventually go to our clinical colleague? How does he accept it from us? And is he really going to take an action basis that or not? What we have observed is, just give you an example of one parameter, immature platelet fraction. It was one parameter. The moment it was talked about few years back, a lot of people changed their instruments just to ensure that they have an instrument where IPF is available. Now, why did this happen? This happened because the moment IPF came into picture, people started talking about it a lot. People started telling their clinical colleagues about it a lot. And again, whenever there would be somebody, who would want to be transfusing or not transfusing platelets, the person would say, "Aap mera IPF karke de do, main batata hu platelet transfuse karna hai ki nahi." So, to that extent, people started looking at using IPF as a parameter, which would guide them to go ahead and give transfusion or not give transfusion. Now, the moment this information goes to our clinical colleagues and they are able to accept it themselves, they themselves will start go and propagate about it. But you are right, sir. I mean, if I look at the number of parameters, the amount of information which the analyzer gives us today, I am sure it's underutilized, first by us, and then subsequently by them as well. Because once, who will tell them? We have to tell them. You will have to tell them. I will have to tell them. Our all colleagues from pathology and hematology will have to tell our clinical colleagues that, look, buddy, this is a parameter which can be utilized, and this parameter will give you more information. And this information you can utilize for your patient in this way or the other. So I think there is a lot of things still to catch up, a lot of time which we'll need to spend on this and ensure that our clinical colleagues are taught. And one small little step with the cube is that we want to praise our own fraternity first, so that they are able to take it further to the rest of the colleagues in the clinical parlance, and ensure that everybody starts to get to know and demand it also. So I think we will have to do a lot of groundwork, sir, and I'm sure with your blessings and with everybody else together, we will be able to do it someday.
Thank you. Thank you. I will just say that more recently I have started using RET-HB. It has been of immense use when I'm seeing a peripheral smear. Sometimes I depend more on RET-HB than my eyes to report iron deficiency anemia. So this is just, I think we can take the questions by the audience.
So there are a couple of questions. May I read it out to Dr.
Yes,
Handu,
please. Yes, please.
So there is a question saying how we can set sensitivity for individual flags in instruments separately for WBC, RBC, platelet, etc.
Okay, so one good thing which most of the industry has done, most of the companies have done, is they have not, allowed us to get into an administrator mode into the instrument on our own whim and fantasy, which is a very good thing to happen. Because just imagine if anybody would be allowed to get into an aircraft and go into the cockpit and start, working on the cockpit, how that aeroplane will be. We will all crash land. So the point is, what I'm trying to make here is, for optimization, there is a specific window in majority of the analyzers, which is an administrator window. And this window allows you to go into the flagging software part of it, and then look at where the where the thresholds have been set. Now, generally, when these thresholds are set by most of the vendor companies, they have done a lot of research on it in their own settings, in their own circumstances, and then they have also validated it across the industry in various hospital and laboratory based settings. What we call beta testing and alpha testing and stuff like that. In fact, CMC Vellore happens to be one of those centers where most of these analyzers are actually, looked at, and eventually the flags are also set. Having said that, does that mean that we really do not need to, look at our flags at all? I would definitely not agree with it. There are flags where we will still need to look into. They will, obviously, I would not want any vendor company to open up their, the cockpits to everybody. I would definitely recommend that, it should be done in conjunction with the people from the vendor company. They will open the cockpit for you. They'll work on the cockpit for you. You only define what you want from them. So how do you do that is the biggest challenge. The biggest that challenge is not very difficult to handle also, because you are expected to anyway review your slide review rules. So if you are expected to review a slide review rules, they are all based on flagging. So you have to make sure that whenever you're seeing a blast flag, are you really seeing a blast in the smear or not? Similarly, when you are seeing an infected RBC flag, are you really seeing an infected RBC in the smear or not? So that's where your threshold setting becomes important. Now, remember, for blast, it may not be a challenge because they would have done their homework very, very well. But when you go across to, infected RBC parameters, or parameters which are more often seen in tropical countries like ours, then that is where people will need to, sit across with the companies, validate it. There is also a very interesting part which I'm seeing in the, chat box, where there is a question which somebody's asked me: how many samples should we be actually looking at? As many as you can is the answer for that. But I would not definitely, because you're looking at something which is so common. If it was an uncommon parameter, where you would, for instance, if I was talking about a PNH, the number of cases itself in a year would be few. So there you cannot have many cases to look at. But when you're looking at something which is like about 7, or, such a common thing where you have so many cases which are possible, as many numbers as possible, the minimum statistically significant number is 20. And if you can do it 200, 200, 500, it will be better, because that will give you a statistically significant number at the same time. So all in all, what you need to do is sit across with your vendor company, get hold of all the flags that they have already defined, see whether those defined flags are, when they have been, flagged out in any of your samples, are they really true? Are they really giving you the information on the smear as well? So if you're able to get that study done, just as the way I demonstrated one study in my slides, that will be able to give you whether your flags are optimized or not. Like just for instance, in our case, we had to optimize our flag with respect to infected RBCs. We had to, in fact, optimize our flag for fragmented red cells also in our analyzer. So similarly, everybody has to look at, the kind of samples that they deal with and eventually define and optimize their, flags, even though the company may have done its job completely. And also one more point I would like to make: for definitive flags, generally you do not have a problem. When you're looking at absolute numbers, for instance, 4,000 is the lower limit, or 12,000 or 11,000 is the upper limit for WBCs, you don't need to change that. But when you're looking at a suspect flag, in such circumstances, you would like to review that part of it in case it's. I hope that answers your question.
Okay, next speaker is Mr. Xin Wu, Hematology Product Manager, Mindray. His topic is optimizing middleware, flagging, slide review rules, automated selection, release of reports. Mr. Xin is responsible for high-end products and middleware software. He is experienced in hematology industry, product request development, and software optimization. I request Dr. Xin Wu to please proceed with his proceed. Thank you.
Hello, ladies and gentlemen. I'm Xin Wu, the Hematology Product Manager in Shenzhen, Mindray. Today, my topic is the optimization middleware, and I will introduce the optimization middleware in the following perspective. The first part is about the flagging and the slide review rules, and the automated validation and selection, and the release of reports. And before our introduction, first of all, I want to introduce the voice of the customer. Maybe some of you may face the below problems during your daily result reports. First of all, is now maybe we feel the higher and higher workload, which will result in the heavy burden for the staff during their daily review and validation for the results. And in some instruments, in some analyzers that doesn't have the capability for the flagging. So will result in a high false negative ratio and finally result in a misdiagnosis. And the third one is that in some labs, they are short of the well-trained technicians. So the experienced technicians, maybe they will have a lot of work to do and will have a very heavy burden for the validation and for the manually intervention. And in some labs, in some software, their design is old-fashioned and unuser-friendly user interface. And finally, in some labs, they don't have the enough budget. So maybe some software are very powerful, but cost very high. So this may be still a problem. So we have one question. What kind of software can help the lab to optimize their workflow? Here we have two keywords. We think the intuitive software and the intelligent software can help the lab to solve their problems, which we mentioned before. So here we introduce our software, our middleware called the Lab Expert. So firstly, what is Lab Expert? The Lab Expert is a middleware between our analyzer and the lead system. Now, currently, all of our 6 series and car series instruments are equipped with the Lab Expert, and all of the future models will equip with the Lab Expert. So between the instrument and the leads, the Lab Expert play an important role for the auto-validation and exam rule setting and the result review. So it is a logical, intelligent, and efficient middleware for the Mindray products, and it supports the QC monitoring, the auto-validation program, the results review, and other useful functions. Okay, firstly, let's introduce it in the first perspective, the intuitive Lab Expert. You can see here in the screen, This is the main screen for the lab expert. In the top is a daily workload. Why we need this kind of tag in the top? Because during your daily work, some of the samples may need to be rerun, so it has been separated into the to be done. And some of them need to go to the microscopic. So for this kind of samples, it go to the microscopic tag. And some of them need the re-exam, so it go to the re-exam tag. And in the left side, it's a sample list. And in the main screen, in majority of this screen is the sample result, including the numeric result and the graphic and the histogram. And in the bottom, there's still a rule record. It means that maybe some samples trigger the rules, so it will be shown here. So by this kind of design, the technicians and the staff and the doctors, they can see, they can review and validate the result just in one site. And in the patient information page, why we say it is intuitive? Because all of the sample information can be equipped from the list system, and it will be displayed here. And besides, we have for each sample result, we have the reagent and QC information. So all of the sample result can be traced. And after talking about the patient information, we go to the result page. Here is a result page. Besides except for the results, here we all just as I mentioned, we have the graphic, we have the histogram, we have a scattergram, and we have different tags for different samples. For example, we have the stack tag, a critical mark, and validation mark. So, which will help the technicians to review the first priority samples in the top, as you can see here in this sample list. So why we call it is intuitive? Because of we have the special design for the layout. And besides the 2D scattergram, in order to have the technicians to review the sample, to validate the sample, validate the result, validate the scattergram, after click the scattergram here, display on the right side, there we will have the 3D scattergram. They can drag the 3D cube in different angles, so they can see the different cell clusters in different way to help them to do the validation. And besides the result display, we also can have the historical result trend display here. They can have the parameter compare, they can have the trend graph compare, also they can have the graph compare. So they can compare the different results for the same sample to see the trend, to see the historical trend, to help the doctors know what the historical trend for each patient. And the intuitive design also, it is in the QC management. We can support the different kind of QC, and we have the several page to review the QC, the graph review, the table review, the parameter review, and the monthly review. Most importantly, if you don't have the list system, you can just print the QC graph out with the very detailed information. Okay, after talking about the intuitive design for this middleware, the second part and the most important part, why we design the lab expert, is because of it is intelligent. First, we will introduce the intelligent lab expert, the exam rules. This is the main screen for the exam rules. The left part is the exam rule tree. You can see some of them will go to if they trigger the exam rules, some of them go to review, some of them go to the exam, some of them need a microscopic. Here in this part, this is the rule list. You can add one as you like. You can delete any as you like. You can customize this kind of rules in your lab. And after you click any of the rules in this list, you can set up the rules here. We have 4 levels for the re-exam mode. After trigger the re-exam rules, we should follow the different way how to deal with this sample. The first level is the sample check. In some cases, the samples may be unqualified, maybe because of the aspiration of the blood, maybe it is unqualified. So the level 1 is the sample check. The level 2 is the analyzer status confirmation. It means that if the result trigger these rules and the rules need to be checked the analyzer, so we'll go to the analyzer check. The most important part is that the most frequently used is the level 3 and the level 4, which we call the rerun and the smear. It means that if this result trigger the rules, the sample will go to the rerun and all the sample will go to the smear. In this green area, which we show a detailed different way we deal with this sample. For example, we can rerun on the same analyzer, or we can rerun on different analyzer, or we can rerun in the same mode, or we can add another mode to rerun. For example, previously you used the CBC plus diff mode, and after you trigger the rules, you can add the reticulocyte mode to get a reticulocyte result or PLTO result. And if you trigger the rules that go to the smear, it means that if you connect with the slide maker, the sample will automatically go to the slide maker and scanner to make a smear and to give you a slide. Yeah. Okay, after talk about the action, now I want to introduce how to set up the re-exam rules, why we say it is intelligent. First of all, as I mentioned just now, you can customize your re-exam rules. After you, for example, if you click the new here, and you can input the rule name. For example, this is the WBC numbers of normal, and you can give a remark here, and WBC higher than 30 or lower than 3, and go to smear. This is like only a remark, and this is the re-exam mode. Go to smear. It means that if we trigger these rules, the sample will go to smear. Okay, and after setting the input the name here, we should set up the parameter rules here. We click here and we input the WBC. We select the WBC higher than 30 or WBC lower than 3. It means that if this sample trigger the WBC higher than 30 or lower than 3, we'll go to smear. This is how we set up these exam rules. And besides the normal setting, we can also set up the exam rules together with a flag. All of our instruments can give a very intelligent flag in our lab expert and in our instrument result, in our result page. All of the flag, you can check the manual. We have very intelligent, very detailed, comprehensive flagging for each abnormality. Okay, so the exam rules can also combine with a flag. And not only flag, we can also combine the rules together with a delta check. It means that if you can use, by combining the flag, the delta check, and the criteria you set up here, WBC higher than 30 or lower than 3, the software will decided that this sample should go to smear or go to the rerun to add in the same mode or in another mode. This is all automatically controlled by the lab expert. This is about the exam rules. After talk about the exam rules, here another key features for this middleware is the auto-validation rules. As we all know, the validation step is the last step that before we release the report. It's the most important step that before we release the report. Every day, many of hospitals, many labs, maybe majority of the samples are normal samples. So if before the auto-validation function, the technicians, they should manually validate every sample one by one. Okay, maybe they will take 3 or 4 minutes for each sample. So it means that every day, maybe they should, if they have 100 or 200 samples per day, they should spend around 500 minutes only for this validation. Yeah. So why we need these auto-validation rules? By using these auto-validation rules, we suppose and we want to help the technicians to reduce their work. Most of the samples, if most of samples are normal samples, they will automatically go to the auto-validation way. So the technicians, they can spend more time to review, to check the abnormal samples. Here I want to give you a explanation of what is the auto-validation rules. We have several checkpoints. The first is abnormal sample check, and we will also check the critical value. We will also check the parameter and flag, and check if the delta check is the abnormal range. And we will also check if the normal range is okay, and we will also have some manual review conditions. Only pass all of them can go to the auto-validation way. If any of them triggered, the sample will go to the re-exam condition, as we have just explained just now. Okay, in order to help you to better understand how the auto-validation rules work, here in the next, I will give you some explanation or examples to help you understand how the auto-validation rules work. Firstly, here we have 4 samples. 4 samples. The first sample is PLT 200. The second one is PLT 20. The third one is PLT 70. But the yesterday result is 72. The last one is the PLT 200. But yesterday the result is 100. Okay, first of all, let's come to the first checkpoint. If all of these 4 samples finish the test, and all of them have the result in the software, and all of them will go detail of these auto-validation rules. The first checkpoint will be the abnormality, to check if there's some abnormal sample, or there are some abnormal things happen in this sample. For example, abnormal aspiration, or abnormal RBC agglutination, or some aspiration happens, aspiration abnormal happen in the analyzer. If none of them trigger, okay, these 4 sample will go to the next step, the panic value check. This here we can see in the right side, the panic value criteria is PLT lower than 30 or upper than 1000. So here we can see the number 2, the sample number 2, PLT 20, already triggered the rules. PLT lower than 30. So this sample will go to the right side to go to the re-exam condition. And others, because none of them trigger these rules, these auto-validation rules, so they will go to the next step to check the parameter and flag. And in the parameter and flag check, the system will check whether the parameter results are within the corresponding validation ranges, and to check whether there is a special flag for any of the sample results. So the number 1, 3, 4, those 3 samples will go to this checkpoint, and here we can see this PLT 70 trigger the lower than 80, so it will go to the right side. Go to the right side to check the abnormal range delta check, and 1 and 4 will go to the next checkpoint to check the normal range check. And in the next checkpoint, the abnormal range delta check, here the number 3, because here we need to check the delta check. The number 3 delta check yesterday is 72, today is 70. So it is within the delta check criteria. So we'll go back to the left side because we think this sample, the delta check is okay. So it means that the result is okay for this sample. And then we'll go to the next checkpoint. to check the normal range delta check. And if those samples trigger the rules, we'll go to the right side. If not, we'll go to the manual, the final checkpoint, manual review conditions. Here we can see the number 4. Number 4, it triggers the rules, so it goes to the same condition. And number 1 and number 3 go to the next step. And finally, the final step is the rules to say the manual condition, manual review condition. Here we set up like the infant. If this sample is an infant, it needs to go to the manual condition, go to the exam condition. If it is normal sample, no, it will automatically go to the auto validation. And here in our examples, the number 3 sample, it is the infant condition, the infant sample. So we go to the re-exam condition. And the number 1 sample, because it didn't trigger any of the the rules here, so it means it passed all of our criteria. So the number 1 will be auto-validated. You can set up in this software after auto-validate, it will automatically send to the lead system. So the comprehensive and the complicated auto-validation rules can help the technicians to separate the normal sample and the abnormal sample. For normal sample, if most of your samples are normal sample, they will automatically validate without any manual intervention. And so they can spend more time in number 2, number 3, and number 4, and to follow the re-exam rules that we have explained just now, and to go to re-exam or microscopic. So this is how the auto-validation rules work. Okay, by using this LabEsper middleware, because this software is highly efficient, so we can solve the higher workload problem because we improve the efficiency a lot. And because we have the very sensitive flagging, so we can solve the second problems that happen in our customer side. And because our auto-validation rules, our our re-exam rules are very intelligent, so we can solve the problem that the lab short of well-trained technicians. And because we have the very good layout design, and if we comparing with other brands, our software is a very our UI design is a very good design and very intuitive. And the most important is our LabEsper, our middleware, is totally free of charge. It is standard configuration together with our instruments. And finally, I want to show you some reference sites which use our LabEsper and to show how our LabEsper help them to improve their efficiency. The first one is the Chen Laboratory Group, DASA group in Brazil. This is a top 5 Chen Lab group globally and the top 1 in Latin America. Here I just want to give you one example. There we install 2 lines, 2 Ki-1000 lines. They have the 8,000 to 9,000 samples per day. And before they are using 11 standalone instrument with 2 standalone slide maker and standard. And before they have 20 staff. But after using our Ki-1000 and LabEsper, they reduce their staff to 13 staff. And their re-exam rate, because we have the intelligent re-exam rules and the auto-validation rules, so they decrease their, previously they have 14% of their re-exam rate, but now only 3% for the re-exam rate, because some of them trigger the re-exam rules will automatically go to the re-exam. And besides, we have the smart flagging function. So some of them will avoid the false negative and false positive. This is the first reference that which use our LabEsper to help them improve the lab efficiency and decrease their staff burden. The second one is another big high volume lab. It's in Turkey. North PHU is the Public Health Union. Previously, they used 10 units of the standalone analyzer. Now they are using 2 Ka-1000. Before, the number of instruments, they have 10. Now they only need 8 units. Before, they have 8 staff. Here you can see they have staff work in every of the instrument before every of the instruments. Now they only need 2 staff here in the lab to run the sample to review the result. And the re-exam rate also decreased from 22% from 25% to 3%. This is also another example to show how our lab expert help the save the labor cost and to improve the lab efficiency. The last one is in the India reference site is a Gujarat Cancer Research Center. Now they are using our Ka-1000 and the sample volume is 1,400 tests per day. And before they are using 3 units of a standalone analyzer. Now we use our Ka-1000 to replace them. They also use lab expert and which also reduce the manual intervention. Okay, that's all for my presentation. Thank you very much.
Thank you, Shin. Dr. Suri, would you like to comment so that I can go ahead with some questions? There are a couple of questions for Shin. So I would like you to comment and we would go ahead with the questions. I think Dr. Suri is... So, Shin, there are a couple of questions from our audience. There is a question saying for a tertiary care hospital handling 300 samples per day, how much % of manual intervention can be reduced by your lab expert software?
Okay, as I have just mentioned in my PowerPoint, we have 2 very successful reference hospitals that they already use our lab expert to reduce their manual intervention rate from around 20% to now currently it's only 3%. So if, as you mentioned in your question, that a tertiary hospital that have 300 tests per day, I think their manual intervention rate will be around 5%. I think it will be okay. But I think this is just estimated. The real number, I think we should decide by the patient and the sample type. But my suggestion and my suppose is around 5%. Yeah.
Dr. Suri is online. Dr. Suri, is there any comment for?
I think I congratulate Dr. Shen for a wonderful, lucid presentation, high-end automation, and the examples he has given is just amazing. So I have nothing but to appreciate his talk.
Thank you very much.
Thank you very much.
Thank you, Dr. Suri.
So we have another question. Can we go ahead with that, Dr. Suri?
Yes, please.
Yes, sir. Thank you. So there is another question from Mr. Kiran K. Do you have any provision to check the sample integrity or quality in your software with respect to TAT?
Okay. About the flag that or you said the provision to flag the sample abnormality. Here we, as I have just mentioned in my PowerPoint, the software we have a flag called like aspiration abnormal or other abnormality, other flags to tag this sample that this sample is some quality problem, and if this sample trigger the time that trigger the TAT time in the sample list, this sample which we already trigger the TAT time will be listed in the first priority, so the technician they can review this sample in their first site. They will know this sample is top urgent.
Okay, one last question. They are asking, can we incorporate the software in other analyzers than Mindray, and is it possible to combine it with hemat chemistry and immunoassay?
Currently, the lab expert is only designed for the hematology between Mindray's hematology models and the lead system. And now, but actually, globally, we already cooperate with other brands regarding their digital morphology. It means the other brands' digital morphology analyzer they can integrate into our system, into our lab expert. For example, like the Television and other Visual Hema and other brands digital morphology, they can be connected to our lab expert. But currently, the chemistry and the immunoassay now cannot connect to the lab expert. But I think in the future, we will design our lab expert like a more powerful software, powerful middleware to connect all of the analyzers in the lab.
I think that's done with the questions. So I request, and thank you, Shin.
Thank you.
I
Thank you
request Dr. Handu to convey thanks to Dr. Suri, please.
Thank you, Shama, and that was a wonderful session. Thanks, Shin, for a lovely presentation with respect to the the way the lab expert is being used in the Mindray group of analyzers. And interestingly, your talk could actually cover some of the questions which kind of remained unanswered when I had finished my talk. Thank you very much for that. And thanks, Dr. Suri. It was really indeed a pleasure to have you with us on board, chairing this entire session and taking your time out on a Sunday and staying with us for so many hours and ensuring that the talks are kind of spearheaded very nicely by you. Thank you very, very much for your time and for your efforts, sir. And I wish you could continue and sit on the with us through the rest of the conference as well. Thank you very much.
Thank you. Pleasure is mine. Thank you, Dr. Handu, and thanks to Mindray. Thank you. Bye-bye.
Thank you, sir. Thank you so much for your time. And I have some instructions for the quiz, which I will display. Our quiz master is Dr. Geeta Vidyadharan from Amrita Institute of Medical Sciences. So she is traveling and she might not be able to connect to us. So she has made some instructions and she has made some quiz questions. Participants need to click on survey link to participate in the quiz. The link will be displayed and will be available only for 5 minutes on the screen. Participants are requested to fill in their contact details as it helps us to identify the appropriate winner. Check your answers once more before you submit the quiz, as there is no way of changing the answers once submitted. To submit your answers, simply click the done icon found on the top of the page. The winners will be declared based on the early entries with maximum scores. So all the best participants, and hurry up. The link will be open now. Go to the leaderboard section on the platform, click the link and move on. The link will be open only for 5 minutes. Please pay attention to that. Thank you.
What we have decided for the day today, between 2 to 2:30, when the actual session starts, we will just have a panel discussion, which ideally we could have had yesterday, but because of the paucity of time, we had to reschedule it for today. It gives me immense pleasure to introduce my panelists, Professor Dr. Sita Lakshmi, who we heard in the morning. As we all know, she's the head of hematopathology, head of St. John's Laboratory Services, and she's a professor and head of the Department of Transfusion Medicine and Immunohematology at the prestigious St. John's Hospital, Bangalore. She's one of those people, who has the MD and the PhD along with her, and of course, she's been recipient of lots of awards and donations. She has 60 publications to her credit in both national as well as international journals, and she has special interests in the field of hematology, transfusion medicine, molecular diagnostics, and blood coagulation. We also have with us Professor Dr. P.G. Subramaniam. He is a professor and officer in charge of the Hematopathology Laboratory at Tata Memorial Centre and ECTREC in Mumbai. I'm sure most of you would know him as an astute flow cytometrist, and he has been the past president of the Cytometric Society of India. He's been a recipient of the ICMR International Fellowship for the Young Biomedical Scientist, and his interests are also hematopathology, flow cytometry, and molecular investigations in the diagnosis and monitoring of hematolymphoid malignancies. We'll also be having with us Professor Dr. Ramon Simon Lopez. For those of you who would know him, he is in fact one of those people with Professor Nair who ensured that the cytomorphometry that we talk about today was actually, the seeds for this was sown between him and Professor Nair many years back in our country. He is the professor of lecturer of artificial intelligence in the University of Sweden, and he's an expert in the clinical and laboratory hematology, oncology, immunology, and immunotherapy, coagulation, blood banking, flow cytometry, and many other aspects with respect to the flow cytometry part of it. We will also be having with us Dr. Prashant, who we heard in the session yesterday with respect to iron states for hematology and hematology analyzers. Dr. Sharma has been a great friend. In fact, I have known him since the time he was here in Delhi and eventually moved on to become a faculty in PGI Chandigarh. Again, his interests are hematology. He has many research projects to his credit and is working prominently with very eminent national and international societies for this. He's also a winner of several national and international awards and for his work in hematology, and he's also the associate editor of the Indian Journal of Hematology and Blood Transfusion. So without a further ado, I think I'll just move on, and I hope all my panelists are with us. Has everyone joined us?
Yes, sir. Yes, sir. Everyone is there now.
Okay, good, great. So let me do the thing and start with the first question, and I think since Prashant was the one who actually started the RBC part of it yesterday, I will just take this question directly to Prashant and ask him, the question which I am posing to you is, how do you define flagging criteria thresholds for smear review for your hematology analyzer? While this is a question which is more generalized, I don't mind you talking predominantly about the RBC flagging part of it. Prashant.
Hi, Anil, and hello everyone. Good to see Ramon and Dr. Sithalakshmi, Dr. Subramanian again. Regarding the flagging criteria, well, I was involved with this exercise when we did the full thing most recently in the early 2010s, and that was because our LIS had undergone a major overhaul that coincided with the purchase of new instruments as well. So we started by looking at the guidance that was available from the learned societies. And there were formal layouts and paths that were available from various consensus groups, including one with Samuel Machen in the IGLH and another one in the Archives of Pathology. But we very quickly realized that the scenarios had to be very lab specific and locale specific. So that was the first major obstacle or first major realization that dawned upon us. And at that point of time, we got a bit lucky because Dr. Sukesh Nair came visiting for a conference here. And we requested him, in fact, to take 2 sessions on this topic. And he was nice enough to share the lower rules with us, and including how he went about validating them. And suddenly it became much clearer. For one, we realized that as a training institute, we did not have the severe dearth of pathologists that probably an equivalent large private center would have. And on the other hand, we had a dearth of technicians, which are very difficult to recruit. And then we also came across other obstacles because the Delta check and those things were, so suffice to say that the initial review and audience is still done at the level of the resident doctor at our center as far as the analyzer reports are concerned. And okay, so but going back to them, so we did the usual things. We looked at the action alerts, the critical alerts. We probably looked at our linearity limits very closely for the first time. I told you the Delta checks were a challenge because of accessing the LIS by the person who was on the machine because of the workloads on the technician, and therefore the sorting of which are the slides we made for a long time was with a resident doctor, the decision, and they had a set of rules which we then configured. We periodically reviewed the limits, but even so, our most, when we look back at it, most of our misses or faults, both positives and negatives, are more often due to a human oversight rather than an analyzer-based issue. Yeah, so that's how we went about the criteria.
Would it mean in that case that you may not be really using middleware to the fullest extent at this point of time, and predominantly a lot of it would be resident-based decisions or maybe technical-based decisions as well?
These are a set of slide review rules which are overwhelmingly about the numerical data, and for the flags you pretty much go ahead with the we don't spend too much time for them, we just go ahead with the slide for any of the significant flags that we decided for. Yes, that's okay.
And just to add a few more things for some of our residents who would be interested to know, what are the, because again, you had taken a session on our red cells yesterday. What would be various methodologies which might be available for red cells in our hematology analyzers? If you could just, briefly touch upon that as well.
Sure. So, as far as the red cells are concerned, the bedrock of cell counts and sizing remains impedance. In addition, light scattering can also give us counts as well as sizing, but also it gives us estimates of cellular hemoglobin content and its distribution, and it also helps in better discrimination of several things, say WBCs from analyzed RBCs and platelet counts. So light scattering is also a major player in the optical red cell counts in the analyzers that use them. And then there's fluorescence, which is obviously used in reticulocyte counting along with nucleic acid binding guides, but then would also give us the IRF, and it improves NRBC enumeration and enables fluorescent platelets and whatnot. And I think based on the today morning session, then I think in analyzer technologies, we must also include stellar vision and other image-based counts, but those are probably still making their inroads into Indian laboratories in a big way.
Yeah, thank you. I would like to pitch in here just for the fact that, the hematology analyzers predominantly will be using two methodologies, as we already know, the impedance and the flow cytometry part of it. And what I would be interested to know now from, let's take in Dr. Sita Lakshmi into picture and ask her about the fragmented red cell parameter. The question to this effect is, how sensitive do you think is this, and how good is this, its negative predictive value vis-a-vis a smear review in your experience?
Yeah, so good afternoon, and happy to be a part of this panel. Thanks, Dr. Anil. I think this is a question that troubles situation which troubles many routine hematology laboratories, especially in an active hematology center where we do encounter quite often the clinical setting of thrombotic microangiopathy, and it becomes very critical to give this information on time to the clinician. And this should happen 24 hours, 365 days. So yes, my laboratory being a teaching institute, and there are times where you will have only residents looking at the smear first, and I'm sure all of you will agree with this, that in the early part of one's career, and I'm sure all residents in every smear will report occasional fragmented cell, occasional schistocyte. You will find such descriptions throughout. So we all understand that smear review, if done by senior experienced hematopathologist, definitely has value. And very many times, this can be loosely interpreted if somebody who is not trained adequately sees the smear. Now, coming specifically to this question, how sensitive is a parameter of fragmented red cell on an automated hematology analyzer? To answer this question, I would say yes, it has a high sensitivity, and therefore it has a very good negative predictive value. So there are situations where the automated analyzer will give a percentage value, and then it is important to review the smear before we give a report. But when this analyzer gives a zero value or absence of fragmented red cells, yes, I would be quite comfortable to say that fragmentation of red cells is not there. So I mean to say that the negative predictive value is high, but if the analyzer gives a presence of fragmented red cells, it's important to review the smear because it is not very specific. And yes, all of us are familiar. Now we have the advantage of the ICSH guidelines which have come out, and I think our practices are more stringent towards interpretation of fragmented red cells, since a lot of it is based on objective guidelines that are available, and of course it's always in the clinical context. So I hope I've been able to answer this question.
Yeah, I think you put it very pertinently, and in the context of the ICSH, it has an absolute relevance. In fact, as you rightly pointed out, ICSH is very clearly mentioned in its recommendation and by the working group on these fragmented red cell parameter, where they have clearly said that it's got a very high negative predictive value. And though they have very importantly put a very nice caveat there and said that it's further research, and again determining the limits of quantitation would be extremely important in this particular parameter. Having said so, fragmented red cell, if it is negative on an analyzer and if you've optimized your flags appropriately, I think it's a beautiful parameter which can be exploited by centers like ours, as you rightly pointed out, with high throughput and high workloads. It's important and imperative on our part to ensure that we are utilizing our time appropriately. Thank you very much, ma'am. That was a very
one point that I missed out, Dr. Anil, if you permit me. What I want to also add is that once you have determined that fragmented red cells are present, and in order to quantify and follow up these patients, it becomes very useful on the analyzer. Because otherwise, depending on when a particular sample would come, and maybe the same person is not looking at the smear on repeated sampling, then in those situations, I find to report percentage, once we have determined that it's positive, it is very useful on the analyzer. I think this is something I have had practical relevance. Otherwise, there are times residencies, there are times the senior consultancies, and the percentages are not accurately reported. So in that context, I find it of great value. Thanks for allowing me to add on this.
Oh, thank you. That was a really nice add-on. And in fact, if I take this further now to Dr. Ramon, it's very interesting that this particular parameter, it actually comes from a very specific channel, which is the reticulocyte channel. And in fact, this channel per se seems to have evolved quite a lot in the last few years. And if we go by what Mindray has also come up with, then that is actually the optical RBC channel. And I'm sure Dr. Ramon has direct experience with this now. So my question to you, Dr. Ramon, is do you see a greater role of optical RBC counts in future? And could you add something specific to it with respect to what's happening on the Mindray front, in terms of the optical RBC channel per se?
Yes, absolutely. I think optical RBC counts will have a very important role in the future. Why? Because there is still a point that is missing in hematology. For example, how we detect the presence of spherocytes. Spherocytes, we know that in the, you can see a higher DW, high MCHC, but really these parameters are maybe sensitive, but very inspecific. And you don't have any way to detect the spherocyte, except if you see the optical RBC counts, in that you can see not only the red cells, but also the platelets, and to differentiate between them when they have similar size or similar physical features like fragments and platelets, that if you don't use optical platelets, will be very difficult to detect. But the spherocytes, for me, is the key. The key that will make that this parameter will be a standard for all the instrumentation. Maybe in the future, if you don't have this optical RBC, you are not going to apply a tender, because if you miss an hemolytic anemia or if you miss any case of spherocytes, that will be a challenge. What we are now working the companies is how to use the reflex testing, how you use that you have, for example, a high MCHC, that we know have interference with biochemistry, biochemical properties of the plasma. But even though you use MCHC, you use RDW, you use hemoglobin, and with this combination, you are going to reflex optical RBC and optical platelets for sure to help in this spherocyte detection and counting. And of course, after that, you can also see the reticulocyte count. That will help a lot. And that is, for me, the key for the future. Hyperchromic red cells, are the key for the use of optical RBC and the differentiation of fragments and red cells.
So there was one very interesting thing which I looked at with respect to the optical RBC channel. It's interesting to see that when you have infected red blood cells, you actually detect them in the WBC channel rather than detecting them in the RBC channel. And the reason primarily we all know is that they remain kind of unlysed and they are picked up in the WBC channel and you actually quantitate them there. My question is, when you go to the optical RBC, would it not be more pertinent to get a better counts or maybe a better sensitivity of this parameter from the optical RBC chamber itself? Do you see a role?
The presence of Plasmodium falciparum and Bvax and other forms of Plasmodium, the problem is they are different. And between the same parasites, it's not the same when you have a Plasmodium falciparum in the face of rings, that if you have the same problem in the presence of gametocytes, but because it's absolutely different too. The thing is, the more important is to have a technology that permits to detect these particles. For that, you need to have a three-dimensional analysis with a cube, if it's possible, to see because if not, it's just something in the bottom. But if you can rotate the cube, you can see that it's different, this image from Candida albicans, from lipids, from other particles that are in the similar. The possibility to rotate the cube permits you to see that. But what I have seen is the majority of the instruments that use similar technology, forward scatter, side scatter, fluorescence, can detect and differentiate Plasmodium falciparum and Bvax. But what happens? When you do the FDA or the training of the instrument, some instruments are made in a region in that they have only Bvax or only falciparum. That is a problem. When you are doing the training of the instrument, the capacitation of the instrument to detect, you have to be sure that you collect samples from different parts of the world, in that you collect different types of malaria. That is for me the challenge. But we don't have to forget false positive. How you can avoid false positive? If you see the patents, I patented myself the detection of malaria, but using leukocyte morphology. The higher standard deviation of the lymphocytes and the higher standard deviation of the monocytes is 99% sensitive for malaria, not specific. You can see also that with some other hemoparasites like Babesia. But if you combine the use of the population in the plot that normally is down in the bottom of the plot, but also you use the change in the morphology of the monocytes and lymphocytes, is when you can increase the specificity of the malaria. But again, you need to be sure in the evaluations that you have different types of hemoparasites, including Babesia, that you can give a false positive of malaria and not detect Babesia. Babesia is rare in humans, very frequent in dogs, but it's absolutely a must emergency that you need to detect it and treat it, because the patients die with a frequency of maybe 70%, 80%. That is for me the important point about the hemoparasites with hemocytometry. And for sure, today we are in the era of the PCR, which every laboratory, even a small pharmacy, have a PCR for COVID. But you can use PCR for tuberculosis, you can use PCR for BCR, adults and chronic myeloid leukemia. You can use a PCR for the detection of the different hemoparasites, including Babesia, falciparum, Bvax. For me, the future is to have a quite sensitive and specific flagging. You cannot spend a lot of time in tests, in polymerase chain reaction tests for all the malaria species, but that will be only in hematology the previous to a reflex testing with microscope for sure, that is the WHO standard reference method, and PCR, including quantitative PCR, to see if the treatment is working well, because we know that some malaria has been resistant now to the antipaludic, anti-malarian agents.
Right, thank you. I'll change a gear a little bit and I'll try and move back to Prashant and ask him a specific question, about unghosted cells. There seems to be a very interesting parameter Can you just elaborate a little bit about the utility of this parameter, if you really you have used this, or maybe an anecdotal one?
Yeah, cluster cells is somehow like artifact or things that you can find in hematology. And the thing is, you normally do this modification to permit to measure the cells in the instrument, and you can use that, interestingly, for the detection of spherocytes. This is one of the important rules, that is MCV minus MSCV, and that is the way also to detect a spherocyte. Normally, the spherification of the red cells have different physical mechanisms, and you can see when you try to spherify the red cells is when you see the difference between spherocytes and red cells that can have similar morphology, similar size. Is that what you asked me?
Yeah, that seems very right. Thank you very much. We have kind of paucity of time, but I'll just move on quickly to Dr. P.G. Subramaniam, and I'll quickly ask him a question, which is like, in fact, two questions together. One is with respect to the reticulocyte count reliability, and since you have in your system more than one analyzer and perhaps using this channel on both them, what would be your take on the reliability of reticulocyte counting on a hematology analyzer and its correlation vis-a-vis the manual counting that you have?
Ours is an oncology center, so we're primarily getting oncology samples, or not primarily, almost exclusively, with very little of other diseases coming in the sense that we are having two cell counters in our laboratory. One is the ADVIA 2120i, and the other is a Coulter DXH. So the reticulocyte count, we do get, we have been having, though despite best efforts, it has not been a very popular parameters with my clinicians, but recently I have got surprised because they want more of use of functional iron deficiency, which is creeping into almost all specialties. So they have started asking reticulocyte parameters more frequently now. The different analyzers are in the sense that an automated cell counter will definitely have a far better CV than doing it by the manual counts, and they work very much well in low reticulocyte counts. But the issue for especially standalone labs, which are, maybe I am in a better of circumstances, but which are not there, is the calibration of the reticulocyte parameters. So that's a very common issue which laboratories are going to face, because we are supposed to calibrate using a manual method as a reference, which is really not, unless you're going to have a set of high retic samples, your calibrations is not going to be very good if you're going to use it as a manual parameters, but it is what is best available and which is done. The reticulocyte, various analyzers use various technology for reticulocytes. So they are either, most of them are fluorescent based. Some, like the Coulter, use the new methylene blue as we use it in the routine manual method. So one thing to remember is that these methods are more or less comparable with each other, but there are small differences, especially when you use advanced parameters of reticulocyte, like especially the immature reticulocyte fraction is something which will vary between instrument to instrument. So there might be, but the variation is very less, as we don't really require that fine an interpretation most of the time for this. We will have to have our own yardsticks for normal. For the beginning, you can use what the manufacturer says as a normal range and see whether it works for your patients in your circumstances. So that's one thing which you'll have to do. The other is that the dyes have different behaviors and different advantages. So only thing is, since ADVIA, the Bayer, which was previously Bayer, has been the front runner in this RBC parameters, especially the CHR is what is now used as a relevance in clinical. So it is in a sense a very good parameter for assessing functional iron deficiency, as well as early detection, as well as monitoring post-treatment
of iron deficiency anemia. So it's in that way, it's a very good parameter to use. So CHR is one thing which we are there. The comparability wise, in general, there will be a comparability which will not affect clinical interpretation much. But if you are really going to go for what is going to be, whether two are going to be getting exactly the same value, then it will involve a certain amount of inter-instrument harmonizations. We also, we were lucky in the sense that we could do the calibrator using the ICSH reference method of thiazole orange and flow cytometry. So we have done that, but in the sense that it is very important that the machine drifts during operations. These can really take your calibration a little away. These are common issues which we face for a reticulocyte count.
Yes. Thank you. Thank you very much. Much that I would have loved to continue with the panel discussion. You know, we have kind of run out of time, and I don't want to be a, you know, an barrier between Dr. Ramon's talk. Is there any last
comment?
Yes, of course, sir. You can make.
It's just a small comment because I think it's important to point that. You know, I have had discussions in America with Dr. Carlo Brugnara. He was one of the first talking about the reticulocyte hemoglobin equivalent, CHR, etc. And what I want to make a point is what the doctor previous to me speak was really clear and true. Reticulocyte hemoglobin equivalent, CHR, is important to detect functional iron deficiency. But what I want to make a point is the treatment is not to give iron all the time. Because it's true that the reticulocyte hemoglobin equivalent is low in functional iron deficiency. You have low transferrin saturation, low serum iron, but in anemia of chronic disease and even in hemodialysis, ferritin can be high. And when the ferritin is high, even if you have a functional iron deficiency, not always you have to give iron. In this case, a reticulocyte hemoglobin content has to be complemented with ferritin, because if not, we have seen a hospital in Israel only using functional iron deficiency to give iron, and they got ferritins of 2,000, 3,000, and this is not necessary. Today we know that in hemodialysis, the erythropoietin is able to liberate the iron from the deposits if the ferritin is there, and thanks to erythroferron, takes the iron it needs for erythropoiesis, and you can correct the anemia due to functional iron deficiency only with erythropoietin if the ferritin is more than 150. But not always use. I am talking about now the clinical use of functional iron deficiency measured by reticulocyte hemoglobin content.
Thank you. Thank you very much. Any last comments from anyone? Otherwise, we'll just wind up. Okay, great. Thank you very much. Thanks everybody for being a part of this panel discussion. And we look forward to hearing Dr. Ramon's talk from now. Thank you, and passing it back to Shama. Thank you, Shama. And thank you, everyone.
Thank you, sir.
Hello. I have to thank you, the organization of the CUBE Aspire 2021 meeting, to invite me again, because it's always my pleasure to be with you all. Today, I have to talk about platelets and platelet accuracy and pseudothrombopenia. And for that, I have prepared a presentation for all of you. Let me share my screen. Okay. Platelet accuracy and causes of platelet inaccuracy. As we know, one of the more common causes for platelet inaccuracy is fragmented red blood cells that can interfere in the platelet counting. As you can see here in the center, there is an histogram of a case with fragments in that the red cells enters in the area of platelets, but we don't know if these are really red cells or platelets, and we don't know if this histogram falls here or falls here. The same for the platelets. We don't know if the platelets are here or these are also platelets. It's difficult. And to put a moving threshold or another systems that cut the edges will not be effective here. But as you can see here in the top, using optical platelets and the fluorescence channel also used for reticulocytes, you can see that the platelets are here in this area, here the fragments, here the red cells, and here the reticulocytes, and that really permits to count a very good count of platelets in presence of fragments. Also schizocytes, also presence of sickle cells, any red cell abnormality can be differentiated very well now with the actual technologies. Another possible reason for platelet inaccuracy are the cytoplasmic fragments of nucleated cells. We can see here a case of a blast with a fragment that is increased when you are giving chemotherapy, because the chemotherapy provoke apoptosis, and the apoptosis provoke that fragments of the cells appears as platelets, and many counters are counting these as platelets, but using fluorescence and optical platelets, these particles don't have nucleic acids, and the fluorescence is negative. And you can differentiate again these particles from platelets using optical platelets. Cryoglobulins, we have here in the right, center in the right, a case with cryoglobulins, and that can also interfere in the impedance count, but not using optical platelets. Bacteria or fungi, you can see here Diplococcus that can be counted as platelets, or fungi, and the spores of the fungi can be appearing as platelets. Another possible interference are lipids. Here we can see the blood smear of a case with lipids, in that you can see that these particles that can be different sizes can be confused with platelets. And that happens in patients in intensive care or with parenteral nutrition, that in that we can see that appears these lipids in the blood. Last but not least, severe thrombocytosis is a cause of the opposite, not thrombopenia, but thrombocytosis, in that some instruments don't count very well the platelets in the high value. Even if the operations manual say up to linear up to 1 million or up to 2 million, if we dilute the samples 1.3 or even 1.5 in counting of 1 million or 1,500,000, we will see that not many times when you dilute 1.3 or 1.5 and you multiply times 3 or times 5, you will not reproduce the first count. And that represents that there is a coincidence phenomenon that some 2 or 3 platelets appear as one because there are too much. And even if you use laminar flow, the platelets appear wrong, and this is a known phenomenon from the time of Wallace Coulter and the first automated hematology instruments. At the end, but also the more important and the more important or the more frequent causes of platelet inaccuracy are ADTA-dependent agglutination and platelet satellites. Here we can see the histograms of optical platelets, in that we can see the fragments, the lipids, how using the cube we can differentiate it very well from other possible interference. The presence of candida, that also again using the cube can appear as an abnormal pattern of erythroblast, that we can see that there is not the typical pattern of erythroblast. Also you have a flag for the erythroblast counting, and you can see also in the diff channel candidas, lipids. If you train your users, your lab technicians, if you have a poster nearby the instrument with examples of cases, that will help to detect this interference in your lab. But the important is when you use optical platelets, this interference, because these particles don't have nucleic acids, they are not counted as platelets. Now we are going to see the ADTA-dependent. ADTA-dependent pseudothrombocytopenia. Here we can see a typical histogram with platelet clumps, big platelet clumps, that really it's difficult to count very well the platelets because they are aggregated and they are not, when you see this histogram, these platelets are going to be wrong. First definition, ADTA-dependent pseudothrombocytopenia was described the first in 1973 by Schreiner. Some other authors talk about that, but officially, because this was a scientific article, that you define that when it's a false low platelet count. Pay attention to that. False low, lower than the good one. Not always thrombopenia, in the presence of ADTA, but also in presence of other anticoagulants. And the evidence of that is when you change the method, you use another anticoagulant, or you use another method, warming, or you mixing or adding substances, the platelet increase. That will never happen with a real thrombopenia, that the platelets increase after warming or after mixing, after adding any substance. For this reason, that is one of the confirmations, because you can find platelet clumps in case of a bad blood draw, in that there is really they initiated the cascade of the coagulation and really are normal coagulation phenomenon that will not be recovered after mixing, warming, and so on. And also you can see platelet satellites that we need to investigate in every case of thrombopenia, because platelets can be also around the neutrophils and is caused by the same phenomenon. Here we have a typical example of platelet pseudothrombopenia, in that the instrument first was running platelets by impedance, because the count in this lab have a rule that indicates optical method when the platelets are low, that it was activated, the channel, the sample was rerun, and was incorporated an optical platelet counting. And this optical platelet counting gave 198, corrected absolutely using ADTA, but using a Mindray instrument with all these technologies that we are going to see afterwards. The same sample with citrate, you see that the count with optical platelets was 253, but pay attention, impedance show a count of 217. Even with citrate, the platelets are lower than using optical. That represents that citrate prevents somehow the problem, are not 20,000, are 217, but it's not enough. Impedance with citrate is not enough. I think you need to use a special channel like that to avoid a thrombopenia, because if not, you are going to provide a not accurate result. And you can see the films of these two examples. The tube, ADTA tube, doing a blood smear from this tube, you can see the aggregates, and doing a blood smear from the citrate tube, you can see less aggregates, but pay attention, you can see a small aggregates of few platelets are not really nicely separated. That represents that citrate improves, but not always solves the problem. Now let me explain you about facts about platelet pseudothrombopenia. This is a topic that has been investigated for many, many years in my life. The first fact, it's in vitro thrombopenia mainly, not always, but mainly, and not in vivo. That represents that the patients that have pseudothrombopenia don't have clinical features of thrombopenia, don't have hematomas, don't have bleeding, epistaxis, hypermenorrhea, etc. It's only a lab issue. Second, how to detect it. You can review all the platelets that are less than 150, for sure, that will be better, but sometimes will require a lot of efforts in the lab. The consensus that I participated, gratefully, in was published in Lab Hematology, that we create a set of rules that says that when the platelets are less than 100, you need to review always in the microscope, even if you trust your instrument, even whatever. Is mandatory, and if you don't do it, you can be blamed, because these rules are published and are respected by many users in the world. That represents that every count less than 100 first time, if it's a known patient, you know that it's a pseudothrombopenia or chemotherapy or whatever reason, but first time you need to review in the microscope and to see what? To see if there are big platelets, if there are platelet clumps, if there is platelet satellites, etc., etc. This is the rule. Okay, another fact. There are real autoantibodies. There is no an artifact that the anticoagulant makes the platelet aggregate only. No, it is really, there are really autoantibodies against cryptoantigens. Cryptoantigens represents that are antigens that in the peripheral blood, the platelets don't show, but these cryptoantigens appears in presence of ADTA. ADTA modify the membrane shape and shows glycoproteins that were not shown before or were not shown in the same way. And that provokes that because there are antibodies against these cryptoantigens, you see the thrombopenia. But not only with, as we have explained, not only by EDTA, you can see that also using sodium citrate, and rarely by heparin, but also with heparin. We have seen cases that you have a thrombopenia due to heparin. But also recently, in 2015, there are cases in that is published platelet pseudothrombopenia by EDTA, but also immune thrombopenia. That represents that the patient have both, and that is an explanation that this is not just an artifact, because some patients have both. That represents that maybe it's like a previous step to have an ITP. Another important fact that you can see published in 2018 by Zhang, that in cases that all the anticoagulants provoke platelet aggregation, but when you collect the sample from the patient and immediately run in the instrument, there is no thrombopenia, you have to investigate the presence of von Willebrand disease type 2B, because it looks like this hereditary disorder makes a special platelet behavior that provokes this phenomenon. Another fact is the antibodies that produce PCTP are better at cold temperature. It's a cryoagglutination, and warming the sample is you always improve or avoid a little this problem. And as well as in platelet satellites or leukoagglutination, that is another phenomenon similar to pseudothrombopenia, that putting the sample, warming the sample, you reduce the phenomenon. Another fact is this pseudothrombopenia is time dependent. The kinetics of this aggregation, it's very interesting. You can see this article from Lin et al. In 2015, that the manual platelet counting was 146. But if you see the counting by impedance in ADTA, after 10 minutes of the blood draw, the platelets were 109, lower platelets than the manual. But in 1 hour, they fell to 63,000, in 2 hours, 54,000, and in 4 hours, 50,000. That represents that during the time, the aggregation increases and the platelets goes down. But also with citrate, citrate is higher, not as higher as the good value, that is 146, it's 139, but it's not perfect, better. And you can see that after the time, also they decrease with citrate, 139, 102, 98, and 91. And that is an interesting feature to understand that it's not only ADTA, it's also a citrate problem. And here, the graphs of these cases, that we always like to see the Blotter-Smith, not only the numbers, because that shows you really the fact, and you can see it to believe. And you can see here how the platelet clumps are also observed in citrate, even after 10 minutes. But in 1 hour, the aggregates are bigger, bigger, and bigger. And you see the impedance with ADTA aggregation in 4 hours is amazing, and 2 hours too, and in 1 hour too. Another fact, ADTA dependent in vitro platelets decrease causes thrombopenia, but also lower platelet counts without thrombopenia. What that represents, that you can find wrong platelet counting in patients with 200,000 platelets, 250, because the patient don't have 200 or 250, have 400, 500, and the real count is lower than the count that reported. And not only you can detect inaccurate platelet count also with normal platelet counting. We will see after one evaluation that they selected random samples running 2 methods to see that, okay? And that is important to know. Another fact is the frequency of pseudothrombopenia. That there is a lot of different opinions because some people underestimate the pseudothrombopenia. But what is quite clear is that the frequency of pseudothrombopenia in outpatient lab, ambulatory outpatient labs, is from 0.13 to 1%, and in the hospitalized patient from 1.26 to 2%. For that reason, also what is a consensus is in hospitalized patients, the frequency is higher. We are going to see after why. And another fact is few platelet clumps can be seen in up to 10% of all the samples in the lab. How we know that? Because in the same study we did to create the rules of validation we did that in the ICSH and ISLH, that we selected samples randomly from the lab with no any criteria, and we observed all the slides in the microscope, even if they were normal. What we found is 10% of the samples have small platelet clumps, and some of them have big platelet clumps, and they were pseudothrombopenia. But ADTA is not a perfect anticoagulant. Many patients have maybe a difficult blood draw, and that is a fact. If you are pure, you will see that you find some platelet clumps in 10% of your samples. Another fact in pseudothrombopenia is there are some substances published in 1988 and in 2012 that amikacin, kanamycin, aminoglycosides can prevent or dissociate a little if you add it to the ADTA tube very soon, before half an hour after the blood draw, can help to eliminate this problem. Theophylline may prevent and dissociate dependent low platelet counts due to pseudothrombocytopenia. But recently, by LIPI, buffered sodium citrate, lithium, calcium chloride, ammonium oxalate, ticlopidine, sodium fluoride, they have checked a lot of substances, acetyl salicylic acid, antiplatelet agents, also potassium acide, also prevent or dissociate the pseudothrombopenia. Another fact, the platelet satellites is the same type of interference or artifact due to antibodies against cryptantigens, and you can see that this picture, beautiful from this article from Freire, that the platelets go around the neutrophils and you have an abnormal low platelet count. And that is interesting to know. But it's not well known, but also you can find as ADTA-dependent leukoagglutination. And that was described, and I saw the slide because I was there in the Mayo Clinic with Robert Pierre, that they found a patient, and after they published this case in American Journal of Clinical Pathology, they all, and Robert Bernard Prey, they published this case. After I saw another case, only one in my life, by myself, detected in France in one evaluation of one instrument around the end of the last century, in 2000, 1999, I saw a case in France, okay? Not very frequent. But again, if you warm the sample, if you mix the sample, if you add aminoglycosides, you prevent or dissociate this local agglutination. Another fact, certain anticoagulants has been proposed to avoid PCTP. One is very old, magnesium sulfate. There are studies in 1934 in that they published that magnesium sulfate is one of the best anticoagulants for platelets. But also citrate 3-pyridoxal phosphate can also, if you anticoagulate the samples with that, you can prevent the presence of platelet clumps. But they are expensive. And that is the article I have mentioned before. Look here, this is a study in that they were collecting the samples using magnesium sulfate or ADTA. Same sample with two anticoagulants. And you can see that using ADTA, you have the counts in blue, in this rhombus blue, and with magnesium sulfate in these squares in red. Look, the first case. With ADTA, 300,000, with magnesium sulfate, 470. What happened here? This patient can have essential thrombocythemia, and you are misdiagnosing this essential thrombocythemia if you report 300,000, and you are going to avoid to detect one disease, maybe because that. Not always provoke thrombopenia, the pseudothrombopenia. And here another case, 230, after using magnesium, you have 330. Another 130, 260. Another 120, 360. You see, there are several cases here. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 in 44, about 21% of the cases that have this wrong platelet count don't have thrombopenia. And that makes us think what we have to do to avoid this inaccurate platelet counts due to this phenomenon. We need to review our our thoughts, and maybe to reflex testing when the histogram of the platelets is not nice, or when we see the possible aggregates in the diff channel. We, the companies and the users, we need to work to avoid to release wrong results due to lower platelet count without thrombopenia.
Another interesting fact that I have been followed up till many years ago, in 2001, because I saw this article in 2001, 2002, Bragnani et al. Published it in Minerva. They published that they were consecutive collecting cases with pseudothrombopenia and looking for the diseases they have. And they found that 24% of the patients with pseudothrombopenia have solid tumors, 19% have myeloproliferative or lymphoproliferative disorders, 11% have autoimmune disorders. And that represents that the pseudothrombopenia maybe is not only an artifact, it can be a symptom. Again, in another article published in 2018 by Zhang, they did similar, but with more cases, and they found also that patients with pseudothrombopenia, 69 have cancer, malignant neoplasm, liver diseases, infections, hematology consultation 20, autoimmune disorders 12, and that represents that we need to consider, as we make this mention, that ADTase-dependent pseudothrombopenia has to be had in account and may be obligated to do a checkup or to exclude other related pathology or a disease in a patient that maybe have not related that they have any diagnosis yet. What is the solution of Mindray for this problem? They have been investigated for many years, this situation. And Mindray has developed several methods to eliminate the platelet clumps and to deaggregate them. They use three basic methods. One of them have several methods inside. The first is to warm the sample, and they do that in the chamber. They count the platelets. Second is they are adding the aggregation agents, several ones, in order to dissolve these aggregates. And third, they do high-speed mixing, but without changing the morphology of the sample of the cells. Okay. And here is what happened normally when you are not doing anything, that the patient becomes activated and after aggregated and provokes the pseudothrombopenia. But if we can see here, this is an schematic platelet with this rectangle, that is representing the platelet, in that you can see that there are three main pathways to explain the pseudothrombopenia. One is the tyrosine kinases pathway. The second is the calcium ion channel. And the third is the glycoprotein 2B3A channel, a part of the problem that is more an antibody antigen reaction. And here we can see the three pathways and how the Mindray is using several reagents to eliminate this calcium ion channel, or the GP2B3A channel, the glycoproteins, and the tyrosine kinases channel. These factors act solving this problem, and some of them contain several substances. The first factor 1 and 2 gets partial deaggregation, and the factor 3 gets complete deaggregation in 98% of the cases in that you apply this method. And that is published in several articles. In this one that was published in Translation Cancer Research, you can see in blue the graph of 23 patients with the platelet count in blue, you can see here, and in red, it's the ADTA tube, but using optical platelets with all these methods, that you can see that is very similar than citrate. In some cases, as here, citrate was, optical platelets was even higher than using impedance, but with the same ADTA, but using citrate, using optical platelets with ADTA was higher than using impedance with citrate. That represents that this method from Mindray solved the problem in the majority of the cases and is similar, but in my opinion, a little better than citrate. And that are examples of evaluation that was done by a customer comparing the Mindray channel, optical channel, with another company, in that you can see that in one instrument using impedance or platelet F, the count was 14 and 38, and using the optical channel from Mindray was 253. And here you can see the cases with the screens recorded. And here you see another case in that the platelet F impedance was 52, impedance from Mindray was 39, platelet F was 98, but optical platelets from Mindray was 390. Using citrate, the count was a little, higher than using impedance. For this reason, even with citrate, using impedance, that is the method that many labs use, they ask for another tube with citrate, you have 276, but using optical platelets with citrate tube or optical platelets with ADTA, you have a higher result than using citrate with impedance. And that is what I said. It gets similar results than citrate, but even better than citrate using the optical channel in impedance or citrate tube. We need to consider that if you use citrate, you need to, we know that, apply a factor, in this case was 1.1, to get the dilution of the sample with the citrate. That is the problem, how much represent the problem in time. That is the schematic published by Zhang. What represents to have pseudothrombopenia? You need to recheck immediately, other anticoagulants, warming the sample, recheck. That is costing time. That also was measured in the top. It was 45 minutes for every case with pseudothrombopenia. And if you reflex with the optical method of Mindray, only 1 minute of time lost. That is really not relevant. And also, of course, the patient will be happier because they will not have to have another redraw, and that is important. And then also nurses will be also happier. Mindray platelet accuracy. Mindray have been working also in other aspects. Of course, using optical platelets, you can differentiate red cell fragments, lipids, whatever, but also you can have IPF, reticulated platelets. That is very important, as we will see afterwards. Also here, you can see the fragments, how we can differentiate that, but also there are other improvements. Now, Mindray counts the platelets from 2 femtoliters, before it was 5 femtoliters. For this reason, that is a big improvement in the BC 6800 plus, because some of the platelets are even lower than 5 femtoliters, and that with that, the platelet count is much more accurate. Another thing, we know that doing in thrombopenia, when you repeat the sample several times, the coefficient of variation sometimes is not very good. But when you run several counts and you get the average, you improve the coefficient of variation. That is an automatic mode in 6800 plus, that when you can set up a rule that every platelet count less than 20,000, you can run 8 times automatically the platelet counting, and you are going to have a much more accurate count. The instrument has been introduced last time, 7 new parameters that are reportable about platelets, and one of the more important is IPF. IPF is really a parameter equivalent to reticulocytes for red cells. Reticulated platelets are the younger platelets after they come from the megakaryocyte, and they are, for this reason, considered young platelets, similar than reticulocytes, and permit to see if the thrombopenia is central or peripheral thrombopenia, if the body is not producing enough platelets or the body is producing normal platelets, okay? Good. The major platelets don't have these nucleic acids that can be stained with new methylene blue or with a fluorescence dye. Here we can see how the IPF is obtained. We can see the small platelets, we can see the normal platelets, adult platelets, and here we can see the young platelets as a percentage of the total platelets, that is the IPF. The reference values of IPF we can find in the literature. Here I made a search of different values by different authors. Okay, you can observe that, and you can find it too in the PubMed. And it has been described many applications for IPF. Differential diagnosis of thrombopenia, how to detect myelodysplastic syndrome, because also we can observe ineffective thrombopoiesis, the same that we can find an ineffective erythropoiesis with high IRF and normal retics, or high IPF and normal or low platelets. That is useful for the diagnosis of myelodysplastic syndromes. IPF is useful for preeclampsia, for bone marrow stem cell transplantations, to see the engraftment, if the bone marrow was successful. In thrombocytosis, differentiating reactive from malignant thrombocytosis. In the liver diseases, in platelet transfusion, to decide when to transfuse and if the platelets are going to be recovered the next day. That is an important information to decide to do a platelet transfusion or not. In coronary artery diseases and in thrombosis, it's important because IPF is also higher in the patients with thrombosis, and that can help to diagnose it and also to see the response to antiplatelet drugs. Also, it's important for the diagnosis of infections. Dr. Boro, Dr. Gini, as many others, has seen that IPF comes higher 1 or 2 days before the sepsis, and that permits to prevent, of course, with double check in your hospital, but that hypothesis shows that we can maybe act 1 or 2 days before the sepsis is there and to avoid many deaths because of sepsis. The future of platelet analysis. Okay, we are working hard now in the combination of MPV, optical MPV, IPF, MPM, MPC, that looks very promising pathway to differentiate between large activated platelets in thrombosis that are big with high MPV, large dysplastic platelets that are degranulated but are not young and not activated because thrombosis, and large hematoplatelets, and that it's also important. Also, we will include some cases of hereditary macrothrombocytopenias to see there if we can help to differentiate them. That is what we are working with. And of course, in addition to the reportable parameters, there are some 7 parameters that are laboratory use only, that represent that we can use it to detect disorders in the lab and after confirmed with approved methods. And we have today 15 new parameters related to platelets. That gives us a lot of opportunities to do ROC curves, to do logistic regression, to see how we can combine them to detect the different causes of thrombopenia, thrombocytosis, myelodysplasias, everything that pathologic that affects platelets. Conclusions. Platelet accuracy is very important in laboratory hematology. There are many causes that can be detected observing the scatter plots and educating the lab technicians. ADTA pseudothrombopenia is the most common cause of platelet inaccuracy and can be prevented in many cases using new technologies and reagents. IPF is a new parameter derived from the reticulocyte and optical platelet channel. And as reticulocytes are very important for the anemia diagnosis, IPF is being considered as a very important parameter for the diagnosis of thrombocytopenia and thrombocytosis, but also in coagulation disorders, in thrombosis. Other applications of IPF looks promising, as I said, its use in thrombosis and infections. Thank you for your attention. It was my pleasure to attend again to the CUBE meeting.
Thank you, Dr. Ramon. Dr. Ramon, I would like you to stay there. At this moment, there are no questions for you in the chat box either. So I would like you to stay there, and I would like you to introduce the next speaker.
Okay, now let me introduce the next speaker. That will be Dr. Rohit Kotipalli. He is from the GSS Medical College and Hospital in Mysore, and he has done his undergraduation from Amata Medical College in Telangana. He will talk about IPF utility in COVID patients. Welcome, Dr. Rohit Kotipalli. We are pleased to listen what you are going to say about that.
Very good evening, everyone. Today, I'm going to discuss about utility of immature platelet fraction in COVID-19 patients. I myself am Dr. Rohit Kotipalli from Department of Pathology, JSS Medical College and Hospital, Mysore. So, coronavirus disease or COVID-19 is a global pandemic causing morbidity and mortality in the affected patients. The disease symptoms can range from mild respiratory infection to multi-organ dysfunction syndrome and a fatal respiratory failure. Hematological abnormalities play an important role in prognosis and treatment outcomes in COVID-19 cases. The hematological abnormalities associated with COVID-19 include thrombocytopenia, prolonged prothrombin time, elevated D-dimer, and fibrinogen degradation products and microangiopathy. Increased D-dimer levels are associated with short-term mortality. The conventional coagulation parameters of intensive care units in COVID-19 patients were significantly higher than those of non-ICU patients. There is also high incidence of venous and arterial thrombotic complications in COVID-19 patients. These complications include acute pulmonary embolism, deep vein thrombosis, ischemic stroke, myocardial infarctions, and systemic arterial embolism. So understanding these hematological complications in COVID-19 patients become very important to assess the patient's clinical outcome and treatment. Thrombocytopenia, along with increased thrombotic risk, raises the possibility of platelet hyperreactivity in some patients with COVID-19. So detection of this thrombotic risk in COVID-19 patients can help to plan their further treatment. So what are immature platelets? Immature platelets or reticulated platelets are the youngest component of circulating platelet pool. They are analogous to erythroid reticulocytes, which are larger in size, have high dense granule content. These immature platelets have greater ex vivo reactivity profile in response to agonists due to the cytosolic mRNA, which is more transcriptionally active compared with mature non-mRNA containing platelets. These immature platelets are more prothrombotic and hyperreactive. They have greater predilection for thrombus formation, and increased levels of these reticulated platelets have been associated with high platelet turnover. So now that we have understood about immature platelets, how do we measure these immature platelets? Immature platelet fraction and immature platelet count. Immature platelet fraction is an automated assay that correlates directly with the reticulated platelet levels. It is evaluated by flow cytometry principle using conventional hematology analyzers. IPC is calculated by multiplying this immature platelet fraction with the total platelet count. Immature platelet fraction has been used as an independent predictor for major adverse cardiovascular events and response to antiplatelet treatment in patients with coronary artery diseases. Whereas immature platelet count has been found to be the strongest independent platelet-derived predictor for antiplatelet response to thienopyridines. Immature platelet count is also shown to be strong independent predictor of major adverse cardiac events in patients with coronary artery diseases. So with these in mind, we have devised a study in our institution, and our aim of the study was to assess the immature platelets by measuring IPF levels and immature platelet counts in patients with COVID-19, which is the study group, and compared to the two control groups. One control group is the group with cardiovascular risk factor, CVRF, and the other group is the group without cardiovascular risk factors, that is the stable cohorts. So study design, it is an observational case control study comprising of consecutive patients with COVID-19 study group and two control groups, CVRF and stable controls. The study duration, it is from April 2021 to June 2021, a total of 3 months. There were no exclusion criteria in the study. The study location is the Department of Pathology, JSS Medical College and Hospital, Mysore. So the methodology of the study was blood samples of COVID-19 positive patients, that is RT-PCR positive cases, and two control groups were studied at the time of admission. Complete hemogram and immature platelet fraction from all the samples was analyzed using Mindray BC 6200 fully automated hematology analyzer using the optical fluorescence, that is reticulocyte platelet channel in the machine. The statistical analysis, categorical variables were described as frequency rates, and percentages, continuous variables were described using median and interquartile range. Continuous variables were compared using Mann-Whitney test, and the statistical analysis was performed using SPSS software 26th version by IBM. For comparisons, a two-sided alpha of less than 0.05 was considered as statistically significant. So these are our results. The first table, we describe the demographic data, where the median age of COVID-19 group was 51 years, median age of cardiovascular risk factor control group was 63 years, and the median age for stable control was 40 years. And in COVID-19 group, 58% of cases were males and 41.1% cases were females. In the cardiovascular risk factor group, 58.16% of the cases were males and 41.84% cases were females. In the stable control group, 57.7% of the cases were males and 42.3% of the cases were females. The next table enumerates the comorbidities in these groups. In COVID-19 group, diabetes constituted about 24.6% of the cases. Hypertension has been recorded in 17.2% of the cases. Coronary artery diseases are seen in 6.1% of the cases. Chronic kidney disease is seen in 1.7% of the cases. And in 50.4% of the cases, there were no comorbidities in COVID-19 group. In the cardiovascular risk factor control group, diabetes constituted the highest percentage, that is 60.3%. Hypertension constituted about 44.7% of the cases. Coronary artery disease was seen in 23% cases. Dyslipidemia was seen in 0.7% cases. And chronic kidney disease was seen in 0.7% of the cases. In this slide, we'll be determining the laboratory findings at the time of admission. The red blood cell count was 4.52 million in COVID-19 group, 4.24 million in cardiovascular risk factor group, and 4.5 million in the stable control group. The hemoglobin was 13.1 grams per deciliter in COVID-19 group, 11.6 grams in cardiovascular risk factor groups, and 13.3 grams in the stable control group. The WBC count was 5.99 thousand in COVID-19 group, 10,000 in cardiovascular risk factor group, and 8.5 thousand in stable cohort group. The platelet count was 2.15 lakhs in COVID-19 group, 2.5 lakhs in cardiovascular risk factor group, and 2.55 lakhs in stable control group. The next slide in the results, we'll be seeing the IPF and IPC values. The IPF percent in COVID-19 group was 3.5%. Cardiovascular risk factor group was 3.6%. Stable control group was 2.4%. The p-value of less than 0.001 was obtained between the COVID-19 and stable control group. The IPC count was 7,000 in COVID-19 group, 7,000 in cardiovascular risk factor group, and 6,000 in stable control group. P-value was significant between the COVID-19 versus stable control groups. So these are our results. The IPF percent on admission was higher in the COVID-19 group, that is 3.5%, versus 2.4% seen in the stable control group with a p-value of less than 0.001. Similar levels of IPF was observed among the COVID-19 and the cardiovascular risk factor control group, that is 3.5% and 3.6% respectively, with a p-value of 0.271. The immature platelet count on admission was higher in the COVID-19 group, that is 7,000, versus stable control group, in which it was 6,000 with a p-value of less than 0.001. The IPC on admission was similar in the COVID-19 group and cardiovascular risk factor group. In either of them, it was 7,000 with a p-value of 0.880. In the discussion, the main findings in our study were COVID-19 patients have high levels of IPF and IPC at the time of admission than the stable control groups. IPF and IPC values are similar in COVID-19 patients and control group with cardiovascular risk factors, which are prone to be associated with enhanced platelet turnover and hyperreactive platelets. Continuing the discussion, acute illnesses have increased platelet turnover and enhanced thrombopoiesis. Enhanced platelet turnover will result in more circulating immature platelets. Due to the increase in the baseline IPF and IPC in COVID-19 patients to the stable cohort, we can imply that these circulating immature platelets can cause thrombotic events in COVID-19 patients. Cohen et al. Have conducted a study and stated that the baseline and maximal IPC values were higher in COVID-19 cases compared to their control groups. In our study, we have noted that the baseline IPC values were higher than the stable control group. And similar values of IPC were seen in both COVID-19 patients and cardiovascular risk factor control groups. COVID patients, particularly severe cases, are prone to have increased incidence of venous thromboembolic events. As a result, venous thromboembolic prophylaxis is recommended in these patients for the treatment of COVID-19 cases, provided that there are no comorbidities. Additionally, arterial thrombotic events, consumption coagulopathy, and thrombocytopenia make the treatment decisions more challenging. The identification of biomarkers that could predict the disease severity and prognosis are essential to plan the further care in COVID-19 patients. IPF and IPC can be used as a helpful tool, which is a direct measure of percentage of immature platelets in the circulation. Immature platelets are more prothrombotic, hyperreactive, and have greater predilection to the thrombus formation. IPF has been used as an independent predictor for major adverse cardiovascular events and response to antiplatelet treatment in patients with coronary artery diseases. Similarly, IPC has been found to be the strongest independent platelet-derived predictor for antiplatelet response to thienopyridines. IPC is also shown to be a strong independent predictor of major adverse cardiac events in patients with coronary artery diseases. So in conclusion, increased levels of IPF and IPC were seen in COVID-19 patients in comparison to the stable control group. IPF and IPC levels were similar in COVID-19 patients and control group with cardiovascular risk factors. So, COVID-19 patients have enhanced platelet turnover and reactivity. Further studies and research emphasizing the mechanism of elevated IPF and increased risk of thromboembolic events in COVID-19 patients are required, which can help with the treatment opportunities in COVID-19. And additionally, it can help to categorize these patients at higher risk so that they can be intervened at an early stage. Thank you so much. So these are our references to the study we have used. I would like to convey my special thanks to my guide, Dr. Asha, and our head of the department, Dr. Vijaya ma'am, professors, and my friends from the Department of Pathology, JSS Medical College and Hospital. A special thanks to my mother and father for all the support in my journey so far. Thank you very much.
Dr. Rohit?
Yes, sir. Can you hear me, sir?
Kotipali, I have a question for you. I have been follow up patients with COVID, and I have seen MPV and IPF maybe it's higher before the cytokine storm. Have you checked your database to see if 1 or 2 days before the cytokine storm, in that platelets fall down, RDW increase, hemoglobin decrease, have you seen if IPF can be a predictor of this cytokine storm?
Sir, first thing in our study, sir, we didn't monitor the patient seriously. We took only the baseline values at the time of admission. And whatever we observed at the time of additions, we have included in the study, sir. But we have restricted ourselves to IPF and IPC counts. So MPV values and hemoglobin fall, we didn't take into consideration, sir. We'll look into it, sir, in further cases. We'll just look into this, as you have mentioned, sir. Thank you very much.
Okay, and the other question is, have you found a correlation between IPF and D-dimer?
No, sir. We haven't included other parameters such as D-dimer, fibrinogen and all, sir, and PT-APTT due to the time constraint. So we are planning to include this in the further continuation part of the study, and definitely we will try to follow it, sir.
Perfect. Thank you so much.
Thank you so much,
Thank you for the inputs, Dr. Ramon. Thank you, Dr. Rohit. So we move ahead to our next speaker.
Yes, let me introduce Dr. Ashifni Sengupta from the Medical Hospital in Kolkata. She is MBBS from Grand Medical College in Mumbai and MD from Lokmanya Tilak Municipal College. She has the primary responsibility is to monitor overall operations and quality of on the lab. Also, she is practicing as a pathologist in all sections of the lab, including hematology, clinical pathology, etc. And she is predominantly working in breast oncology and hemato-oncology with additional work in liver and gastrointestinal pathology and so on. Thank you. Dr. Sengupta, is your floor. The floor is yours.
Thank you, sir, for that kind introduction. Very thankfully and a very good afternoon. It's afternoon over here. So thank you for that. I think I'll go straight to my presentation. I'll share my screen. Yes, my talk is on a paradigm shift in hematological parameters in serious COVID patients. I'm from Kolkata, and I'll be talking predominantly of the geographical distribution and the hematological parameters in serious COVID patients. I have just used a subset of the COVID patients who have been serious with and admitted in medical super specialty hospital. This is my hospital, which is a super specialty hospital in Kolkata, a flagship hospital with many more in the rest of the so I'll be showing the geographical distribution is West Bengal now. As compared to the first wave, in the second wave, as this comparison shows, the first wave, the COVID cases, we had a steady number of cases, but it formed a great plateau as compared to the other places in Kolkata, like the other 4 metro cities, and overall in the states also, West Bengal was far down in the least in the first wave. But it's in the second wave, which maybe because of the political processions and festivities, for in short, COVID inappropriate behavior, which has led to this surge in the cases in West Bengal. Of course, the first case was started in Kolkata on March 2020, and naturally it has always spread from the urban to the rural areas. So it predominantly talks about the cases in Kolkata. My hospital, medical super specialty, has also infrastructure wise made changes to incorporate all the surge that was there, and for a few months it was a exclusive COVID hospital. From first wave, where there was an initial spatial spread was much later, with the West Bengal average being 0.6 as compared to even Indian overall average of 0.8 to world that time was much higher, 1.3. But during the second wave, West Bengal took over with the rise of the new mutant, that is B1618, along with the double mutant variant, which was already prevalent and which was a major component which formed the 90% cases registered for the peak. And at its peak, it had almost 33% positivity. in the general population, in our hospital, in the total number of cases, we were getting a positivity of almost 60 to 70% of the total number of tests being done in our lab. And but the COVID infection rate that time nearly, as compared to its previous 0.4, that time the rate shot up to 1.36. So, but by June, the cases started declining, and even now we have cases, but then it is much less than, has come down to less than 10%. Probable reason and also was because of the rapid testing, which was initially not as much, but with the second wave, there was increased testing modalities made available, also infrastructure changes made by the different hospitals, one of which is our hospital, who started the testing almost in prior, and also made infrastructure changes with annexing of more places to isolate people as well as to treat COVID patients, bringing in infrastructure changes also to incorporate serious patients. Because it's a tertiary care hospital, we had a lot of critically ill patients coming in, also from the district areas. So this is a retrospective study of all the critical ill patients and those on who required stay for more than 7 days, also those who required ventilation support and also ECMO support. The criteria, of course, were that of respiratory failure, shock or other organ failure associated with that. So all those mild, moderate cases were not taken in this scenario. We are compiling and collating even more data to further increase this study and publish this further. So in this study, we have taken the hematological parameters, were analyzed on the Mindray 6800 with and then compared with all the inflammatory parameters for the severity, that is CRP, LDH, ferritin, and of course the coagulation parameters of all the parameters of D-dimer, PT, APTT, and these were not just once, but as and when the patients had to be managed, it was dynamically done over in the hospital. Almost 90% of the patients had comorbidities. Predominant of that was hypertension and diabetes, but quite a few had CKD and even heart disease. And the age distribution that we saw as compared to the first wave, the second wave, we saw that the age parameters were quite different. In the first wave, we had more elderly patients coming in with so the average age was around 72. But in the second, the major problem that we saw was quite a middle-aged people and younger people coming in, with the average age being almost 45 years. And also similarly, more than 60 years, the patients were almost from the bulk of the first wave, while in the second wave, they were quite low in number, almost 15%, because probably there was a massive vaccination drive, which has been fruitful in bringing down the numbers in the elderly patients. But it was the younger patients also. I think the factors that have come must have been responsive is that it was the younger population who is more mobile, more involved in the political processions and festivities and all those. So they were probably the mobile population, which probably resulted in this kind of a age distribution. Regarding the gender distribution, it is worldwide known and so similarly seen. That is, males were the predominant population, of course, but in the second wave, definitely there were more females being involved compared to the first wave, that we saw that even though males still had to take the brunt of the major The WBC counts that we have, this has been taken from the start of the admission, because we know that daily counts of the WBCs have been done for the patients when they have come. Some have been in the hospital and then been there. Some have shifted from other centers and come into our referral centers. So these were the most of the patients were having leukocytosis this time in the second wave, as compared to that of the first wave, where only 1/3 of the patients, almost 32.6% patients, showed leukocytosis as a presenting symptom. Most of the patients had normal counts, and but in the second, we saw that it was leukocytosis predominantly, maybe because of the longer stay, as well as these patients were already severe with severity. Leukocytosis has been developed, and leukopenia as a presenting feature was not there much, especially in the second wave, though it was slightly more as compared to the first wave, where leukopenia was seen on admission, but predominantly that was not a presenting feature as when the patients were admitted, but they later on tend to develop it as and when the progress of the state is further. Regarding leukomoid reaction, this is a particular finding that we have seen more in this time, probably because of the peak or more number of cases, and also maybe the use of steroids and other medications prior to even the critical illness that was there. So in the earlier first wave, we saw that almost 7.7% cases showed leukomoid reaction, that is more than 30,000 count. But in this particular wave, the data during the peak surge of the cases, nearly 32% cases had leukomoid reaction. This could be because of the increased use of steroids and other, also management of the patients in the other hospitals, could also be septicemia induced coagulopathies. That could be the major reason for this. Many of them, of course, were non-survivors. Almost 90% of those who had leukomoid reaction were non-survivors, and 1/3 of them even had 1/3 of these total people, persons or patients having leukomoid reaction, had count even more than 50,000. In fact, one patient had a count shot up to more than 1 lakh, triggering it. But then, of course, the count then came down later. Regarding eosinopenia, almost 100% of them had eosinopenia on admission, which was recorded seen from the records earlier or after the patient has been shifted over here, with the average with the on admission eosinophil less than 0.02 in most of the time, and continuing for nearly 50% of the total stay of the hospitals. So the average stay that was there in the hospitals, we have calculated, this has been around 23 days for most of the ventilated and patients on ECMO. In fact, our hospital has the largest ECMO facility in Asia, which has been augmented because of the COVID surge. But the most important is that recovery of eosinophils was seen to come to normal levels in almost 100% of the survivors, and only 2 patients had actually developed eosinophilia. Both of them survivors. One of whom, of course, had developed mucormycosis. The other was not found to have mucormycosis. Thankfully, we had much less number of cases of reported mucormycosis in our hospital, though there were quite a few suspected cases. Only 2 of them were actually found to be diagnosed with proper details and with confirmed on culture. The NLR ratio was found to be increased as compared to the first wave that we saw in our hospital. The patients were checked for the NLR ratio. Most of the patients came with NLR ratio. All those who were in severe had increased NLR ratio. Even in the first wave, the average but was around 13.66, while in the current wave, the NLR ratio was also found to be increased to almost 21.48%. And as for the lymphocyte monocyte ratio, a very important finding that we found this time was that increased monocytes percentage, with a lot of atypical monocytes coming in, which was not so much as much seen in the first wave. So the absolute counts of monocytes went high, even, and with associated lymphopenia, the LMR ratios, there was an inverse relationship with the severity. So in the severe cases, as compared to the first wave, in the second wave, we see that the LMR ratio is much reduced as compared to the first wave. So being from 3.77, which we found as an average in the first wave, to 2.24 in the second wave. With regarding the platelets which were found to be initially, I think all my previous speakers have also said, and I've also studied on IPF. Platelets, initially, there is something called as a megathrombocytosis or megathrombocytes, which is seen in Bengal. Also, some people call them fondly as Bengal syndrome, because low counts and megathrombocytes is a norm in the eastern part of the country, mostly in Bengal and its nearby states. But so normally we tend to have a lot of low counts. Also, all the platelet parameters, including MPV, PDW, IPF, are much higher as compared to the average nationally as well as that of international literature. But there was a different finding that we found in COVID patients, that as compared to the normal patients, the platelet counts were found to be much higher as compared to the normal, because normally we had to do a lot of slide reviews because of the low platelet counts that were there, but which markedly reduced during this COVID times, and which could be attributed probably to the increased use of, say, steroid, causing a reactive increase in the platelets. So in spite of having low counts in here in COVID, most of the COVID patients, even in serious COVID patients, those on ventilators and ECMOs, you saw that the platelet counts remain normal as compared to the other. With leukocytosis, platelet counts were used to normal until after a prolonged stay, when the platelets started going down or the WBC going down, most of the time they were associated with sepsis-induced coagulopathies, which were confirmed by coagulation parameters. I haven't included the coagulation parameters in this part of the study because just concentrated on the parameters on routine parameters on the cell counter. And they were only found to be decreased while we did a platelet lymphocyte ratio. It did not actually correlate, and the low values were much lower as compared to that of the normal patients. So I haven't actually included in this part of the slides. Among the RBC parameters, these were always the last to respond in the routine parameters, because unless the patient had a predominant initial comorbidity like chronic kidney disease, hemoglobin RBCs relatively remain stable, and they decrease on in the later part of the stay with increased numbers of acanthocytes, cystocytes coming in. Also DCT positivity, which was found in quite a few of number of patients, but it was almost the last parameter to become and decrease in the patients that were serious. And most of the patients in whom it has decreased and have been non-survivors. Regarding a particular finding that we found this time, more and more patients came with immature granulocytes and normoblasts. Quite a few of them showing leukoerythroblastic picture. Of this picture was of course increased with more the number of day of stay, and also associated with marked leukocytosis. Quite a few of them showing leukemoid reaction, and deranged coagulation parameters were always associated with this picture, with increased D-dimer levels, prothrombin and APTT showing mild to moderate variation. And most of the time they were found to be associated with sepsis. The bacterial cultures were also done by BACTIC, and positivity rates are there. The sepsis induced coagulopathy was probably the most important cause of this leukoerythroplastic picture. So that's to summarize my talk. It was a brief some references that have been taken to, and that's all that I have to share with for today. Thank you.
Thank you. Yes,
Dr. Ramon,
yes,
do you have any queries?
I have a question for you. Can you tell me about this lymphocyte-monocyte ratio? Because I have observed that the monocytes, before the patient becomes severe, they become even bigger. We have a research parameter, we say laboratory use only parameter, monocyte Z. And in 2 studies, we have seen that previous to the severe phase, monocytes become bigger and after decrease the size. It's interesting, your findings about the monocyte being as an important factor to follow up. Not many people said that.
Yes, we have seen that the monocytes have become larger in size with more blue, more cytoplasm, also increased granularity. And more, so we could call them more like a little reactive or atypical monocytes. And
I would like that you publish this as a letter to the editor, because that will help to understand the physiopathology, that you have correlated these changes we see in the size with morphological aspects in the microscope. That will help a lot.
Yes, we have confirmed the morphologically every time with every slide of these patients. I'm in a process to collate data. I know my data seems very less researched, but we are in the process of collating this data and trying to publish this data. So
the other point, I recently had a discussion also about COVID and hematological parameters, and it was said that neutrophilia was maybe not caused by bacteria, but cytokine, the interleukins increase, and that makes a growth. But it was very interesting also that you have done the cultures and published the correlation. That was my opinion too, that it was a secondary bacterial sepsis to the COVID because the immunodeficiency. For the reason, these facts, I think, needs to be published too, because this is very useful understanding what's happening with the neutrophilia.
A good point, sir. I will look into that and also corroborate it with try to corroborate it with the positivity of the cultures and the yes, I will definitely take it into consideration.
Thank you so much. And now we have the...
Thank you so much.
Dr. Ramon, there is a question for Dr. Ashwini. Madam, can you answer? It is there in the chat box. Can you answer it? You can type the answer. Yes. You can type the answer if you require.
I'll answer it. In the case of low platelet in Bengal, would the platelet count change if the person immigrates to other states or still remains low level? No, I guess it will remain the same, because I think Dr. Shukesh Nair, so many others, even my friends from Mumbai have all been telling me that this is a constant finding that they find in all the patients from Bengal. So moment they know that this person is from Bengal, they know that the count is going to be lower, but the patient may be essentially normal. It's a normal phenomena here that, and even with the best counters, even with optical mode, we have found that yes, the counts come lower, and the platelets are more larger, with larger MPV, PTW, and even IPF levels. I've already presented that in a previous forum regarding high IPF levels, much higher than the national average and the international average. So, but it will definitely remain the same. The patient's genetic constitution, there is a genetic constitution to this. So I don't think that's not going to change.
Thank you so much. Your research was very useful and very nice, very well established. Thank you so much for your.
Thank you so much. It was nice talking to you.
And now we are going to have with us Dr. Pradeep Suri. He will talk about hematological parameters and COVID prognosis. Dr. Suri is MBBS and MD Pathology from Maulana Azad Medical College in New Delhi, and MBA in Healthcare Administration. He has done some courses like Clinical Laboratory Management. And can you put the slide, please, with the okay. And welcome, Dr. Pradeep Suri. Please, the floor is yours.
Thank you, Dr. Rahman, for your kind words. I will begin my presentation from point where people come before going to Dr. Sen Gupta's hospital. Primarily, we are an OPD setting laboratory, so we look at parameters of patients who are still not admitted and are seeking admission. So from that perspective, we are going to look at parameters of patients who are first time diagnosed RT-PCR positive, and we do the hematological and inflammatory markers and see who are more likely to go to need hospitalization, and look at the prognostic significance of different markers. Especially this time, we had a very intense second wave, and there was a lot of shortage of beds in Delhi, at least. And some amount of triage of who needs hospital first can be done by having some look at these markers itself.
Perfect. We are waiting to hear from you.
We all know that CRP is the most suitable marker for looking of aggravation of COVID from mild to moderate to severe, with an average level of 20 to 50. And elevated CRP levels are observed in up to 86% of severe COVID patients, which makes it the most useful marker for monitoring the disease severity. Next, we have ferritin, which is kind of a double-edged sword, as it is both an pro-inflammatory as well as an anti-inflammatory marker. It is also an acute phase reactant and involved in iron metabolism. It has got significant prognostic value in COVID-19 patients. However, one single value is never enough to determine. Serial rising titers of ferritin are more significant, especially when we are looking at cytokine storms. When they say that, when the levels increase to more than 600 to 1000 within a span of say 24 to 48 hours, along with an elevated IL-6 levels, which are 10 times the normal level, this is kind of, a telltale sign for impending COVID storm. So ferritin, apart from being an inflammatory marker, is also a useful marker to look at impending COVID storm. Next, we have the interleukin-6 or IL-6. It is a potential predictor for development of hypoxemia in COVID-19 patients. And at a concentration of 24 picogram per ml, it shows excellent sensitivity and good specificity across various studies. Next, we have lactate dehydrogenase or LDH, and their elevated levels are associated with increased odds of both developing severe disease, 6 times more odds of developing severe disease, and approximately 16 times more odds of developing higher mortality. So it is not only a marker for severity, it is also a marker for mortality, and it's a very useful inflammatory marker. Then we have D-dimer, which is both inflammatory as well as pro-coagulation marker. It correlates well with other inflammatory markers, and it is more meaningful for a prognosis of survival at a cutoff of 2.025. So what is the objective of our study? We have basically tried to look at various hematological parameters, most of what Dr. Sen Gupta had described earlier, and tried to correlate with these various inflammatory markers that, with the rise in these inflammatory markers, what is the change in the hematological parameters, and which one amongst the many are best suited to triage patients into mild, moderate, severe even before the symptoms have manifested. And we have then tried to establish the most useful markers among them that can be used for COVID-19 prognosis. So the materials that we used in our study were for CRP and LDH, we used Cobas Integra biochemistry analyzer. For ferritin, we did Abbott Architect chemiluminescence system. For interleukin 6, we use Beckmann access system. For D-dimer, we use VIDAS system using alpha technology. And for doing RT-PCR for COVID-19, we use Bio-Rad CFX96 as well as ZBio extraction system. And the CBC with reticulocyte count we did for each of our patients on Mindray BC 6800 plus. So these were the materials that were available to us to conduct our study. So what we did was a simple 4-step methodology. Sorry. Yeah. So all the patients who were RT-PCR positive were selected in the scope of study. Patients who had got CBC and all these 5 inflammatory markers, who had not got rather, sorry, were excluded from the study. So each one of our patient had got CBC and all the 5 inflammatory markers that were part of the study. Patients were asked for a history of corticosteroid intake, and the group was further filtered with people who had already started corticosteroid were excluded, as we know that corticosteroid makes NLR jump up, so that neutrophil lymphocyte ratio, which is a very important marker that we were studying, should not get biased by corticosteroid intake, because then the NLR will no longer be a reliable tool. And then we performed an unpaired t-test for each one of these parameters with each of the inflammatory markers. And most of these patients were followed to see which one of them needed hospitalization. So first, CRP, we divided CRP into 2 categories, less than 20 and more than 20. And we did the markers that we did were absolute lymphocyte count, absolute neutrophil count, RDW, both CV and SD, immature platelet fraction, NEUT-Y, neutrophil lymphocyte ratio, immature granulocytes, high fluorescence cells or the high fluorescence lymphocyte cells, immature reticulocyte fraction, and mono-Z. So these were the markers that we studied. For CRP, the 3 markers that showed, significant difference between the 2 groups were absolute lymphocyte count, absolute neutrophil count, and neutrophil lymphocyte ratio, with value of 1.9 and 1.2 for the absolute lymphocyte count, 5.4 and 6.3 for the absolute neutrophil count, and 3.7 and 7.2 for the NLR. The other markers which showed mild significance were HFC and NEUT-Y. Next, we did for ferritin, we divided again into 2 groups, ferritin less than 300 and ferritin more than 300. Again, the 3 markers that showed promising results were pretty similar. Absolute lymphocyte count and NLR were similar to that in the CRP, but absolute neutrophil count did not show that much of a difference. However, HFC showed a significant difference in this case. HFC from 0.31 was difference to 0.6 in the higher group. So HFC was a more significant marker with ferritin. Next, we did a correlation with LDH. Again, 2 groups, LDH less than 350, LDH more than 350. So the 3 markers that did show better correlation were similar to that in CRP. Absolute lymphocyte count was 2 in the first group and 1.3 in the second group. Absolute neutrophil count was 5.2 and 6.5. And NLR was 3.5 and 7.3. So NLR was showing the most significant difference across the board amongst all the 3 inflammatory markers so far. Then we did for interleukin 6, we again divided interleukin 6 into 2 groups, less than 24, more than 24. So the absolute lymphocyte count, neutrophil lymphocyte ratio, and NLR showed the most significant difference. Absolute lymphocyte count was 1.8 and 1.3. NLR was 4 and 6.2. And HFC was 0.33 and 0.53. Absolute neutrophil count did not show that much of a difference. Last, we did for D-dimer value less than 1 and more than 1, we differentiated again into 2 groups. We could have taken 0.5, but because there were a lot of elderly people, so age correction we did, and so we took 1 as a good number so that we could differentiate, age corrected patients also. In this group, surprisingly, absolute lymphocyte count, absolute neutrophil count, and NLR did not show that much of a difference. NLR did show mild difference, but surprisingly, a new parameter cropped up, immature reticulocyte fraction. This showed a significant difference. It was 10.8 in the group where D-dimer was less than 1 and 16.5 in the group where D-dimer was more than 1. Surprisingly, reticulocyte percentage and absolute reticulocyte count did not show that much of a difference in this group. So this is the unpaired t-test for CRP versus neutrophil lymphocyte ratio. It was extremely significant. The mean difference was 3.5. This is that unpaired t-test for CRP versus absolute lymphocyte count. It was also extremely significant. P-value was less than 0.0001 and the mean difference was 0.52. T-test for CRP versus absolute neutrophil count, again extremely significant. Mean difference was 2.47. This is t-test for ferritin versus absolute lymphocyte count, again extremely significant. The mean difference was 0.47. T-test for ferritin versus high fluorescence cells, again extremely significant. The mean difference was 0.268. However, there was a very interesting finding with HFC. Although HFC was higher in the group which had higher inflammatory markers, but an HFC value more than 1% was, none of these patients needed hospital admission, and few of them who actually did not require any oxygen support. So HFC value more than 1% was also seen as a good prognostic marker. So that was the dichotomy with HFC. This is ferritin versus neutrophil lymphocyte ratio, again extremely significant, p-value less than 0.001 and the mean difference was 2.678. IL-6 versus absolute lymphocyte count, again extremely significant, mean difference of 0.470. Then IL-6 versus neutrophil lymphocyte ratio, it was again significant, mean difference 2.17. IL-6 versus HFC, again extremely significant, mean difference 0.21. D-dimer versus immature reticulocyte fraction, again extremely significant, p-value was less than 0.0001 and the mean difference was 5.658. CRP HFC correlation was mildly significant. Same for CRP HFC in percentage as well as absolute HFC, mildly significant. CRP Newt Y was also mildly significant, which shows that most of these neutrophil absolute that was increasing was not due to shift to left or neutrophilic leukocytosis, rather due to lymphopenia. So it is more a case of relative neutrophilia that was happening. There was not so much a shift to left in all these cases. Then ferritin absolute neutrophil count was again mildly significant with a p-value of 0.0124. IL-6 absolute neutrophil count was not significant. D-dimer absolute neutrophil count was not significant. D-dimer absolute lymphocyte count was also not significant. So D-dimer was not showing much significance with most of the hematological markers barring IL-6. Same D-dimer NLR was again not significant. And D-dimer HFC was also not significant. So in conclusion, absolute lymphocyte count, absolute neutrophil count and neutrophil lymphocyte ratio were the best prognostic marker, showing excellent correlation with most of the inflammatory markers. NLR was the most efficacious markers amongst the various parameters analyzed, with a caveat that till you put the patient on corticosteroids. Once the patient is on corticosteroids, then NLR is no longer a reliable marker. Immature reticulocyte fraction showed excellent correlation with D-dimer, but not with other inflammatory markers. This could be a topic for further research to see why immature reticulocyte fraction is increasing with increase in D-dimer. Although total reticulocyte fraction is not increasing, only there is a shift to left, maybe because of some RBC destruction there is some bone marrow reactivation. I don't know. So with these words, I'd like to thank you all. If there are any questions, I'll be glad to answer.
Yes. Thank you so much, Dr. Suri. It was very nice presentation. And I have to say something that, you know, for some people maybe looks not interesting, the exhaustive statistics you did. But as you mentioned, we found incredible things, incredible facts. I expected to find much more correlation with D-dimer and IPF, but not. It's IRF. You know, D-dimer correlating with red cells parameters. That is amazing. And we need, absolutely, I agree with you, we need to investigate that. For the other reasons, I think LDH, lactodehydrogenase, correlates with IRF. That maybe confirm the component of hemolytic anemia, that there is some hemolysis. But again, another correlation that I cannot explain is why high fluorescent cells correlates better with ferritin. Normally, I will expect ferritin correlating with hematological parameters, because anemia of chronic disease, because blocking the iron metabolism, an increase of hepcidin, an increase of ferritin, but not. You find that high fluorescent cells, that will be the presence of lymphoplasmatic cells, correlates with ferritin. That is amazing, and that's open new pathways to investigate COVID. And that, thank you very much. Looks like for many people maybe it's boring to see, but believe me, it is amazing, because because normally we look for the correlations that we have in our mind that have sense, but look for other correlations can open new pathways to understand COVID. And thank you so much. I was really excited with your talk.
Thank you, sir. Thank you so much.
Very good. And now it's time for Dr. Amrita Saraf, Senior Consultant Hematologist at Singh Ganga Ram Hospital. She will talk about predicting severity in COVID patients using novel hemocytic parameters. Dr. Saraf, as you can see here, is presently working as Senior Consultant in the Department of Hematology in Singh Ganga Ram Hospital, New Delhi. She did the graduation and post-graduation training from the Institute of Medical Science. She has done her postdoctoral in the Mount Sinai, School of Medicine in New York, in flow cytometric immunophenotypic in blood, bone marrows, and hematopoietic transplant pathology. She has a vast experience in teaching, involved with academics, published papers, and delivered several talks in national and international meetings. Dr. Amrita Saraf, the floor is yours.
Thank you, Dr. Raman, for your kind introduction.
Yeah.
Hi, everyone. So first of all, I would like to thank the Mindray team for giving me this opportunity. So today I'll be sharing a small piece of work, and the title of this is Predicting Severity in COVID-19 Patients Using Novel Hemocytometric Parameters. As we all know, the COVID-19 is an ongoing global pandemic which is caused by severe acute respiratory syndrome coronavirus 2. In short, we call it SARS-CoV-2. It was first described in late December 2019 in China. COVID-19 has very variable clinical manifestation. It can range from mild flu-like symptoms, it could be asymptomatic, or it can vary to life-threatening ARDS, acute respiratory distress syndrome, and organ failure, which can cause death. As we all know, the standard test to detect COVID-19 remains RT-PCR, which is highly specific but lacks sensitivity. The complete blood count is the most routinely performed inexpensive hematological test, which is used globally, and most of the routine laboratories are equipped with often high throughput hematology analyzer. In this respect, leukocytosis, neutrophilia, and lymphopenia have been reported in COVID-19 positive patients. However, some of these analyzers further differentiate the subsets of leukocytes involved based on scatter and fluorescence properties, which include size and cell volume, denoted as FSC, forward side scatter, then internal structure, side scatter, and DNA-RNA content by fluorescence properties, SFL, reported as research parameters in the cell population data. as most of the published data in these patients is focused on traditional parameters such as lymphocyte count, platelet count, and NLR, so we decided to assess the role of novel parameter. So the aim of this pilot study is to analyze the contribution of these novel parameters to established clinical risk factors in predicting adverse outcomes in COVID-19 patients to support patient management decision and thus facilitate timely interventions. Coming to the methodology, the study was carried out in Department of Hematology, Sir Ganga Ram Hospital, New Delhi, and data from 2 months, April to May 2021, was collected and analyzed. In this retrospective pilot study, total 30 COVID-19 patients were included, which were confirmed cases by RT-PCR, and all these were admitted in the hospital ward. 20 of them were shifted to ICU after progression of the disease. So this included 20 male and 10 female patients from age group 30 to 89 years. All the baseline COVID workup was done as per the guidelines. The admitted patients were divided into two broad groups. The one, patients who were admitted in the ward who got discharged with improvement, and the patients who developed cytokine storm syndrome as per the criteria, and they were shifted to ICU. The patients having hemoglobinopathies, hematological or solid malignancies on chemotherapy were excluded from the analysis. CBC parameters were measured by collecting peripheral blood in the EDTA tube, and they were analyzed on a fully automated hematology analyzer, Sysmex Exxon 1000. The advanced research parameters were related to scatter and fluorescence properties of neutrophil, lymphocyte, and monocyte, which were obtained from analysis. In addition, 20 cases of normal controls were also analyzed. So following parameters were done, and they were detected using automated cell analyzer Sysmex Exxon 9100. So we had detected IG and RBC, neutrophil reactivity intensity, NEUT-RI, NEUT-GI for neutrophil granularity, neutrophil FSC for the size and volume of neutrophils, then the similar parameters for monocyte, which included MOSSC for monocyte nuclear irregularity and metabolic activity, MOSFL, MOFSC for the size and volume of monocyte. Then there was lymphocyte SSC, lymphocyte SFL for metabolic activity, lymphocyte FSC for the size and volume of lymphocyte. In addition, high fluorescence lymphocyte count percentage and absolute value HFLC were also included. So describing in short these parameters, the site scatter signal of neutrophil population, which is plotted here at x-axis of the scattergram, it's an indication of the granularity and internal structure, and the fluorescent intensity, which corresponds to the RNA and DNA cell content, is plotted on the y-axis, which is an indicator for increased RNA activity. Similarly, these parameters were also seen for lymphocyte and monocyte in addition to neutrophil. So in the differential channel, these cells were differentiated based on their fluorescence signal intensity, the size, and the internal structure. The parameter NEUT-RI, we know it reflects the neutrophil reactivity intensity. In the 90-degree side scatter light of the differential channel, we got information about cell density and complexity, which represents the granularity. So when the complexity of the neutrophil increases because of the change in functionality, so the parameter NEUT-GI also changes accordingly. Similarly, there are changes in this parameter for lymphocyte and monocyte. Coming to HFLC, we already have talked enough about HFLC. So in short, HFLC count reveals a cell population which can be distinguished from monocytes and normal lymphocytes in a 5-part differential channel by the higher intensity of their fluorescent signal. Previous studies have demonstrated the correlation between HFLC and activated B lymphocyte, HFLC and plasma cells in the peripheral blood. So HFLC are actually exclusively activated B lymphocytes which synthesize antibodies, and it is recognized by markedly high increase in the fluorescent intensity compared to that lymphocytes which are not activated. So most HFLCs may represent only antibody producing B lymphocytes. It is also proposed by Listen et al. In the article. So coming here, we can see that there are these routine and research parameters from the hemocytometric plot from in different categories. So there are 3 patient groups where in the COVID-19 negative, we can see that there are different cell population as well as their x-axis showing side scatter and y-axis showing the fluorescence intensities. Then here it is one of the COVID-19 positive case without cytokine storm. So here this panel shows the area where it is RE and AS, but in our country, as there is no license available to assess these AS lymphocytes and RE lymphocytes, we can get only HFLCs. So as we know that HFLC represents antibody synthesizing lymphocytes, so HFLC was included in this analysis study. Now in this, the third category, here it shows the use of measurement of the reactive monocytes, RE mono, and immature granulocytes. Here we have included these three parameters for neutrophils, then monocytes, lymphocytes, along with the HFLC. Here is the analysis. We can see that in the first group, the 20 controls were compared with the total number of admitted COVID-19 cases, that were 30 cases. The second group was non-severe patients which were admitted in the ward, which were 10, versus severe who had to be shifted to ICU because of the developing complications. And the third category was the patients who were investigated at the time of admission, the baseline, which were 20 in number, versus when they shifted in ICU and got cytokine storm. So these 3 categories are mentioned here based on these parameters. On analysis, we found that for the control versus total admitted positive cases in the ward, we found the significant difference in the parameters Newt RI, then monocyte SSC, monocyte SFL, the metabolic activity and nuclear irregularity for monocyte, and HFLC, percentage and absolute value. While we did not find any significant difference in the patients non-severe versus severe, which included the patients who did not develop symptoms and who did not worsen in terms of clinical presentation, and versus the patients who had to be shifted to ICU. In the third category, which was done between the baseline investigation versus when they got shifted to ICU, it was only the HFLC percentage which showed a significance difference. So we, in short, we found the significant difference in Newt RI, the SFL, that is the site fluorescence of neutrophil, monocyte nuclear irregularity, MOSSC, monocyte metabolic activity, that is MOSFL, along with HFLC percentage and absolute number between the control group and all the patients admitted in the ward who were diagnosed as COVID-19. While in the other group, where the patients who developed complications shifted to ICU, when compared to their baseline parameters studied, it showed significant difference only in the HFLC percentage. So coming to the discussion, as we all know, the fear of third wave of COVID-19 has already alarmed the globe. There is a need to assess the disease severity and mortality risk associated with COVID-19 for the optimal management of the patient. And the several inflammatory and hematological parameters are thought to associate with the severity of this disease. So this pilot study was an attempt to examine these relatively novel hemocytometric parameters in these confirmed positive cases of COVID-19. And we found that there is a significant difference in terms of NEWT-RI, MOSSC, MOSFL, and HFLC in terms of percentage and absolute value between the control group and all the patients admitted in the ward. So, coming to the conclusion, these parameters, if found relevant in a larger number of cases, it could be used as suitable biomarker for prognosis of COVID-19 disease. And the alteration in these parameters can be easily used for severity and mortality analysis, as routine blood tests are easy and they are readily available. So these evaluation of novel parameters can aid clinician to identify potentially severe cases at early stages, initiate effective management in time, conduct early triage, which may reduce the overall mortality of COVID-19 patients. So this study identifies and describes a summary of changes in the novel WBC parameter of COVID-19 patient. Although this is a pilot study with a small sample size, it is a step towards understanding the hematological manifestations of COVID-19, and knowledge of these constellation of changes in the peripheral blood cells by a simpler method, if substantiated with larger studies, it may help physician to diagnose COVID-19 in the absence of a negative RT-PCR and antigen test.
Okay, thank you, Dr. Saraf. It was really a very interesting talk, and I have to make some comments to you that I really appreciate, because some other people like me, Dr. Urrechaga from Spain, and the previous speaker have shown how monocytes can be so useful for COVID. And you mentioned the granularity, as the previous speaker have described, that in the microscope they see also a increase of monocyte granularity. Monocytes, we know, that are very involved with the cytokines, and it's something that we need to explore, all of us, and continue working. Monocytes were forgotten for many years and really now become very, very important. And I am happy that your results also show that. My question for you is, first, have you seen in the group of patients that come severe, okay, what happens 1 day or 2 days before, when they are still moderate, not severe, because that is what we are working with, to try to prevent or to predict what's going. And that is what I propose to you. If you have done, I am asking you now, but if not, to search in the future, what's happening this group that becomes severe, compare it with the group that will not become severe, that will stay in the moderate phase or in not acute phase.
See, actually, thank you for your question and for your comments. Actually, what I would like to say here, that the number of cases who were admitted in the ward initially, and some of them actually kept on worsening, and finally they had to be shifted to ICU. So at multiple points of time, the CBC parameters were noted and their other biochemical characteristics were also studied. But in this part of this pilot study, even though not too many number of readings have been taken, but it shows that we might get something significant if we actually decide the time points when they were admitted to start with at the baseline, then when they developed symptoms and they qualified to be called as, they need to be shifted to mechanical ventilator or in ICU. So there need to be a better framework of the study to highlight what you are actually asking. So I really understand, and I think that needs to be incorporated when we want to highlight the alarming features based on these parameters for a clinician to get some kind of a hint.
And the last but not least, I have to tell you that I was one of the first also working with the more automatic morphology of leukocytes from many, many years ago, and we are now involved in quality control. How many instruments you have in your lab? How many instruments you have in your lab?
Right now we are using Sysmex
but
only. Actually, we
but
have
how
3
many instruments
equipment
from the same
of
type you have in your lab? 2, 3 instruments?
Yeah, we have 3 of same type.
Okay, that is what I am asking you. Please, I would like that for the next time would you present your results, that you analyze the same parameters, the neutrophil SFL, the monocyte X, analyzing the same sample in the 3 instruments, because we are now trying to investigate the variation between instrumentations and the variation in the time of these parameters. I think it's time that we, all the people that we have been working in this, what we call cell population data or automated morphological parameters, we can have, we can understand the stability in the time, the variation between instrumentation, because still we don't have calibrators, and the moving average of normals, all of that will help to standardize the use and to find cutoffs that we can use to the 3 instruments in our lab, or to the 2 instruments in our lab, or to the 10 instruments in our lab, depending how big is the lab. Thank you so much. It was very, very useful, your talk.
Thank you. Thanks.
Thank
Good.
you, Dr.
Now it's time to
Thank
present, it's time to present the next chairperson. That will be Dr. Shabnam Rohi. She's a director in the laboratory medicine from Sakra World Hospital. She has more than 20 years of experience in her field. She has received her postgraduate degree from KMC in Bangalore. Her areas of clinical expertise include the diagnosis of hematological disorders. She has been an assessor for NABL for the past 10 years. She has multiple certifications in hemopathology and quality assurance. She also has several publications in national and international journals, presented papers and posters in national conference, and served as faculty in CME programs. Welcome, Dr. Shabnam Rohi. The chair is yours, and now we are happy to introduce you. Thank you.
Introduction. Thank you, Dr. Raman, for the kind introduction. And I thank the faculty of Mindray and BLK Max for inviting me as a chairperson for this event. I thank you all.
Very good. Perfect.
Now I would like to introduce the next speaker, Dr. Rajalakshmi Rajashekar. She is an assistant professor of pathology, JSS Medical College. Her topic will be diagnostic utility of platelet histograms and flagging performance from automated hematology analyzers. She is a 4th rank holder in MD pathology from RGUHS, that is Rajiv Gandhi University of Health Sciences and Research. She is trained at Tata Memorial Hospital, Actrek, Mumbai in hematology, National Institute of Immunohematology, Mumbai in coagulation disorders and hemolytic anemias. She has 7 international and 6 national publications to her name. She has participated as a panelist in panel discussions, presented oral papers in national and state conferences. The panel is on, the stage is yours, Dr. Rajalakshmi. You can carry on. Dr. Rajalakshmi.
A good day to everybody. At the outset, I would like to thank the organizers for giving me this opportunity to present the study. Today, I will be presenting a study on the diagnostic utility of platelet histograms and flagging performance of automated analyzers with thrombocytopenia. So, over the recent years, hematology analyzers have evolved from semi-automated to fully automated ones. While the majority of these enumerate the platelet and red cell counts by impedance principles, many of these analyzers use the optical light scatter or optical fluorescence methodology to count the platelets. A histogram, which is generated by these analyzers, is a graphic representation of the collection of data, which is based on the cell size, number, and is a very powerful tool in morphologic analysis of red blood cells, white blood cells, and platelets. The platelet histograms are a neglected part of the automated hemogram, which unlike the RBC histograms, which have been studied in detail about their shapes, about the bimodal pattern, and about the utility in various anemias, these platelet histograms are not evaluated properly, and which, if interpreted, will have a significant diagnostic potential to prove relevant information on the patient diagnosis. So the present study aimed at analyzing the platelet histograms in thrombocytopenia with simultaneous interpretation of platelet flags and platelet counts by impedance and optical fluorescence methodology. So the objectives in the present study were to analyze the platelet histograms in thrombocytopenia, to correlate the platelet flags with peripheral smear findings, and to recognize the analyzer results consistent with spurious platelet values. So these were the three objectives of the study. Coming to the methodology, this was an observational study which was done on a sample size of over 300 blood samples of thrombocytopenia in the Department of Pathology of a tertiary care hospital in Mysuru, Karnataka. The histograms and the other parameters of autoanalyzer were obtained by a 6-part automated hematology analyzer, Mindray BC 6200 series. The 300 cases of thrombocytopenia were divided into 3 categories based on the platelet count, as into category 1, a severe thrombocytopenia category with less than 50,000 platelet count, category 2 with the platelet count between 50,000 to 1 lakh, category 3 where the platelet count was divided into the cases with 1 to 1.5 lakh per microliter. And this is the severity of thrombocytopenia which we have taken into account for our study. The parameters in histogram that were evaluated were height, breadth, upper discriminator, and the shape of the histograms along with the platelet flags which were generated. These histograms were evaluated in relation to the platelet flags, followed by a peripheral smear analysis and correlation of these parameters. The statistical analysis was conducted by entering the data in MS Excel sheet and using SPSS version 23, which was licensed to the institution. Descriptive statistical measures like percentage were applied. Inferential statistical tests like chi-square test was applied to test the association between grades of thrombocytopenia and the histogram patterns. The association was interpreted statistically significant at a p-value of less than 0.05. So now we will move on to the results. The platelet histogram is a graphical representation where it measures the platelets between 0 to 30 femtoliters. And here, if we can see the first photograph, this is the normal curve which is seen in a platelet count of 2.13 lakh. That is in the normal patients, normal people, where the platelet count is more than 1.5 lakh. And this is a smooth curve with a right skewed right side of the right arm of the curve. And here, the height of the curve represents the platelet count, while the breadth of the curve represents the platelet anisocytosis. The instrument also had platelet parameters which were depicted by numerical values, and also the flags which were generated by the analyzer. And the 3 flags that were generated by BC 6200 analyzer were platelet clump, platelet histogram abnormality, and thrombocytopenia. So this is a photograph which is showing all the 3 flags in a case of thrombocytopenia with platelet count of 89,000 per microliter. And now this is the table 1, which is depicting the platelet flags generated in thrombocytopenia in our 300 cases, the total study number. And here, if we can make out, there were 102 cases in category 1, 107 cases in category 2, and 91 cases in category 3. So the category 3 was a mild thrombocytopenia, and in category 1, which is designated as severe thrombocytopenia, here we can see thrombocytopenia flag was generated in all the cases, and the sensitivity for this flagging was 100% for all the cases. The other types of flags that were generated were clumps and platelet histogram abnormality in severe thrombocytopenia cases. While in mild thrombocytopenia, the platelet flags were generated only in 14 out of the total 91 cases. Hence, we infer from this table that flagging performance of the analyzer was more whenever the platelet counts were less than 1 lakh. So in the category of mild thrombocytopenia, flagging performance was less compared to the cases with moderate and severe thrombocytopenia. So now we will move on to the histogram patterns in thrombocytopenia. This is the table which is showing the histogram patterns which were described as having the following types in all the cases of thrombocytopenia in our study. And here the patterns described were slightly undulated downward curve, serrated downward curve, saw-toothed curve without touching the baseline, shortened height of the curve, shortened peak with elevated tail, multiple peaks, and a normal curve. So here, this is a graphical representation where you can make out the frequency distribution of histogram patterns in thrombocytopenia. So first we will see the last category, that is category 3 of mild thrombocytopenia. Here if we can see the blue bar diagram shows a predominant pattern of 87% of the cases which is showing a slightly undulated downward curve. This was a predominant pattern that we saw in the category of mild thrombocytopenia. And when we move on to the moderate thrombocytopenia, we can see some more bars also which are coming up here. And if we can make out, there is a brown bar that is having almost 65% of the cases showing the pattern of serrated downward curve. The other patterns in this moderate thrombocytopenia category were shortened peak with elevated tail and 3% with multiple peaks, and some with serrated downward curve, some with undulated curve. So here the predominant pattern was that of a serrated downward curve. When we move on to the category of severe thrombocytopenia, unlike the other two categories, we can easily make out that there is a diverse pattern of histograms with a predominant pattern of 33% where it was saw-toothed without touching the baseline. A saw-toothed pattern where it did not touch the baseline was the predominant pattern, and all the other patterns such as serrated downward curve, multiple peaks, and then short peak with elevated tail, all were noticed in this category. So now we will see the individual histograms in each of these categories. Category 3, which is of mild thrombocytopenia, and here the first histogram is from a sample of 1.27 platelet count, which is showing a slightly undulated downward curve. This is based on the normal curve, which is a slightly right skewed curve, which is smoother, which is very smooth, whereas here if we can see it is an undulating downward curve, and this was the predominant pattern that was noticed in all these cases, 87% of mild thrombocytopenia cases, and this we found to be statistically significant, predicting the histogram pattern in this particular category of severity of thrombocytopenia. Now if we move on to category 2, again if you remember the bar diagram that I projected, 65% of the cases had this pattern of slightly serrated downward curve. Unlike the first category, which I would like to project again, there is only slight undulation of the downward curve, but when we move on to this category, we can see a serrated downward curve, which is almost there in many of these samples, ranging from 50,000 to 1 lakh. If we can see, this is 77,000, 61,000, 82,000, 85,000 platelet count, but the pattern is similar. So this is the curve pattern that we appreciated in moderate thrombocytopenia category. And now moving on to the category of severe thrombocytopenia, which had a diverse pattern of histograms. The first one is that of a saw-toothed curve, which was present in 33% of the samples. And here we can make out, unlike the first two categories, it's not at all a curve. Here we can make out more serrations, saw-toothed appearance of the curve with the associated flagging that is generated by the analyzer. And hence, and this was the predominant pattern. The second pattern, that is serrated downward curve, similar to the moderate thrombocytopenia cases, was also generated here. This is the third pattern which we notice, that is shortened peak. And then the other patterns such as multiple peaks in case of 7,000 thrombocytopenia and short peak with elevated tail. So these were the diverse pattern of histograms that we got in our results. So coming to the discussion, the predominant pattern was slightly undulated curve in mild thrombocytopenia, while none of the severe thrombocytopenia cases showed this pattern. So this we thought could be more indicative of this mild thrombocytopenia cases. So the commonest pattern in category 2 was serrated downward curve, and this was also seen in some cases of severe thrombocytopenia and only 4 cases of mild thrombocytopenia cases. In mild thrombocytopenia, compared to the severe category of 3, the diversity of patterns was very less. So this association between the thrombocytopenia cases and the patterns of histogram was found to be statistically significant with a p-value of 0.0011. And now, the diverse pattern in severe cases of thrombocytopenia can be explained by the peripheral smear correlation, where we saw anisocytosis in majority of these cases and many had giant platelets. This could be the result of high marrow regeneration, which releases the immature larger platelets and hence resulting in more anisocytosis and more abnormal platelet histogram curves. But both in moderate and severe thrombocytopenia, unlike the mild thrombocytopenia category, anisocytosis was a feature in peripheral blood smear examination, and this could be the reason for the serrated patterns and other patterns that we have noticed in these two categories, unlike the smooth little undulated pattern that we saw in mild thrombocytopenia cases. So now, these histogram variations in thrombocytopenia were studied by Shetty et al., which has described the following patterns: normal curve, curve not touching the baseline, broad-based curve, curve with short peak, bimodal peak, and sawtooth appearance. And these patterns were correlated with the mechanisms of thrombocytopenia. A thorough literature search could not give us many results. Many studies which have evaluated elaborately the platelet histogram patterns in thrombocytopenia, dividing them into different categories. So ours was a study where we have divided it completely into different categories and we have evaluated all the abnormal patterns of platelet histograms. Now we will move on to the spurious low platelet counts and the correction. So here this was the third objective of our study, where we tried to analyze if we can find out any spurious values that can be identified by the analyzer results. So there were 33 cases of spurious low platelet count out of 300 cases in a study. And out of them, platelet clumps were seen in peripheral smear of 26 cases, which was because of probably EDTA-induced pseudothrombocytopenia, resulting in a low platelet count by the analyzer. And the histogram patterns in this was multiple peaks seen in 18 out of 26 cases, which is a good number to say this could be a consistent pattern in platelet clumps. And the other patterns were sawtooth or serrated pattern and short light. And the flagging that was generated for platelet clump was seen in 24 out of 26 cases, again giving an evidence that this is a reliable indicator from the analyzer. And to correct this spurious value, the measures that we took were the optical fluorescence method, which is available in Mindray BC 6200, which increased the platelet count in 13 out of 26 cases. And in 9 cases, the sample was tested upon recollection with citrate anticoagulant and the count was given after correction. The second cause, a spurious low platelet count that was observed in our study, was seen in 9 cases of smear, where it showed significant number of giant platelets which were almost of the size of RBCs. And this could be very well explained because the RBCs and platelets are counted in the same channel, and hence giant platelets are not counted as platelets and could give rise to a spurious low platelet count on the analyzer. Though there were cases wherever thrombocytopenia was there, there were good number of giant platelets, but the number of cases which gave rise to spurious low count because of the giant platelets was seen in 9 cases, where the peripheral smear manual counting was given to correct this particular problem, and that yielded a higher manual count, platelet count, compared to the automated analyzer. And here, coming to this problem, we had the pattern of histogram that had elevated tail in 7 out of 9 cases. And 2 of them showed serrated curve, and histogram abnormality was the flagging generated, which was seen in 6 cases. So now we will see them, the photographs, where you can see the histogram, which is showing multiple peaks, which is not touching the baseline. It has a broader base, and this is because of the flagging which is generated, that is platelet clump and platelet histogram abnormality. And the same sample on peripheral smear examination is showing multiple platelet clumps, and this is because of EDTA-induced pseudothrombocytopenia. So the same platelet clumps which were seen in our study had different patterns, such as this multiple peak in majority of them. And here you can see the serrated curve in a patient of platelet count 63,000, and flagging was consistent for all of them, that is platelet clump. So these were the patterns that we have got in case of platelet clumps. So now EDTA-dependent pseudothrombocytopenia has been a well-known entity where a study by Thomas et al. Has reported multiple peaks in platelet histogram as the predominant pattern that indicates clumping of platelets that should be noticed by the peripheral blood smear examination. While a study by Nagler et al. Has recognized EDTA-dependent pseudothrombocytopenia by histogram pattern of serrated curve. While in our study, both of these histogram patterns were observed in platelet clumps. So this is a very useful finding. So now the second cause of spurious low platelet count, that is giant platelets. So this is a classic platelet histogram that we have got in a case of giant platelet, which was confirmed on peripheral smear examination. The photograph is being projected here, where you can see the multiple large platelets in the field, which are almost of the size of the RBCs, and the histogram is showing the classic elevated tail. And here the tail is almost even starting within 30 femtoliters and it is going high up. And this was the cause of giant platelets, and that was the indication given by the histogram that there could be giant platelets, and that warranted a peripheral smear examination. So this was the other pattern that we saw in giant platelets, where there was a serrated curve. This did not touch the baseline. Peripheral smear showed giant platelets and the count was 1.2 lakhs. And here the other additional indicators that were provided by the analyzer were increased immature platelet fraction of 35% and platelet large cell ratio of 73%. Though these two indicators were not consistently seen in all cases wherever there were giant platelets. So the analyzer could be of significant help in recognizing the spurious values. The histogram patterns of multiple peaks were seen in majority, that is 18 cases of platelet clumps, proving that this pattern can reliably predict the presence of platelet clumps in the sample and warrants a slide review. The elevated tail in platelet histogram was consistent with giant platelets, which was seen in peripheral smear of 7 out of 9 cases. The flagging performance of analyzer for platelet clump was seen in 24 of 26 cases, further endorsing the utility of flagging performance of automated analyzer as definitive tools for identifying the spuriously low platelet clumps. This is another additional parameter or additional facility that is there in our analyzer, that is automated Mindray BC 6200, which also estimates the platelet count by optical fluorescence method, which corrected the platelet count in 13 samples with platelet clumps. And a study by Bayo et al. On BC 6800 analyzer showed that optical fluorescence platelet counting with its dissociation effect on platelet clumping in these samples of platelet EDTA-induced pseudothrombocytopenia yielded counts that were significantly higher than the impedance method of platelet counting. So they also say optical fluorescence platelet counting is useful to exclude non-platelet cells such as erythrocyte debris, microerythrocytes, and leukocyte debris, etc. So in our study, because the instrument had this facility, we could evaluate the platelet count even by optical fluorescence method, which improved the platelet count in 13 samples. And now this was the example. You can show the photo. You can see the photograph here, the printout from the analyzer, where platelet I is by the impedance method, the platelet count is 94,000, and by optical method, platelet count is 2.59 lakh. So there was a pseudothrombocytopenia, which is because of the EDTA, and hence this was corrected by this method of optical fluorescence counting, where this Mindray analyzer does this platelet counting in the reticulocyte channel, and that is a optical fluorescence method, which dissociates the platelets and gives a higher platelet count compared to the impedance method. There is another example here. If we can see the platelet count by impedance method, which was 27,000, while in optical method the count was 1.44 lakhs, and this was a very useful parameter that we have studied. So now another interesting part of our study is the histograms which had a typical elevated tail. So when we went back, there were 37 cases in our study which had this kind of histograms with elevated tail, and the associated abnormalities were divided into these 4 particular causes. One of them is microcytosis, the other is RBC fragments, giant platelets, and the next cause is hemolyzed sample. And this was seen in good number of cases, and the patterns were as follows. So the first one is elevated tail with associated microcytosis, where the peripheral smear showed microcytic hypochromic cells. MCV was 56 femtoliters in this particular sample, and platelet count was 62,000. And if we can see these different histograms from different samples, it is very much convincing that this pattern could be taken as a definitive indicator whenever we have the MCV which is low and there is this elevated tail that is indicating microcytosis. And the other important cause of this elevated tail was seen in cases of fragmented RBCs, and this again is because of the fact that fragmented RBCs could come in the way of platelet counting because both are counted in the same channel, and hence in this particular sample of microangiopathic hemolytic anemia we can see the flagging for fragments as well, and we can see the platelet histogram with an elevated tail which is not reaching the baseline, and on peripheral blood smear examination we can see numerous fragmented RBCs, broken RBCs. So this was a case of hemolytic anemia. And now this is another example where we saw similar pattern, though the platelet count was 2.27 lakhs. So here I would like to stress upon the fact that though the platelet count is normal, the platelet histogram is definitely giving us a clue that there is something abnormal that warrants us for a slide review. And here this abnormal histogram warranted a slide review, and on slide examination we saw numerous fragmented RBCs, and that was again consistent with intravascular hemolysis, and the reticulocyte count was also high, 8.8% in this particular case. So now the other reason that the other usefulness of this analyzer was seen in a hemolyzed sample where platelet histogram showed an elevated tail, and we can see an obviously abnormal RBC histogram as well, where the increased upper discriminator of platelet histogram is seen and abnormal lower discriminator of RBC histogram is also seen. And here we can make out that RBC histogram is not starting from the baseline and platelet histogram is not touching the baseline. And this particular sample on examination showed all the RBCs which were lysed. Going back to the history, this patient had transported the sample in heat on a day of on the afternoon of one day where there was significant higher ambient temperature, and he had transported it where there was hemolysis of the sample, and all these hemolyzed RBCs were counted as platelets which had given a platelet count which was spurious of 9 lakhs per microliter. So this was a very useful indicator which was actually identified even before the smear examination was done for the sample. And now the sensitivity of platelet histogram in cases of abnormality of upper discriminator due to red cell fragments, microspirocytes, that is microcytic hypochromic cells or nucleated RBCs, was 73.3% in case of a study by Prabhat et al. So this is in support to our study where we have diagnosed all these causes for this abnormality of upper discriminator, where we have seen the red cell fragments, smaller RBCs, microcytic hypochromic RBCs, and even the hemolyzed sample which was diagnosed based on this. So now to conclude, histograms generated by the automated hematology analyzers are useful tools of diagnostic significance. They allow the pathologist for slide review, especially in centers with higher sample load. EDTA-induced pseudothrombocytopenia can be reliably diagnosed by the flags and histogram pattern of multiple peaks. So now the histograms can display wide variety of platelet data pertaining to their number, anisocytosis, spurious low or high values. The platelet histograms are very useful in detecting the associated abnormalities of RBCs such as microcytosis and hemolysis apart from the platelet parameters. So from our study, we would like to also conclude that optical fluorescence platelet counting on reticulocyte channel is an alternative method to count the platelets whenever the facility is available in the analyzer. The study endorses the utility of platelet histograms, which was so far underrated as a diagnostic tool, and we also recommend their inclusion in the slide review criteria. So hereby, I would like to thank the organizers and conclude with the saying that the more we analyze, the more we realize the utility of analyzers, and there are a lot more parameters to be still explored in the automated analyzers. I would like to thank the professor and head of the Department of Pathology, Dr. Vijaya B. of our college, JSS Medical College. It is a constituent college of JSS Academy of Higher Education and Research situated in Mysuru. And I extend my thanks to the principal of our medical college who has offered us such wonderful instruments for us to work with. And also hereby, I would like to thank Mr. Biju Radhakrishnan, who is the application manager of Mindray, who is always at our service to clarify all our problems and doubts related to our instrument use. Thank you one and all again.
Thank you, Dr. Rajalakshmi, for the lucid presentation. JSS has also been my alma mater. I feel very proud to chair a session by a person who is in JSS, and it is a very good presentation where you very clearly divided your topic into three different portions. One was the platelet histograms and the correlation with the different morphologies, then spurious thrombocytopenias, and also the correlation of the elevated tail with the different RBC fragmentation syndromes and hemolysis and all those things. Those are very well brought out. It was a very excellent presentation. Now the floor is open for questions if there are any. I don't see any questions in the chat box. Shama, do you have any questions with you?
No questions yet, ma'am, in the chat box. So if you have any queries, you can ask.
I just wanted to ask you, what was the clinical significance of those undulating downward curves which you saw with any morphological correlations which you have done apart from platelet anisocytosis? Did you happen to see anything else in those histograms?
Madam, actually, I would like to first of all thank you for your appreciation towards our study, and we have actually heard you before in NABL assessment also, so it was wonderful, and now it's really nice that you're chairing my session. And I would like to answer this question, Madam. Actually, the main purpose of the study was, so far all RBC histograms have been studied in so much detail that after we received these 6-part analyzers, as you've seen in our laboratory, I had some interest towards how do these histograms will be of any use. So in this mild thrombocytopenia category, this undulated curve, which was a little downward curve, apart from the downward curve where there was anisocytosis, in mild thrombocytopenia category, that is more than 1 lakh, there was no much significance, madam. But less than 1 lakh, I could make out there was much of overlap with these larger platelets, giant platelets, smaller RBCs, fragmented RBCs. So these were definite clues. So that I felt with this pattern of histogram, wherever there is serration, this could be a slide review criteria. So we can include these patterns also with slide review criteria, even when the other parameters are indicative. So correlating both RBC curve, histogram, and platelet curve, definitely we can come to a conclusion even before the slide is prepared. As I said in hemolysis case, that was a very known case, madam, for us. It was a technician's daughter. So we knew she was quite well. Looking at the platelet count of 9 lakhs, suddenly I felt, oh, this must be something spurious. So that way I felt these patterns are definitely useful, madam.
Yeah, definitely they are very useful, especially in peripheral centers where you don't have pathologists round the clock. If our technicians can recognize this and then give at least some immediate relief to the patients, that will be very helpful. And I think this platelet histogram need more research, and people should utilize it more often.
Yes.
Thank you very much for your very nice talk. Thanks.
Thank you, madam.
Thank you, Dr. Rajalakshmi. And shall I move ahead with the next speaker introduction, ma'am?
Yes, Shama, you can move ahead. Yeah, our next speaker is Dr. Preeti Chavan. I hope I pronounced your name correctly. She's a lab manager at Actrec, Tata Memorial Hospital, Navi Mumbai, India. Her international experience includes various programs, contributions, and participation in different countries for diverse field of study. Her research interests reflect her wide range of publications in various national and international journals. Her expertise is in the field of internal medicine and biology. Over to you, Dr. Preeti. The stage is yours now. She will be speaking on, I think, correlation of Advia and Umizan 2500. Dr. Preeti, you can start your presentation now.
Good evening, everyone. So today I am presenting a study that is comparison of select platelet parameters between Advia 2120I and Umizan H2500 hematology analyzers. A brief background. We all know that thrombocytopenia is a frequent complication of cancer and its treatment. So in a setting like ours, platelet counts, especially below 50 into 10 to the power of 3 per microliter, become very crucial as cutoffs for prophylactic platelet transfusion for majority of our BMT as well as medical oncology patients lie in that range. So for an asymptomatic patient, it could be less than 10 into 10 to the symptomatic patient with fever, it could be less than 20 into 10 to the power of 3 per microliter. And for a bleeding patient, it could be less than 50 into 10 to the power of 3 per microliter. So that range of platelet counts, especially below 50 into 10 to the power of 3 per microliter, is very crucial and it is necessary for good patient management. It is also important in that perspective that the platelet counts that we receive are reproducible as well as comparable. But as we all know, a single sample which is run on different analyzers will give you variable results, and it can be attributed to the various methods used in different analyzers. In automated analyzers, the different methods currently, as of now, used for analysis include impedance with curve fitting, which remains the commonest technology used for platelet counts in hematology analyzer, as well as it remains the industry standard. In addition, there are optical methods which include flow cytometry based on platelet scatter, diffractive index value, or fluorescence dye staining. However, the gold standard remains the ICSH methodology. So here RBC to platelet ratio is performed using CD41 FITC, CD61 FITC antibodies and calculating the RBC to platelet ratio based on cluster resolution of platelets and RBCs evident in fluorescence versus the forward scatter. On the same background, at Tata Memorial Hospital, Sehgal et al. Had conducted a study in the year 2009-10 in samples with platelet count of less than 50 into 10 to the power of 3 per microliter, where platelet counts between cell line sapphire by Abbott Diagnosis, LH750 by Beckmann Coulter, Rna immunoplatelet method by Rna Matrix were compared to the international flow cytometry reference method, which was used as the standard method. And the key finding from this study was that impedance platelet counts with curve fitting from LH750 were found to be more accurate than optical methods with a bias of 0.111 into 10 to the power of 3 per microliter. In this background, currently we are using Advia 2120I as our laboratory analyzer in our laboratory, which is our primary analyzer. However, Medical kept their Umizan H2500 analyzer for evaluation in our laboratory. And we did this comparison study between the platelet parameters, that is platelet count, which is very important for our setting, and MPV between these two hematology analyzers. So in brief, materials and method. What we did was we compared around 850 randomly selected blood samples which were collected in K2-EDTA anticoagulant tubes of cancer patients taking treatment in our center as well as staff of the hospital on both the analyzers simultaneously. The platelet counts range from 6 to 1600 into 10 to the power of 3 per microliter, and the values obtained for platelet parameters are studied for correlation and bias. Advia 2120I was used as the standard. Now, a little brief about the principles of the two analyzer. The principle of Advia 2120I It includes the integrated analysis, that is the two-dimensional platelet analysis called as 2D platelet method, and is the integrated analysis of red blood cell and platelet measurement. So what it does is the low angle, high gain, high gain light scatter signals for each cell are transformed into volume and refractive index values. And on the scatterogram, on the x-axis is the high angle, high gain light scatter, and on the y-axis is the low angle, high gain light scatter. That is, on x-axis will be the refractive index and y-axis will be the cell volume. And it displays the cells with volumes of 0 to 30 femtoliters. For cells with volumes greater than 30 femtoliter, it is done using the Rbc scatter cytogram. Large platelets are identified on the platelet and Rbc scatter cytograms based on the refractive index values and a volume of more than 20 and less than 50 femtoliter. So on this integrated analysis, you can see this is where the platelets will be counted. This is where the large platelets will be counted, and this is where the RBCs will be counted. Now these are the platelet and RBC cytograms. So in the platelet cytogram, this is where the platelets will be counted. This is where the large platelets, and this is where the RBC will be counted. And on the RBC scatterogram, this is where the platelets will be counted. For MPV, the 2D platelet volume histogram, it is calculated by distribution of cells by volume, and the histogram has a range of 0 to 60 femtoliter. MPV is the mean of this 2D platelet volume histogram. Now the principle of Fluorescence H2500, it uses two technologies. One is impedance to measure the volume and extension light to measure refractive index and also improves the specificity. So when a cell crosses the optical beam, the optical detector is designated to provide a sensitive response which includes scattering and absorption, and that is how optical extinction is calculated. So on the x-axis will be the volume by impedance, and on the y-axis will be the optical extension, and that is how the platelets and RBCs will be calculated. So this is the scatterogram where platelets are counted below this refraction index of 1.39, above which are the RBCs. This is the impedance histogram for volume, and MPV is measured by the impedance. The linearity of the analyzer, both the analyzers stated by their respective companies for platelets are as follows. For Advia 2120I, it is 0 to 3500 into 10 raised to the power of 3 per microliter. For Humizan, there are two linearities. For hemoglobin more than 2 gram per dl, it is 0 to 2500 into 10 raised to the power of 3 per microliter. And hemoglobin less than 2 gram per dl, it is 0 to 5000 into 10 raised to the power of 3 per microliter. Now the results that we obtained, when we correlated the platelet counts for all the samples between these two analyzers, the coefficient of correlation was 0.959 and the mean bias for the bias plot was 9.652. For the platelets counts showing, which were less than 50 into 10 to the power of 3 per microliter, which is important for our setting, the coefficient of correlation was 0.438 and the mean bias was 0.889. For MPV, the coefficient of correlation was 0.570 and the mean bias was 0.449. Now, these findings from our study, when we compared them with the published literature, the findings were as follows. There is a study by Bruegel et al. Where they compared around 290 samples, which were simultaneously run on 5 different analyzers, that is Sapphire, DXH 800, Advia 2120I, XC5000 and XN2000. And regression was done to the median of all the readings from all 5 analyzers. Similarly, difference was also calculated to the median. The findings for Advia 2120I in this study were the coefficient of correlation was 0.95 and the mean bias was 10.5. As you can see, it compares well with the findings of our study, which were 0.959 for coefficient of correlation and 9.652 for mean bias. There were some studies where Humizan H2500 was compared with different analyzers. A study conducted by Horriba Medical International themselves compared XC2100, XN10 and ADVIA 2120 with Umisen H2500, and the coefficient of correlation for ADVIA 2120 was 0.98. Malaika et al. Compared XN 2000 with Umisen H2500 and the coefficient was 0.993. Horiba Medical International themselves correlated ADVIA 2120 in another study with Umisen H2500 and the coefficient of correlation was 0.976, which correlates well with the findings of our study. For MPV, there were few studies. One was by Malaika et al. Where XN 2000 compared to Umisen H2500 gave a coefficient of correlation of 0.929. While Horiba Medical International, when compared ADVIA 2120 with Umisen H2500, the coefficient of correlation was 0.767, and the same for our study was 0.570. So, in conclusion, we can say our study showed good correlation between the two analyzers for platelet counts and was comparable to other studies. The mean bias observed to be 9.652 and is comparable to that seen in the study by Bruegel et al., which was 10.5. For samples with platelet count of less than 50 into 10 raised to the power of 3 per microliter, there was lower correlation as expected, as there is always higher variability in that range of platelet counts. However, mean bias, if you see, was observed to be minimal at 0.889 between the two analyzers. There was lower correlation for the MPV value between the two analyzers, and the mean bias was minimal at 0.449. So we can say the two analyzers compare well for the platelet count and show minimum bias for platelet values less than 50 into 10 raised to the power of 3 per microliter, which is important for the decision making for prophylactic platelet transfusion management. These are the references which were used and acknowledgements. Thank you.
Thank you, Dr. Chavan, for the very well-articulated presentation. You have compared ADVIA 2120 with Umisen H2500. That was a very nice presentation. Is there any questions which are there in the chat box? I don't see any questions. I have a question. You have mentioned that there was a variation and little less correlation in the thrombocytopenia. Have you classified them in different levels, like thrombocytopenia, normal and abnormal, or have you categorized, like the previous study, they had categorized thrombocytopenia itself into 3 categories: less than 50,000, 50,000 to 1 lakh, and 1 lakh to 1.5 lakhs. So have you categorized them like this, or is it in general you have done the correlation for all types of all platelet counts?
No, ma'am, we have categorized. The value of less than 50 is very important for us because of the prophylactic platelet transfusion threshold. So I have highlighted it in the current study, but we have also compared at different cutoffs. It's just that in this study, over here, I have not presented that data, but we have done that.
Okay.
And for what I can say is for less than 1 lakh also, it is correlating well. The correlation was not seen only for the less than 50 population. Whenever the counts were higher, less than 1 lakh, less than 1.5, the correlation was there.
Okay. Thank you, Dr. Chavan.
Thank you, ma'am.
Thank you, Dr. Preeti Chavan, and thank you, Dr. Shabnam Ruhi. May I call on Dr. Handu, because this was the last lecture for the day. So may I call upon Dr. Handu to thank everyone and also give his guidance again, like for a mega event for the next year. Thank you.
Thank you, Shama, and that indeed was a very interesting presentation, especially for the consideration that we looked at thrombocytopenia at different levels. And of course, as Madam told us, that they have done thrombocytopenia, evaluation even at the lower levels. Thank you, Dr. Shabnam, and thank you everyone for going through this presentation, the entire session. It indeed was a pleasure to have all of you on board. And I think with these few words, we now come to the close of this meeting. And we look forward to having this meeting again next year, hopefully. And hopefully in physical presence, in person, rather than, this video types and virtual ones. Thank you, everyone. And thank you, Shama, for all the effort that you've taken.
So may I interrupt you a bit? Sorry.
Yeah, sure.
There are quiz winners to be announced. So I will display them on my screen. Yeah.
Go ahead, please.
So we have 3 winners for the quiz. So I would like you to announce the winners.
Wonderful. So the first winner of the quiz is Dr. Ritesh Kharache. He's a pathologist from Seven Hills Hospital, Mumbai. Congratulations, Dr. Ritesh. So the second winner of the quiz is Dr. Gayatri. She is a postdoctoral fellow in Hematology Laboratory at Christian Medical College, Vellore. Congratulations, Gayatri. The third winner is Dr. Deepak Daswani. He is the director of and consultant pathologist at Daswani Pathology Laboratory, Mumbai. Congratulations, Dr. Deepak. Yeah,
thank you, sir.
Fantastic. Over to you, Shama.
I take this opportunity to thank, on behalf of Mindray, I would extend sincere gratitude to all the esteemed speakers who have enlightened us with their extensive knowledge and experience, and also the honorable chairpersons who have guided us speakers throughout the 2 days with their vast experience over the years. I also thank the patient listening and comprehension of the audience, without whom this mega event was not possible. I thank Dr. Anil Handu, who is our mentor and guru, to guide us through this journey and make this event a mega success. Last but not the least, I thank my Mindray team, who has been extensively working for not only these 2 days, but the past 15-20 days to make this event a success, toiling a lot to get the speakers on board, to get the chairpersons on board. So a heartfelt thanks to my team, Mindray. And I think, sir, we close the session for the day.
Yes, we do. Thank you.
Thank you, everyone. Thank you.